Hey, how are you, Dennis?
I'm very well, thank you. Oh no,
Who's
who has that music?
that? Okay. Dennis, just to check, would you say anything in the beginning, like introducing yourself and this event, or what?
Okay, I'll say a very quick few words and then hand over to you.
I appreciate it. Yeah.
Okay, yeah.
Is Asia the first region to go? Or?
Yep, it is. Asia is the first to go today.
Okay. Hi, Celia.
Hello, Rod. Hello,
Hi,
Celia.
Andrian.
Hi, everybody.
Hello, Celia. So sorry, Celia. I didn't send you a photo of mine.
No worries, Andrea. We can make another one during the day. I will take a picture of you.
Is our AV group just in the background, or are they here somewhere?
They are in this room, yeah. It's Toti is with us today, and he's in the background, yeah. He's in the room today.
Okay.
Hi, Toti.
Hi, Toti. Great. Wow.
Din. Bukan. Hah? Bukan. Nak ni nak.
Okay.
So, Dennis, we don't have to record, no? That the co-host won't have to record. Toti is going to do it.
Well, yeah, Toti will take care of all of the things that need to go on to the other. Yeah.
All right. Okay. I could see my friends. I'll help you in renaming. Jirapon is Thailand. Okay. Mr. Wow Ken. Hong Kong. All right. How are you, Dr. Rasak? Long time no see. You're in mute.
You can hear me now?
Yes.
Okay. Good to see
So
you.
are you a Yeah. Are you a frontliner, Dr. Razak?
Uh, Not exactly frontliners. I don't treat COVID patients.
Oh, what if a nurse is in a hurry and falls down the stairs? You have to check the bones, right? Okay, who else is here? Oh, I could see Virat. Virat, you're there? And Sherlyn.
Hi Rod, I'm here.
Hi Rod, hi everyone.
Should
Sherlyn
I
from Malaysia.
rename you? Yeah.
Hello, Dr. Raja.
Should I rename you
How are you?
both?
To happen online for CML Advocates Network. My name is Dennis Costello. I don't know many of you, so I am the executive director of the network. I joined last September actually, and I'm joined here also by my colleague Celia Marin, who's part of the team that will be helping us to animate the day. It's a very special day for us as a community. It's our day where we take time to look for recognition for CML, but also to get together as a community. This is the first of many events that will happen around the world today because of the COVID situation. Many groups can't do the kinds of events that they would normally do face to face. So we're taking an opportunity to go all over the world, starting in Asia Pacific, then going to Middle East, Africa, Eastern and Central Europe, Western Europe, Latin America, and North America, all throughout the course of today. Each of these meetings will be chaired by members of the network and essentially members of our steering committee. And I'm very, very pleased and honored to be able to share this meeting today with my good friend and colleague, Rod Padua. So I'll hand over to you, Rod, to be able to take it from here. Thank you.
Thank you, Dennis. So, good afternoon to everyone. And welcome to a very exciting World CML Day. It's a Tuesday, September 22. As you know, World CML Day, as the name suggests, is being recognized globally, including, of course, Asia Pacific. It has been a long, stressful 20 years of our CML journey, but life's been good. We are all here living our lives as normal as possible. I am Rod Padua, your representative to the steering committee of the CML Advocates Network, and I will be moderating today's session. So to our speakers, please introduce yourself and your group. Say hi, hello to your members joining us through Zoom and the other live platforms, and then respond to the following questions. Number one, during this pandemic, what are your experiences or challenges or fears as a CML patient? And second, how can the CML Advocates Network assist your group in the future? All right. So maybe I can start to break the ice. I am Rod Padua again. I am the president of Touch by Max Philippines. Kumusta na sa mga CML patients sa Pilipinas? Sana okay lang tayo dyan. Follow the health protocols. Okay? Huwag nang lumabas ng bahay. Perhaps it is safe to say that the pandemic has altered the way of life for all of us, most especially the patients. While a small number of CML patients in the Philippines had COVID-19, for most of the patients, it is the mental stress that is quite unbearable at times. What if we get the virus? What should we do? If normal, healthy people can die, are CML patients more susceptible? Aside from these fears, the financial burden of buying the medicine got a lot worse in the Philippines. What little government assistance the patients were getting previously were all diverted to the pandemic efforts. So now, either some of our patients have stopped taking their drugs totally or are very much below dosage levels. I received late reports that many have died already. That's the very sad part. How can the network help us? You know, fundraising has always been a weakness for us. Not to say that Touch by Max has not been raising funds previously. We did many times. But the results are not to the level which can bring tangible benefits to the patients insofar as buying TKIs are concerned. And since trainings and seminars nowadays are through virtual, through webinars, my wish is for the network to assist us with skills training in fundraising. That is the first step. Then maybe later on, with these funds, we can buy some TKIs on our own and to help those patients. And I hope it's not going to be too late. Okay, so that's for the Philippines. Who would want to go next? I see Ken of Hong Kong. Ken, how are you, my friend? How is CML life in Hong Kong? You are in mute, Ken.
Hello, Rod.
Yes.
Can you hear me now?
Yes.
Okay.
Clear.
Okay. I can speak now. Hello, everyone. I'm sorry I have to say good afternoon to every one of you because previously my audio has not been properly set up. Right now, I can start now. So good afternoon, everybody, especially to Rod and Dennis to organize such an event. And hello, everybody for the Asia Pacific region. I'm Ken Choi from Hong Kong. I'm a CML survivor. I belong to two Hong Kong cancer organization. First one, Hong Kong Adult Blood Cancer Group, and the second one is the Cancer Patient Alliance. Well, the first topic, major challenges in 2020 or during the time of pandemic and our experience. Well, first of all, we find in Hong Kong the life-threatening coronavirus can be even more fatal than CML. And Hong Kong is completely short in personal protection equipment like the face masks and sanitizers. And very often we have to queue overnight and pay outrageous price, but still cannot get it because they sell out very fast in a matter of minutes because the demand exceeds the supply very, very much. So we asked the farmers and the local charities to donate or subsidize the PPE, namely the face masks and sanitizers. And we collect them and we mail them by post to our patient members. And in case we have some excess left, we also distribute to non-member patients, say at a train station or bus stop. The second experience during pandemic, of course, is caused by the lockdown. All leukemia and CML conference or seminar put on hold. But luckily, we managed to register the virtual conference by EHA, namely the European Hematology Association, and learn a lot from the experts all over the world about the latest treatment options of blood cancers, especially CML. And our big thanks, heartfelt thanks to CML Advocate Network and Jan Gisler, who notified us of such good opportunity. So thanks again to CML, AN, and Jan. And the second topic is, well, chant the slogan, right? Today more than ever, a cure for CML. Well, I think we all agree what CML patients across the world need most today more than ever is universal health coverage, meaning access to life-saving drugs, or better still, a cure. Without financial hardship. Because if we can find a cure, we can get rid of the financial toxicity, meaning the economic pressure, as well as the undesirable side effect. Today, I think many countries have achieved this goal, especially those in Europe. But unfortunately, for some countries, they are still struggling, including Hong Kong. So back in Hong Kong, our government is unwilling to invest in healthcare infrastructure. That's why we don't have public health insurance, we don't have reimbursement program, and we don't have cancer budget. I happen to know Philippines is quite advanced because Philippines have cancer legislation, right, Rod? And I think Malaysia is doing similar thing. So shame to Hong Kong. Therefore, and also the government is unwilling to fund the expensive cancer drug, including the CML TKI. So patients have to pay themselves out of their own pocket. And what we expect the CML Advocate Network can help us. Therefore, I would like to call upon the international community, especially the CML Advocate Network and members of the CML Horizon Network, to help Hong Kong remove the high-income country stigma, get rid of it, so that the farmers will become willing to discount the expensive drug price for Hong Kong patients, and so that also international charities will be more willing to come to Hong Kong to support our patient advocacy effort. And having said that, of course, I totally agree with Rod that the finance is the blood and backbone for all patient organization. And I agree with Rod that we want to learn from the best practice or what others APEC countries are doing in terms of fundraising or in terms of building key capacity. For example, to be effective in public speaking, which would be very helpful to our patient advocacy effort. That is from Hong Kong. Thank you.
Thank you, Ken, so much for being honest. Something I cannot understand, but I did when you explained it many years ago. How come a rich country like Hong Kong, wouldn't get much assistance from the government? But you said that they're expecting us because we have money to pay for our own medicine. So that's how I understand you. So thank you so much for the comments. My only question, Ken, and probably
Yes.
the others too, with the political situation there, is there any effect on the CML patients with the
Certainly,
politics
of
there?
course. You mean the effect of coronavirus on CML patients?
No, the China effect.
Oh, the China effect. Oh, yeah. Thank you for asking this. Many of our advocacy effort, patient advocacy effort, has to do with the government, the administration. And because of the China effect, they imposed the National Security Act, which can take away our freedom of speech and freedom of expression. Therefore, we cannot criticize the government for not funding the drug, for example, which may be walking on the fine line. They can say it is anti-government. It can pose a potential threat to the national security, so to speak. But of course, we all know that this is rubbish. So in other words, we have to be very careful with our advocacy effort, especially our public speech.
Wow, Dennis, I think we have our job cut out for Hong Kong on how to strategize, without, getting into politics and angering which side. So again, thank you, Ken. Thank you, and see you soon.
Thank you. Thank you.
Next is from Indonesia. We have Andrian, the largest country in Southeast Asia.
Okay, thank you, Rod. Hello, everyone. I'm not alone here. There are our member also from Indonesia. There are Linda Sitorus, Susina, Sukardi, and then Pinky. We thank you very much for your come to this event. Hello, everyone. I am Andrian. I am Andrian Rahmatsa. I'm from Indonesia CML and GIST community. I was diagnosed CML since January 2011 and started using Imagine 400 milligram since February 22nd, 2011 until now. I would like to say selamat memperingati Hari Leukemia Granulositik Kronik Sedunia 2020. So that's in Indonesia, in Bahasa. Hari ini bersama-sama lebih dari sebelumnya untuk hidup tanpa leukemia granulositik kronik. Today, together more than ever for a life without CML. For me, commemoration of World CML Day is not to celebrate the disease, right? But rather to remind everyone of the importance of rare hematological disease awareness, which represent 10 to 15% of all leukemia in adults. To raise awareness of the needs of patients living with CML, to remind everyone the importance of raising awareness of the signs and symptoms of leukemia, encouraging friends who have just been diagnosed to be examined by health professionals, and hopefully this will help reduce the number of preventable leukemia deaths around the world, right? And bring them better outcome. This year is a tough time for everyone in the world, I think. We all face a pandemic around the world, of course, including me and our friends in Indonesia. But this pandemic makes us all work more creatively, moving our conventional activities to digital-based activities, just like now. So, and of course, this is proof that we will not be discouraged to continue working and provide the widest possible benefit to the community. This pandemic not only forces us as CML patients to adapt to new habits, but it could be that everyone is doing the same thing, right? So our challenge as CML patient is how we can remain consistent and committed to maintaining our health. And of course, being part of the solution to prevent the spread of COVID-19. Well, we can still work in this new era, or in bahasa beradaptasi dengan kebiasaan baru. So how we have to commit to stay at home, to keep productive, to keep our health, and for sure to be very careful when going to access our medicine at the hospital, especially in Indonesia for those who should access their medicine in the hospital that handles COVID-19 patient every month. So as you know that in Indonesia, every day is rising. The new cases is very rising every day. So because of that, there's no face-to-face meeting in large number again. Now everything has to be done virtually, just like now. And this is a challenge in itself to adapt to existing technology. So because not everyone aware of technology. So hopefully this pandemic will pass soon. Treatment and even vaccine can be used as another form of prevention beside the existing preventive protocol, which are expected to become new habits, just like Ken said, hand sanitizer and so on and so on. So today is World CML Day. Today, there are only two TKIs in Indonesia, which are imatinib and nilotinib. We are very, very grateful that our medicine are already covered by national health insurance. But we all know that our system isn't perfect yet. But it's not about waiting for this. It's not about waiting for the system to be perfect, right? Because there is no perfect things in the world. So it is about life. So our patients need another TKI besides imatinib and nilotinib. I always remember what Ian said. We see people dying of CML, even though it is a well understood, biological well understood, a well treatable disease with 5 different therapies on the market. But if we cannot access the drugs, if we cannot access testing, people are still dying from the disease. And that's happened in Indonesia today. And access is a big issue. It's probably the biggest barrier that we have. Some lucky patient can get access to other TKI from overseas. But how many patients are there? How about others who are not as lucky as others? Patients who have mutation, who have resistance, who need so badly these TKIs, who waiting for a miracle to come, who needs a life, who want to see their children grow up with their parents completely, who wants their parents not to worry about them, and so on. So together, more than ever, we hope that CML community in this world can work together with us, that how we can get access to other TKI beside imatinib and nilotinib, how we can encourage our physician to get access to other TKIs, the compassionate drug, and even clinical trial in Indonesia. How we can encourage our health institution, government, and public society to understand what we need. We need our medicine. We need diagnostic and monitoring facilities that can afford, which are covered by national health insurance. So may God always give us health, strength, bless our journey in achieving a cure for a life without CML. So keep up the spirit and do not give up. Thank you, Rod.
Thank you, Andrian. Just a short question. I know you have many, many patients. Now, during the pandemic, we know in order to get our supply of TKIs, whether it's in compassionate use or through the MAX, we have to show that the TKI is working. And the way to do that is to show our latest PCR test. Now, this is very difficult in times of the pandemic because we have to go outside, wait in line in the laboratories, together with some patients that might probably be COVID. So how did you do it?
Yeah, I think this pandemics, some cities had some cities get a lockdown, or what we call in Indonesia is PSBB, you know. Yeah, thanks God, grateful that we still can go to lab facility to get monitoring, but you know. There is a very limited facilities to get monitoring. Not only monitoring, but also diagnostics. In some hospitals, there are still a lot of patients who cannot access the diagnostic facilities, so they can get their TKI. They still take hydroxyurea because they cannot go to the lab to get their diagnostic, because it's not about the facility, it's not about what COVID-19, I think. So because we have protocols, We have protocols. Then we aware about that. We every day we socialize. We get educated to them to always to remember that we have protocols. But the problem is the budget. You know, it's so very expensive. So I think Rod, for us in Indonesia, not only about it's not about COVID only, but it's about money. We cannot afford these facilities because very limited. Because we have to go to private lab, then in hospital.
Wow. Well, what struck me most, Dennis and Celia, is that some of their patients are still taking hydroxyurea.
Exactly.
Can you believe that? So anyway, thank you, Andrian, for sharing
You're
us
welcome,
your thoughts.
Rod.
And
You're
thank you
welcome.
to your team in here at Zoom. Next, we
Thank
have
you.
Pon of Thailand.
Hi, everyone can hear me?
Yes.
Yeah.
Yes.
Okay. So my name is Jirapon Chaimongkon from Thailand. I represent Thai CML working group, Thai CML patient group. So during the pandemic, what we are having the problem is we having a problem to go to the hospital. Every city has been locked down in Thailand. So most of the facility is in Bangkok. So we have separate the patient into two groups. The one that live in Bangkok, we ask them to come in the hospital in the person in order to get the medicine, because you have to show your face and the ID card to get the medicine. So we ask them to come to the hospital. But my doctor, she is like 70 years old. It's not safe for her to come to the hospital as well. So we are putting the telephone. So we are using the live stream video conference with the doctor, but with the help of the nurse, patients still come to the hospital and can be able to access and get the medicine back, okay? And for those who cannot come to Bangkok and have a friend in Bangkok, we ask them to send the ID card to a friend who can then come to the hospital to pick up the medicine for them. So that in that solution, we can help more than 250 patients with the solution, okay? Then the second question is that how CML patients can help each other on the network. In Thailand, we have 3 of the TKI is available, which is imatinib, nilotinib, and dasatinib. It's no problem for us that we can access 3 of them. But because of the imatinib has been the license expired, and there are many generic coming to Thailand. We have at least like 4 or 5 different brands that come in. The problem is that one hospital give this medicine TKI, and then the next month they run out of the supply. They give another brand, and then we cannot figure out that if person have the side effect or the bad result, it came from that they are stopping the original one, or it came from which generic that caused that problem. You know, we cannot figure it out because they keep changing the brand all the time. And this is one of the big problems. I have seen that many CML patients fail the TKI and become mutation with T315I, which only need a ponatinib. But the ponatinib in Thailand is not available. So what the CML network can help with a ponatinib or any any TKI that in the future, example ABL001 or whatever it is. So I want to be able to fly some of the patient overseas, somewhere that they have a test lab, or maybe I can fly to any country that having the trial on the new drugs, and one person can help on accommodation, another one can help on transportation to pick up and send the people to the clinical trial, and maybe other can help with the raising the fund. So in this way, from my own experience, I live in Thailand, but I fly to Singapore to have my medicine 5 years before I have the medicine in Thailand. So that means for me, I graduate overseas. I be able to fly overseas and do everything by myself. But for the other people, I don't want that we are leaving some CML patient left behind or die without the hope, because the ponatinib is actually work for the mutation. And I don't want to see anybody that I know that die without the hope and then waiting for a ponatinib to come to Thailand, which is impossible for us now. That's it for me.
Okay, thank you, Pon. I'll try to break what you said in two parts. The first one are the good news. You're the first country that offered solutions already during the pandemic. What you did, one was the video with the doctor and the patient. The second is those from Bangkok helping others who come from far away. And you're lucky because you have so many TKIs. Now, the bad news, as we hear it, and maybe this is where the network can help, Dennis, is, and rest assured for everybody, I have been voicing out our concerns to those that are doing clinical trials in Europe and in the Americas, that go to Asia. There are so many patients there that could be under clinical trials. So we hear you, Pon, in case the disease goes beyond the T315I, and there are some innovative drugs for clinical trials. We hear you, and we are with you, and we'll try to make Asia more immersed in those clinical trials. So thank you, Pon, and thank you to the other Thais in this call, Pasusant and all the others.
Okay.
So next, may we have Dr. Razak, because he's going to have an operation and he has requested he be next. Yes, Dr. Razak.
Okay. Can you hear me now?
Yes.
Okay.
Yes.
Not to say that I am going to have an operation. I already blocked my clinic until 3 p.m. But anyway, hi everybody. Welcome to this sessions. It's great to meet everyone, even though I have not met all of you on this platform. And happy CML Day. I'm Dr. Abdul Razak, a practicing surgeon as well as CML patients and leader for Malaysian CML support group. Okay, coming to the questions that each leaders need to share or give their opinions. For the first one, of course, I think it's almost universal that all patients, whether they are CML patients or they are normal patients or even normal populations, we have fear of our safety and risk of contracting COVID, especially us as CML patients. These are some sharings from our Malaysian patients. Secondly, so the first one is fear of safety and risk of contracting COVID as CML patients. Secondly is we are, especially CML patients, because as we know, we are at a higher risk of contracting COVID-19. So we are sort of like having a difficulty in accessing the right and credible informations pertaining to all these safety and risk. Patient has limited access due to delayed or extended follow-ups, not to mention less contact with the treating doctors or physicians. And as we know, before this, we used to have our usual educational workshops through a physical or face-to-face, but now we can't do that anymore due to the restriction of meetings in large numbers of people. And I think the other one is some patients, especially from outstations, they have to travel, and because of the travel restrictions from the government, there is sometimes ago that some patient has problems to get to the hospitals to get treatment. So, but we learned something, however. So in mitigating all these challenges and gaps, Malaysian CML community, our society, our support group, we have shown some increase in relationships and our communications among patients through social media discussions, WhatsApp groups. We talk a lot and we share, some tips while going through this trial time. We have changed our educational sessions from physical to online platforms. And with this, almost everybody or anybody with internet connection would be able to join from anywhere. We must thank our healthcare providers because they have strengthened the delivery of healthcare to us to minimize the risk of patients having compromised care, especially to reschedule the appointments, and among others, the healthcare providers will, do a delivery of medication through postage services, so that patients has, reduced trips to hospitals. And thanks to our government too, to relevant authority, especially our Ministry of Health and Ministry of Internal Affairs, who has create good standard operating procedures, strengthening our universal precautions, and keep reminding us to maintain our good practice every day. And finally, how can the CML network help groups in the futures? I would be more grateful if CML Advocacy Network could produce more conclusion from any research from any countries and pertaining to CML patients who are affected with pandemic, so that we can learn, especially from the countries that have been mostly affected, or who has more CML patients have been affected by COVID, and from there, if the network could share guidelines, obviously it needs to be a patients-friendly guidelines, so that we can something that we can share amongst CML patients. And lastly, community in the research pertaining to treatment and especially in the upcoming vaccination trials to come. Yeah, so I think that's mainly our sharings from the Malaysian CML patients. We do not have a lot of problems in accessing the medications. Even without COVID, we have a small problems of getting the medication but we guess that it's only like a time problem, which is going to be resolved, very soon. So yeah, Rod, I think that's all about Malaysians' experience.
Yeah, thank you, Dr. Razak. I was about to say that, Dennis, that Malaysia is the envy of most of the countries in Asia. They don't have any problems in access. They have the TKIs, most are in Malaysia. And as Dr. Razak is saying now, even during the pandemic, and that is my question to you, Dr. Razak, who pays, you said the drugs are being delivered.
Sorry, my line is breaking. Can you repeat?
You said earlier that the drugs are being delivered to the houses of the patients. Who pays for the courier?
Oh, the patients themselves.
Okay. But do they have to show proof that they have a PCR test that is the drug is working, or no? Just deliver the drugs every time.
Okay. Fortunately, the restriction is only involved for a few months, so that does not affect their monitoring time. So right now, everything has come back to almost normal. So most patients will come back to the hospitals and have their treatment and monitoring and everything.
Thank you. Again, just to set an example, bone marrow transplant in the Philippines is $100,000 US. In Malaysia, it's $200, I think.
So if it's done in the private, if it's done in the public setting, it
thank you,
still costs
Dr. Razak.
$100 US if it's done in the private setting.
All
But
right.
most patients who eligible to have transplant, they have access to, it's just a waiting time, because the list is getting longer. But fortunately nowadays, bone marrow transplant for CML patient is getting less, common.
So thank you, Zach.
Welcome.
On my breaking at your side, and I miss you, my friend. We missed you for many years now. Thank you. Yeah. Okay, we have next online. We have Shova from Nepal.
Namaste. Hearing me? Hello.
Shova.
Yeah.
Can you hear me? Can you hear me?
Yeah.
Yes.
Yes. Namaste.
Yes.
This is Shova from Nepal. I was diagnosed with leukemia 19 years back, and I'm doing well till now. I'm here representing Blood Cancer Society Nepal. But before saying some other things, what we are supposed to say, I would like to thank you all for this opportunity for letting me in to speak some few words of mine. Well, we all know how frightening this word cancer is and how expensive the medicine we consume. We are lucky that we are getting all TKIs in Nepal, but the lockdown due to the COVID has badly affected on the supply of medicine. Even the price of generic is not affordable to lower income country like us, which has created so many questions among the patients. Like, how longer do we have to wait for a medicine? What is the supply? What if the supply won't get easier as earlier? How to manage the expense if the lockdown keeps on extending? What if we stop the medicine for a time being? Do we have to face fearful death? Yes, these are the questions among the patients. And this has turned the situation unpleasant in previous few months. However, the situation has turned a little ease later on with the help of doctor and the hospital here, as they have made the way out for the access of medicine, and they provide the online service for the OPD. We have been getting the opportunity to take part in the conference every year, which continuously help us to know better about CML and the drugs. Hope this continues with the passing year, and I'm thankful to this CMLN networks who has provided this opportunity. Here in Nepal, all TKIs have been provided and patients are getting benefited too. But there is no lab which performs BCR EBR test and government is not helping either. So if CMLAL network can help in providing the machine with the kits for the max access hospitals here, that would have been more helpful for the patients in the underdeveloped country like us. That's all what I have to say. Thank you.
Yeah, we hear you, Shova. Even before the pandemic, it is our honor to be able, the network's honor to be able to help you by giving your group a grant for the PCR testing of some of the patients. That
Yes,
was
thank
even
you.
before the pandemic. So now,
Yeah, I missed out thanking the community network for the grant we have been granted. But due to pandemic, it is on hold. We could not. Yes, the program is on hold.
okay, so get the picture of why I personally, let's say, fought for Nepal being included in the list of countries to get the grant. If I remember right, I said then, if it's just another, consultancy work, the result of which would be lying in somebody else's drawer, I would rather that we help Nepal because it would be for the patients getting their PCR test. So now you could see the hardships that they have going too far just to have that PCR machine. So thank you, Shova, and good luck to you there.
Thank you.
We have from India, Param.
Hey, hi, Rod. Good morning. Good afternoon. Hope you're able to hear me. Hello?
Yes.
Are you able to hear me, Rod?
Yes.
Yes, Param.
Oh, hi, Dennis. Okay, thank you.
Yes,
so
we
it's
can,
Param
we can
here.
hear you.
I represent India and I belong to the south of India, as India itself is a subcontinent. I'm a CML survivor, so diagnosed about 16 years back and was on the first stage TKI treatment, but unfortunately fell into the category of resistance and went through a bone marrow transplant. And at the moment, I'm disease-free. And I represent the patient organization, which is the supporting arm of the Max Foundation India operations, which is called the Friends of Max. So we represent the entire CML and the GIST community for this subcontinent, which constitutes about 18,000 patients of CML. Going to the question, on this eve of this World CML Day, I would like to give this message that the CML has brought us together today. And my wish on this day is that, we all should be, raise our patients' voice to lead a healthy life with a cure in the future. And I wish all of you stay safe and stay blessed and be out of the disease sooner. Going to the first question on what Rod has given us to us on the pandemic challenges. The pandemic has actually given this certain word of uncertainty. But when I link CML to the pandemic of COVID has created so much of uncertainty. But from a CML community, there is a lot of certainty. We have imatinib to various TKIs coming year after year. And now, can we get to a certain momentum of getting a cure? So probably that's what, the pandemic has thrown us the light. It's only also every day it's a uncertainty that is the certainty word today in this world. And from an India perspective and from a Max Foundation and a Friends of Max perspective, I'm very, I would like to say that, as a team, the whole supply during the lockdown, we had, 3 or 4 different stages of lockdown. Currently, it's been completely eased out since the last week of March. but I'm very proud to say as a community, all the patients across the various stratums of economy got their medicines on time without any major disruption. How did it happen? One, through a constant engagement with the patient network through our Max Foundation and we as the city chapter leaders. Two, the doctors who treat these patients stepped up from their comfort zones and used all models of the digitization to give the prescriptions and to give the supply conformity and to re-establish the links to make sure the patients get their medicines on time. Third, the distributor, at different parts of the cities and the tier 2, tier 3 cities, they raise their bar without not putting so many conditions. Earlier, many years back, we used to have, you have to give all the 3 empty strips of the carton box to the distributor, then he gives us back another set of tablets. But they eased out lots of conditions, and with a very good systems of a barcode, with the patient ID, and with a prescription from the doctor, a e-copy, a soft copy was more than enough for the distributor to give the medicine either to the patient directly or to the caregiver who represents with these documents. And one of the best example which touched my own heart as a patient advocate was a young boy of 25 years was in this city where I belong to, which is Bangalore, but he belongs to the native state, which is about 400 kilometers, roughly about 300 miles from his hometown, where his doctor resides, where all his patient IDs are there, where every detail of his, and he's here and he's stuck in the lockdown. He just got 15 days of supply. So through Max Foundation, with me, he contacted us and we worked together. We worked with his doctors in his home state, got all the things done on the soft copy. I reached out to the local distributor out here and we facilitated in getting, because the government agency said anything to do with cancer, anything to do with therapies that's chronic ailments, there is no restrictions and you need to show those documents, so they allow you to move around the city. And we were able to get him the medicines on target, and he could stay healthy and continue to have his medicines on time. And that's very, very delighting for me to share on this eve of the CML Day. And I think a couple of more initiatives that the COVID has brought us is through digitalization, how we can continue with it. One of the biggest strengths Friends of Max has is the patient group meetings. And we did 2 major meetings, one in Kolkata and one in Bangalore, where I represent. And we had close to about 200 patients coming online, especially people from different status of the society, logged into the Zoom call, put questions ahead of time, and we had almost for an hour and a half a similar patient-centric engagement workshops that helped us to connect with the patients and continue with the compliance, reminded them to take their medicines on time, and do the test only when it is necessary and as mandated by the doctor, because the doctors had said that for those patients who are not mandated to go to the labs need not go during these pandemic times. And it was a good balance that we created, and the patients and their caregivers were all doing good. And this has now this momentum has picked up, and we have a series of patient-centric meetings. And even today we do have some more coming up, and that's the kind of engagement we continue to do so. And another initiative that we have taken from my Friends of Max is, as we see, India also has its challenges from a payer perspective, from an insurance perspective. So we from Friends of Max reimburse many of the medical tests and the transportation costs to those patients who come from different parts of the country, to make sure that because the huge burden of doing the test takes a toll on their own economy. So we support them through reimbursements. So with all these initiatives, I think we are securing the lives of those CML patients and their caregivers, and putting up the smile and trying to learn, share, and continue to enhance the quality of life of this community in this country, as well as working with the other communities. I think the second question has to see how the global CML network and the regional CML network can help from my perspective and from a patient organization perspective is how much of the doctors from this area, because India is a subcontinent. We have a large pool of patients who are more than 20 years. And when I see some of their own data, when they talk through doing the patient grouping, they all are a very strong candidate for the treatment-free remission. But when we talk to the doctors, few of them are quite educated, few of them are not. So how to bring them to the speed to those doctors who are specialists in treatment-free remission? So how to bring them and how we can enhance the panel of doctors coming into the CML network. And I think if, and also, that will help us, in bringing, a community to help because the treatment-free remission has to run through the doctor. That's A. Second thing is access. And I think for cure, I think this country and for the population here, we have to engage the stakeholders, we have to engage the government officials and the doctors along with the companies to see how we can accelerate the access program. And I think that's the roadmap that I would like to really see from a World CML Day perspective, is to see cure either from a treatment-free remission or through access programs with all the latest TKS coming into this country, thereby enhance the quality of life of our CML patients, of our brothers and sisters from this country. Thank you. Happy World CML Day.
Thank you, Param. I could relate with regard to the what you said about TFR. Also in the Philippines, we are trying to make it a program. It has to be, a partnership between the patient and the physician, and also if there's a society of hematologists that, would endorse the whole program, that would be the best, because there is not one single entity that can do it. So I could relate to that. In terms of the success of your initiatives, would you say it's because of your city chapters, which many of the countries here do not have? How many city chapters do you have, and how does it work?
14 cities. Yes. So what we did is, initially when we started about 10, 15 years back, it was, India is a larger country and we were all together. Then we decided, we have to break it open, because to get a further penetration into, because, each state has got a larger population of patients. So we identified, champions from the city chapters, so who can be the city chapter leaders, and they became our voice with the doctors, with the patients and the caregivers. So we, it's like, kind of empowerment of, all of us not be able to reach out to the patients. So that helped. And those city chapter leaders are so vibrant in reaching out to the community and helping us through manage many, many of the things. So that model is really, really working for us, Rod.
Thank you. Thank you.
Thank you.
Okay, so unless there's another country, the last one to speak is Danny of Taiwan. Donnie, how are you, my friend? You're in mute.
Yes, this is Donnie from Taiwan. I'm represent the Taiwan Bone Marrow Transplantation Associations. Actually, it's, for the pandemic period in Taiwan, I would say it is almost no influence, because up to today, the whole Taiwan islands, we have only 500 cases in Taiwan. So we have no knockdowns. Patients can easily to go to a hospital. The only limitation is you must have the appointment with doctor before you can go into the hospital. And before you go to hospital, face mask is necessary. And before you entering the hospital, the alcohol, so you need to wash your hand. And of course, you need to measure your temperature before you go to the hospital. And I just listened to the other countries' situations. I can only say to live in Taiwan is very lucky. We have no access issue. We have enough medicines. And during the pandemic period, the only things we need to education our patients is to how to protect yourself. We always remind our patient, not only within our group, but also our government in the TV programs. I will say it's almost every hours. They use the different ways to educate people how to protect yourself. For example, when you go to the public transportation, you must wear masks. Yeah, and the other things like if you can just postpone your large meeting. So something like this. All of the things we need to do is protect yourself, and especially when you get a fever, you can call a special taxi. We call it COVID-19 taxi, and this COVID-19 taxi is clean, and the taxi driver is with special training and to protect you and protect himself. And the special taxi will bring you to the appointed hospital to further check. And so for the CML patients in Taiwan at this moment, because just like what I said, we have no issue to access the medicines. The issue we have is a little bit different. It's the issue we are facing is we need to encourage patients to continue to take the medicine and do not reduce the doses by himself or even stop the doses by himself. And we always educate people. If you want to reduce or even to stop doses, you must discuss with your doctors. Actually, 2 days ago, we have our CML days meeting physically, and our doctor is a little bit angry and sad because his patients stop the doses by himself and make his situation from the normal phase into the acute phases. So my doctor is very, very angry. Yeah, so the situation we are facing is a little bit different than the other countries. We must remind patients do not reduce the doses and do not stop the doses by himself. That's the issues we are facing. Sorry. Next is just echo to the question regarding the fundraisings. Actually, so we do not do the fundraising only programs. What we do is we hold a seminar every month in many hospitals. Just like when the audience listen to our seminar and he learn about the CML, then he might be willing to donate. Yeah, just to take an example, 2 days ago, so we have a physical our CML days. Yesterday, we get $3,000 US donation, just because of we hold a seminar and to educate the people what is CML and what the CML patient needed to take care of themselves. Yeah, the last is regarding the group, the CML group. I think the webinars like this one is very good because in the past we can only meet one time a year, and many people cannot fly to the Europe and to take long days to go to the other country. But nowadays we might be easier to hold seminar 6 months. 6 months, every 6 months, and I think to let us to go to together close and the shorter is might be a good. Okay, Rod, I'm finished.
Okay, thank you, Danny. Well, Taiwan is again another country we are very much envious about when Danny is saying all these things. I'm just curious, Danny, if the patients there don't have any problems with access, what is the reason for not taking the drug?
The side effect.
Side effect. Ah, okay.
Yeah, the side effect.
Mm-hmm. So they're deciding on their own without their doctor's permission to stop.
Yes.
Mm-hmm. So what is the next step? Because you said that there are availability of more TKIs.
You mean the patient who want to?
Yeah. Will he be shifted to the next generation TKI?
No, actually, we are sending our social worker to try to contact him to explain and what he should do next, because he just refused to take the medicine again.
Mm-hmm.
Yeah, he do not even want to pick up the doctor's call. Yeah, he decided by himself. Yeah.
That's interesting. Huh?
Yeah.
I don't know if it's about one person's choice, own choice, or because it's taxpayers' money, the government has the right to send in a social worker to convince him. I don't know, but maybe it's a rare case, no? Not so many patients like
it's
that.
A rare case.
Yeah,
not many, but some. Yeah, not many.
Okay, with the good news, maybe with all the good news from Taiwan, maybe we should go to Taiwan, right, guys?
Yes.
Maybe we should go there.
Yeah, but nowadays you need to be isolated by 14 days.
Okay, no more. We will not go. Okay, thank you, Donnie.
Thank you.
Let's hear from Sohag from Bangladesh.
Thank you. Actually, I was confused. I am going to miss. Anyhow, I was in Facebook. I saw the live, so I suddenly I found that it already started. I don't know. It was miscommunication. Maybe my wrong misunderstanding. So anyhow, I catch the train finally. I'm lucky. Actually, I'm Shohag. I am a CML survivor for the last 19 years. I diagnosed on 2001. So till then, I am on imatinib, Gleevec. From the beginning, I was in GPAP program. So in 2005 or 6, the GPAP program stops when Bangladesh starts producing generics. So, but nobody's and Max Foundation is so kind that they are continuing for supporting the patients, those who are under GPAP program. So at the beginning, we were 21 patients on the GPAP program. So now, due to the age and other complications, most of our fellow colleagues left us. Only we three only we are now surviving. So we are still fine. And we established a patient supporting group in 2013. When we found that there is lots of patient, actually lots of misinformation. When they diagnosed initially, Bangladesh is a very poor country, and also literacy is was not so high 10 years back. So when they diagnosed CML, doctor or physicians told that this is blood cancer. So they are not informing this is CML. They informed that this is blood cancer. So initially they thought that, okay, blood cancer means gone. So there is no treatment or something like this. So initially they're mentally, they totally destroyed. And those who have some financial capability, they try to go to abroad. Abroad means our neighboring country, India. So after visiting India, visiting physicians, they lost most of their financial conditions. Then they come back to Bangladesh. When they found that there is a medicine, there is a good treatment, but at the time they don't have the money. They already lost all of their money. So there is, for this, we thought that there is a big gap on communication. So we started a organization with 3 or 4 physicians. They support us. Initially, we only 3 persons involved on this organization. Now we are 84. So our first target was to create awareness among the patients, even among the physicians also. So at least physicians should inform to the patients that you shouldn't say the blood cancer. You should say the CML. This is one type of blood cancer. There is a treatment. So there is a possibility to survive. You can show us that we are surviving. So we try to, visit lots of physicians in mainly the capital city. So first 3 or 4 years, they support us, but then they ask, the physician asks that the only the awareness program will not work in Bangladesh. So you need to work, you need to do something for the patient assistance program. So I just tell the background of the history of Bangladesh. At this moment, actually in the pandemic situation, what we faced, at least I have 10 to 15 patients. They called me during the pandemic situation. Most of the patients are taking imatinib from Indian generic. So the price is low, though Bangladesh produces around 8 companies produces generics, but the Indian company's price is 1/4. So they go to for Indian company. So, but due to the 5 months restriction, movement restriction, they don't have any medication. So they suggest, someone called me that I don't have any medication for last 1 month. So I asked them, why you stop medicine? So he's told me I cannot go to India. I don't have any access to Indian medicine in Bangladesh. So I suggest them, discussing with the physicians, and also I have learned something that you can change the generic from one company to another. So I suggest them to, why not you take the Bangladeshi one at this, at least at this situation, though it is little bit costly. Then they they thought that it's strictly prohibited to change the medication from one company to another. So then they start again medication with the Bangladeshi company. So first 3 or 4 months there was a problem of access, but after 4 months it's now okay. But due to the pandemic situations, those who are taking medicine by own, they have learning. Earning is stopped, so still they are facing problem because we don't have any access program in Bangladesh. Just a few months ago, in the pandemic situation, one pharma company starts access program for the very poor patients, actually for the garments worker, rickshaw puller. So now they are giving free of cost medicine, but the problem is that they don't have money to the regular follow-up. Yeah. So lots of problems here due to the pandemic situation. Earnings actually goes down. So problem is still we are facing. We try to help them through some donor people to collect money and distribute them, but still we are facing. And today we have a webinar at with a pharma company and some physicians today's evening. So we will raise this issue. Hopefully we will find some solutions today. And for the what CMAL can do for an organization like us or for a country like us, actually there are a lot of things. Actually, access, in case of Bangladesh, access is a problem. So if anything, any steps or any things for the access program for the poor country like us will be very much helpful. And another thing is that the awareness program for the physicians. When we started in 2003, the World CML Day observing, I never found a doctor or a physician, they know that this is the World CML Day, 9/22. And we even informed them, what is the 9/22? They became astonished. This is excellent, excellent thing. But today, around 7 to 8 pharma company and physicians organizations are observing World CML Day. This is our achievement, I think. So awareness for the awareness of the physicians is still, as Param said, that in Bangladesh also there are some patients. I met a patient 38 years with CML. He is now 78, but he started its interferon and hydroxyurea 38 years. So he's taking now imatinib. There is nobody is there to suggest him he wants to stop medicine. So he stopped trial, but there is a gap of stop trial informations among the physicians and even also the patients. So any awareness programs and also the access programs for the country like us will be very much helpful if CML can do such kinds of or take any initiatives, such kind of initiatives will be highly appreciated. That's all from my side. Thank you, Rod.
Thank you, Suhag. You know what? I'm trying to digest what you said about the generics, and I can't seem to understand if you have 4 generics made in Bangladesh, and yet the patients are getting the one in India because it's cheaper. Can your advocacy group not make noise on those pharmaceuticals to say, hey, look, if you lower your price, the patients get the drugs from you. We don't have to go to India. Have you thought about that?
Yeah. Last 4 years we are talking. Now you see, after before 4 years, nobody invited us. The patient groups invited us any program. Now they are inviting us, and they started reducing the price. And even one pharma company, they declared yesterday that they will give free of cost medicines for 150 patients per year. So it starts working. So hopefully, let's see what will happen in coming years.
Congratulations on that. That's big news for us advocacy groups, and for everybody, because Suhag discussed this somewhat. And there's one other country. You know, we have a generic declaration at the network, which means basically, because I was part of that, which means basically, if the government will be procuring our TKIs, and for 1 month, it's a red pill. The second month, it's a blue pill. the third month, it's a yellow pill. We have the right, all right, to tell the government there has to be no change in the quality of life, in the bioequivalence, all the parameters that should have been there in the first place. Even if we are given free medicine, it's all there in the generic declaration. Now you would say, oh Rod, it's just paper, right? Our government will not honor those kinds of documents. But let's see if the network, together with our executive director here, can make some representations to the higher authorities, because it's human life that are at risk. In the Philippines, we are about to encounter that maybe next year. The government is to procure that way. So I'm still unsure whether it will happen to us, but I'm getting ready for the generic declaration to be known to them. So on that note, Dennis, I don't see any other country on
Yes,
queue.
Rod, thank you. Yes,
Rod.
your suggestion is very good. Actually, we also suggest the physicians and also the pharma companies. If you want to donate, you want to be a specific hospital. Not one hospital will take different pharma companies generic. So you pharma company donate this hospital, and this pharma company donates another other hospital. So patient should be specific. Thank you very much, Rod.
So
Yeah,
proud
Rod,
of
thank
you,
you, Rod.
Suhag. You've gone a long way from the start of 4 patients. I know you, so you've gone a long way. Yes, Andrian, anything to say?
Yes, agree with you. I'm waiting for Dennis to present the declaration of the generic to our high level government, because now we are in Indonesia. We have nine generic imatinib. So we already get imatinib generic since December 2019. So in 2 months, we can get two generic red pill, and then next month is a yellow pill also. So yeah, we're waiting for CML Advocate Network to get to send us some declaration, something for our government. Thank you, Rod.
Thank you, Andrian. So maybe Dennis, that's a way forward for this region on the generics declaration. That wouldn't take much. Okay, I see our friend, a member of the steering committee from Latin America. Just say hi, Jose. We're very glad you're here. How are you, my friend? Say a little something. This is the Asian group.
Hello, everybody. Nice to see
Nice to
so
meet
many
you too. Nice to
familiar
see you.
faces.
You know,
Hi, Dennis. Hi, Adrian. Hi, Sower.
you know, guys, if we had pushed through with Costa
Sohag.
Rica, he is the man.
He's the
Yes,
man.
exactly.
The
Yeah.
man. Yeah.
We have sightseeing Costa Rica
And
group, right?
and he kept all the sightseeing pictures ready.
Exactly what
Yeah. Okay.
We'll make it. We'll make it to Costa Rica.
Oh,
We
the
will make
giraffes,
it to
the
Costa Rica.
lions. Yeah.
We will make it.
Thank you, Jose, for dropping by. Dennis, it's all yours.
okay.
All yours.
Okay.
We are looking at you at the TV.
So nice to see you, Jose, and thank you very much, Rod, for that really excellent overview of the region. I really learned a lot, and I really feel that now, as the network, we can definitely start some initiatives to support the great work that you are doing. And certainly, you know, it's interesting that Jose joined us and that we couldn't all make it to Costa Rica this year, but I want to let you know that Horizons is still happening. CML Horizons will be virtual from November 6th to November 8th. And because it's virtual, we're making it free for everybody. So everybody will be able to attend. And probably later this week, you will receive the information about how to register for the Congress this year. We've had to adapt the program slightly because obviously we don't want everybody to be stuck in front of their computers for 3 days. So it's going to be a slightly shorter Horizons than we would normally have. But I think it's a very good idea for future Horizons to look at this generic question and really relook at the declaration and bring that back onto the agenda as something that the network can do for you all, along with some of the other great ideas that you shared with us today. So I wish you all very well wherever you are. Stay healthy, stay strong. We will continue now with some pre-recorded videos that we've put together because we have some people from the region, from Australia and from New Zealand, who couldn't make it with us here live today. So what I'm going to do is I'm going to share my screen and we can watch these videos if you want, if you have the time to stay on. It's just a few minutes.
How has 2020 affected the CML community? How can we work together for a life without CML? What's next for the CML community? The CML community recently came together to ask some of these questions. The following presentation was completed via online interviews and self-tape submissions from the CML community. We would like to thank those patients, advocates, and the physicians who contributed to Voices of CML. Arigato, Sisi, Terima kasih, Dhanyavad, Kobkun Krab, Salamat, thank you. Today, together, more than ever, for a life without CML.
Challenges that I faced in 2020 in relation to CML would be the COVID-19 pandemic and understanding how that will interact if I was to contract COVID-19, interact with the drugs, the treatment, the leukemia itself. And I found it quite difficult at first to find the answers to those questions. I found it a little bit tricky, but as the months have gone on, I think there's a little bit more evidence available. So I've been able to get some answers at least. But it's still something to grapple with and something to be aware of and be a little bit concerned about.
In a world that we've seen that's really changed in 2020, the CML community is striving for a life without CML in it. So now more than ever, as a community, they should be coming together to highlight what support can enable them to reach this outcome, whether it be access to treatment, access to allied health to support them in their everyday life, or access to groups like patient organisations like the Leukemia Foundation, because people living with CML aren't always accessing their treatment centres, and in a COVID normal world that we may see into the future, how people living with CML can come together as a community and find access to these key supports so that they can have and live their best lives.
CML community over the last 10 plus years has been staying together, and the pandemic now has brought us to stay together even in a virtual world. Normally we join as a community, we share our best practices through face-to-face meetings, but the pandemic did not allow us in 2020. So one of the things that we continue to do is to be together. Community needs to stay together, work together, and share some of the experiences the CML community faced during this pandemic, and try to learn and try to get some questionnaire evolved around this pandemic and how did we as patients, the caregivers and the community faced it, and try to regroup both through these virtual meetings and as well as whenever possible face-to-face meetings, and build up the health quotient. I will call it as the health quotient. Build up the health quotients moving forward to help the community to face any more uncertainties that keeps coming up and stay together for a better quality of life moving forward.
2020 has so far been a very challenging year for the patients insofar as access to the medicines are concerned. With the limited government funding for CML, it is now zero, as all the funds have been shifted to COVID-19 pandemic. Many of our patients are now turning to the cheapest generic they can get from the internet.
So even though we faced a lot of challenges in 2020, one of the successful outcomes of the Leukemia Foundation and many of our blood cancer experts and people living with blood cancer in Australia has been producing a national action plan, which we have delivered to the federal government in Australia, which provides a blueprint on how we can improve outcomes for people living with blood cancer and people living with CML. So importantly, I look forward to 2021, us as a collective blood cancer community, really elevating the work of this national action plan so that we can improve people living with CML and all the blood cancers in Australia with their access to treatment, care and information so that they are empowered to make the best decisions about their everyday in their everyday.
On World CML Day, we will be holding a webinar for our members for them to know the latest developments about the CML environment, both medical and financial. For the rest of the year and 2021, we will be establishing the CML Alliance of the Philippines to consolidate the voices of all the CML groups all over the islands.
One of our key focus areas at the Leukemia Foundation in where we can improve on in how we deliver our care is moving into a digital space, which really removes any challenge or burden to where people may be living or where they're at. I have worked in the blood cancer area for over 20 years, and though I know a lot about blood cancer, connecting with others, and that's where the CML Advocates group brings together right round our globe, patient advocate groups, patient advocates themselves. And knowing that you're not alone is a really important value for people from what they've told me. So connecting to others living with CML who may have been through what you've been through, and connecting, as I was saying, we're moving to a digital space. So to be able to provide that space to understand that you're not alone in the globe, and there may be someone who's experienced things that you can learn from, but even if there's not something to learn from, that's someone who understands you. So there are digital support groups online, and we do have them as well. So I encourage people that if they are feeling vulnerable, that they look and reach out to those trusted patient groups that the CML Advocates work with.
That's probably the toughest question, and it could be applied to every blood cancer. I mean, I suppose the key for us, I come back to our vision and mission. So our vision is to cure, our mission is to care. We're doing the caring element at the moment. I think the cure side of it, research and finding ways of minimising and reducing the number of people that are presenting with CML and all blood cancers for that matter, has got to be in the back of our minds, somewhere along the lines. It's a big mountain and something to aim for, but certainly being able to address it, ensure that people's lives are livable and enjoyable first and foremost, but that we can ultimately get to a point where we find an answer. So big goal, but be a nice goal, wouldn't it?
Also, in the near future, as the representative of Asia Pacific in the steering committee of the CML Advocates Network, my hope is to make my region more visible and engage in the various projects available globally.
So a core part of our support services at the Leukemia Foundation was delivering a lot of that care face-to-face. So as COVID hit our shores in Australia, we quickly worked with our blood cancer healthcare professionals to understand how we could best support people living with blood cancer and CML in Australia. So that meant us having to quickly change from that face-to-face model and start offering our services online. So we now run an online Facebook group for people living with CML. We run online support groups that have been quite successful.
In 2021, the goal is to still be here for patients around New Zealand. We would like to continue to support them as much as we did before the pandemic, as well as the local healthcare professionals around the country. And it's a big goal for LBC to continue to be able to support haematology research throughout the country. We're a big funder of research and we would like that to continue as well.
One of the first really important steps for every individual living with CML, regardless of where they live, is that access to information that's relevant to them. So no matter where they live and what treatments may be available, understanding what may be available and what best they can do for themselves, and having that power and that permission in their treating discussions to ask the questions that they want to ask until they seek that clarification can really ensure that they can make the best decision for themselves and advocate for their best care. So I think understanding and having access to key information, and the Leukemia Foundation is a great source with our website, which was newly launched recently, to ensure that no matter where somebody lives in our global community, that they have access to trusted information around CML and the treatments and managing the side effects so that they can, as I said, be their own self-advocates in what their best care looks like.
Look, the things that we need to do, the things that we want, I suppose there's an exchange currency that goes on. What funding and money buys us, obviously, is resources. So the key things on the ground for us would be the ability to afford to have greater resources, or certainly geographic spread of resources around the country. We have an equity issue in New Zealand. Some people live rurally, so ensuring that they get the same quality of support and service, not only from our health service, but from us, is a key part of that. So that buys us the capability of doing that. And certainly, I think the funding and investment we can make into research in particular to try and find some of the answers, to try and find some of the smart ways of reducing the likelihood of blood cancers and CML has got to be part of the answer too. So the downside, the upside, the downside is that funds tend to buy that sort of resource. Also, the downside is we need to find those funds. So at the moment, it's more around those resources to be able to do that.
You know, since the Philippines is composed of many islands, mostly rural of them, our goal and greatest challenge is to reach out to all of those patients out there who don't have the access to the medical facilities, including the medicines that they need.
Yep. I mean, I guess moving forward with some of the COVID, I think part of this virtual delivery is just going to stick with us. So I think we're going to try to find a way as an organization to, embed this element of running education to patients and families. I think we're going to continue with our webinar program. So we've been doing a lot of that. And I see as well, I mean, just finding a way to connect with patients. This never goes away. And just as well, updating a lot of our booklets. So I'm thinking about our CML booklet, and that's actually just a few months away from being the most up-to-date, having like the best information, 2020 information. So we're gonna, we're gonna continue to spruce up our catalog of education in 2021, and some of it is just going to start with our bread and butter, our booklet, our disease-specific booklet, CML.
The target for year 2020, our target is try to spread the information for CML for people to understand more what CML is about, especially for the advocates?
I think one of the resource that is very much needed is the community to further work through this process through virtual meetings and not lose the the tempo, because normally what happens is when we meet in many horizons and many other meetings, we get a chance to face. So one of the resource that is really needed, the global community should stay in formats to stay together globally as well as regionally. This is very, very important resource. Second thing is, as the webinar forums are really picking up, how do we bring the healthcare professionals and experts who have dealt with the pandemic and try to link with the CML community? How do we bring them and share, because this is very important to get an input from our healthcare professionals and experts to, help us to further deal through this in the coming years. So I think these two are very useful resources that I definitely need to further continue on this community engagement as we step into 2021. These two are my main resource that I expect.
We had to take our services online with our Facebook groups for people living with CML, online support groups, as well as the team right around the country in Australia reaching out to people who have had contact with us before, just as a check-in, because people living with CML may not be going to their treating centres, and we wanted to let them know that the Leukemia Foundation was here for them as the challenges arose in their everyday of living with CML and facing the challenges of COVID. The Leukemia Foundation is proud to be working with the CML advocates around elevating and highlighting the needs of people living with CML right around our globe. Here we proudly embrace Blood Cancer Awareness Month in Australia and at the Leukemia Foundation. And on World CML Awareness Day, we'll be hosting an interactive webinar with Professor Tim Hughes, who's closely aligned with the CML advocates, and we're really proud to offer that session to support people living with CML to learn more about their leukemia and also how they can work towards a life without CML.
Yeah, as a CML community or CML survivor, what I think that though we are living with CML for a long, but we have a lot of complications. We have a lot of side effects. So a life without CML would be great for us. So in that context, I think our community should raise our voice to have a treatment or so to have a facility that can lead our life without CML. So we can what we can do, we can raise our voice in different platforms in the world, in the different pharma companies to and even also UN. We can raise our voice that a world we need to live without CML.
I believe in three processes. One is, we as human beings, we are blessed to have a beautiful body. We are given a mind, and there is a soul, which all revolves around energy. And I would like to give this message of this famous equation called E is equal to mc square. I think most of you remember. So for the community, I would like to say, what does this translate? E is energy. We are all governed by energy. E is equal to, the M is the motivation, the first C is connection, and the second C is collaboration. So E is equal to mc square is energy is equal to motivation into collaboration into connection. And the community has to engage and increase a high intensity energy to stay together. And yes, I have faced, one of my very close friends, she's struggling through one of the predicaments, from the CML manifestation. But it's very important to, bring those energies of positivity to, because
The pandemic is creating a lot of negativity. So how can we do? And we as human beings can change the negative to positive. And it all needs through a motivation, through a connection, and through collaboration, and with best practices that we have fantastic patient advocates. Try to learn from them on their coping strategies. Each one has got many coping strategies. So we should adopt and try to learn and try to engage and try to work towards that behaviors in us so that this energy kindles and spreads into the community. That would be my message to my fellow, countrymen, my region, and to the global community.
I think the goal for me in relation to wellness for 2021 will be to keep fit and healthy, both physically and mentally. I think they're the keys to fighting CML. So the goal for me is to continue to spend the right amount of time on my personal health, and also to continue supporting Leukemia Blood Cancer New Zealand in the ways that I can. So whether that be shaving my head in the Shave for a Cure campaign, or climbing the Sky Tower as it will be this year, actually, in the firefighter climb in November of this year. So continue raising awareness, continue raising funds for LBC.
And I suppose my message is that I want to pass on my heartfelt thoughts to everyone that's out there. I know that we're all experiencing extraordinary times. And I'd like to recognise and thank all the frontline health staff, not only in New Zealand, our country, but around the world. Amazing dedication. And that includes their own support services team. Equally, I'd like to reach out to family and patients and peers and colleagues and partners right around the world and wish them the very, very best. I hope they stay healthy and safe. And I'll also finish on the note that it is CML Day. And today, together, more than ever, for a life without CML.
Welcome to Voice of CML. Shortly, you will hear from some of our members at CML Advocates Network. A few years ago, we started with only a few countries, but since then we have grown. We have 126 patient organizations in over 93 countries around the world. Every year, on the 22nd of September, we come together to raise awareness for the CML community. Unfortunately, 2020 has presented us with many new challenges. However, we continue to adapt. In this 6-part live stream, we hope to give all those around the world the opportunity to come together and share their stories using the digital space. Today, many CML patients do not have access to life-saving treatment. Many CML patients do not have access to doctors. Many CML patients do not have up-to-date credible information on the very disease they live with every day. Our hope is to share those stories while also teaching and raising awareness for chronic myeloid leukemia. Today, together more than ever, for a life without CML.
Today, together more than ever, for a life without CML.
Today, together more than ever for a life without CML.
Cool. Today, together more than ever, for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
It is CML Day, and today, together more than ever, for a life without CML.
Hoy juntos más que nunca por una vida sin LMC.
اليوم معا أكثر من أي يوم مضى لحياة خالية من سرطان الدم المزمن.
Today, together, more than ever, for a life without CML, mabuhay.
Hari ini bersama-sama lebih dari sebelumnya untuk hidup tanpa CML.
Aujourd'hui, tous unis, tous uniques pour une vie sans LMC. Today, together, more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today,
Together,
more than ever,
for a life without CML.
Today, together more than ever for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for life without CML.
Today, together, more than ever, for life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for the life without chronic myeloid leukemia.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Welcome to Voice of CML. Shortly, You will hear from some of our members at CML Advocates Network. A few years ago, we started with only a few
How has 2020 affected the CML community? How can we work together for a life without CML? What's next for the CML community? The CML community recently came together to ask some of these questions. The following presentation was completed via online interviews and self-tape submissions from the CML community. We would like to thank those patients, advocates, and the physicians who contributed to Voices of CML. Arigato, Sisi, terima kasih, Janyavad, Kobkun Krab, Salamat, thank you. Today, together, more than ever, for a life without CML.
Challenges that I face in 2020 in relation to CML would be the COVID-19 pandemic and understanding how that will interact if I was to contract COVID-19, interact with the drugs, the treatment, the leukemia itself. And I found it quite difficult at first to find the answers to those questions. I found it a little bit tricky, but as the months have gone on, I think there's a little bit more evidence available. So I've been able to get some answers at least. But it's still something to grapple with and something to be aware of and be a little bit concerned about.
In a world that we've seen that's really changed in 2020, the CML community is striving for a life without CML in it. So now more than ever, as a community, they should be coming together to highlight what support can enable them to reach this outcome, whether it be access to treatment, access to allied health to support them in their everyday life, or access to groups like patient organisations like the Leukemia Foundation, because people living with CML aren't always accessing their treatment centres, and in a COVID normal world that we may see into the future, how people living with CML can come together as a community and find access to these key supports so that they can have and live their best lives.
CML community over the last 10 plus years has been staying together, and the pandemic now has brought us to stay together even in a virtual world. Normally we join as a community, we share our best practices through face-to-face meetings, but the pandemic did not allow us in 2020. So one of the things that we continue to do is to be together. Community needs to stay together, work together, and share some of the experiences the CML community faced during this pandemic, and try to learn and try to get some questionnaire around this pandemic and how did we as patients, the caregivers and the community faced it, and try to regroup both through these virtual meetings and as well as whenever possible face-to-face meetings, and build up the health quotient. I will call it as the health quotient. Build up the health quotients moving forward to help the community to face any more uncertainties that keeps coming up and stay together for a better quality of life moving forward.
2020 has so far been a very challenging year for the patients insofar as access to the medicines are concerned. With the limited government funding for CML, it is now zero, as all the funds have been shifted to COVID-19 pandemic. Many of our patients are now turning to the cheapest generic they can get from the internet.
So even though we've faced a lot of challenges in 2020, one of the successful outcomes of the Leukemia Foundation and many of our blood cancer experts and people living with blood cancer in Australia has been producing a national action plan, which we have delivered to the federal government in Australia, which provides a blueprint on how we can improve outcomes for people living with blood cancer and people living with CML. So importantly, I look forward to 2021, us as a collective blood cancer community, really elevating the work of this National Action Plan so that we can improve people living with CML and all the blood cancers in Australia with their access to treatment, care and information so that they are empowered to make the best decisions about their everyday in their everyday.
On World CML Day, we will be holding a webinar for our members for them to know the latest developments about the CML environment, both medical and financial. For the rest of the year and 2021, we will be establishing the CML Alliance of the Philippines to consolidate the voices of all the CML groups all over the islands.
One of our key focus areas at the Leukemia Foundation in where we can improve on in how we deliver our care is moving into a digital space, which really removes any challenge or burden to where people may be living or where they're at. I have worked in the blood cancer area for over 20 years, and though I know a lot about blood cancer, connecting with others, and that's where the CML Advocates group brings together right round our globe, patient advocate groups, patient advocates themselves. And knowing that you're not alone is a really important value for people from what they've told me. So connecting to others living with CML who may have been through what you've been through, and connecting, as I was saying, we're moving to a digital space. So to be able to provide that space to understand that you're not alone in the globe, and there may be someone who's experienced things that you can learn from, but even if there's not something to learn from, that's someone who understands you. So there are digital support groups online, and we do have them as well. So I encourage people that if they are feeling vulnerable, that they look and reach out to those trusted patient groups that the CML Advocates work with.
That's probably the toughest question, and it could be applied to every blood cancer. I mean, I suppose the key for us, I come back to our vision and mission. So our vision is to cure, our mission is to care. We're doing the caring element at the moment. I think the cure side of it, research and finding ways of minimising and reducing the number of people that are presenting with CML and all blood cancers for that matter, has got to be in the back of our minds, somewhere along the lines. It's a big mountain and something to aim for, but certainly being able to address it, ensure that people's lives are livable and enjoyable first and foremost, but that we can ultimately get to a point where we find an answer. So big goal, but be a nice goal, wouldn't it?
Also, in the near future, as the representative of Asia Pacific in the steering committee of the CML Advocates Network, my hope is to make my region more visible and engage in the various projects available globally.
So a core part of our support services at the Leukemia Foundation was delivering a lot of that care face-to-face. So as COVID hit our shores in Australia, we quickly worked with our blood cancer healthcare professionals to understand how we could best support people living with blood cancer and CML in Australia. So that meant us having to quickly change from that face-to-face model and start offering our services online. So we now run an online Facebook group for people living with CML. We run online support groups that have been quite successful.
In 2021, the goal is to still be here for patients around New Zealand. We would like to continue to support them as much as we did before the pandemic, as well as the local healthcare professionals around the country. And it's a big goal for LBC to continue to be able to support haematology research throughout the country. We're a big funder of research, and we would like that to continue as well.
One of the first really important steps for every individual living with CML, regardless of where they live, is that access to information that's relevant to them. So no matter where they live and what treatments may be available, understanding what may be available and what best they can do for themselves, and having that power and that permission in their treating discussions to ask the questions that they want to ask until they seek that clarification can really ensure that they can make the best decision for themselves and advocate for their best care. So I think understanding and having access to key information, and the Leukemia Foundation is a great source with our website, which was newly launched recently, to ensure that no matter where somebody lives in our global community, that they have access to trusted information around CML and the treatments and managing the side effects, so that they can, as I said, be their own self-advocates in what their best care looks like.
Look, the things that we need to do, the things that we want, I suppose there's an exchange currency that goes on. What funding and money buys us, obviously, is resources. So the key things on the ground for us would be the ability to afford to have greater resources, or certainly geographic spread of resources around the country. We have an equity issue in New Zealand. Some people live rurally, so ensuring that they get the same quality of support and service, not only from our health service, but from us, is a key part of that. So that buys us the capability of doing that. And certainly, I think the funding and investment we can make into research in particular, to try and find some of the answers, to try and find some of the smart ways of reducing the likelihood of blood cancers and CML, has got to be part of the answer too. So the downside, the upside, the downside is that funds tend to buy that sort of resource. Also, the downside is we need to find those funds. So at the moment, it's more around those resources to be able to do that.
You know, since the Philippines is composed of many islands, mostly rural of them, our goal and greatest challenge is to reach out to all of those patients out there who don't have the access to the medical facilities, including the medicines that they need.
Yep. I mean, I guess moving forward with some of the COVID, I think part of this virtual delivery is just going to stick with us. So I think we're going to try to find a way as an organization to embed this element of running education to patients and families. I think we're going to continue with our webinar program. So we've been doing a lot of that. And I see as well, I mean, just finding a way to connect with patients. This never goes away. And just as well, updating a lot of our booklets. So I'm thinking about our CML booklet, and that's actually just a few months away from being the most up-to-date, having like the best information, 2020 information. So we're gonna, we're gonna continue to spruce up our catalog of education in 2021, and some of it is just going to start with our bread and butter, our booklet, our disease-specific booklet, CML.
The target for year 2020, our target is try to spread the information for CML for people to understand more what CML is about, especially for the advocates.
I think one of the resources that is very much needed is the community to, further work through this process through virtual meetings and not lose the the tempo, because normally what happens is when we meet in many horizons and many other meetings, we get a chance to face. So one of the resources that is really needed, the global community should stay in formats to stay together globally as well as regionally. This is very, very important resource. Second thing is, as the webinar forums are really picking up, how do we bring the healthcare professionals and experts who have dealt with the pandemic and try to link with the CML community? How do we bring them and share because this is very important to get an input from our healthcare professionals and experts to, help us to further deal through this in the coming years. So I think these two are very useful resources that I definitely need to further continue on this community engagement as we step into 2021. These two are my main resource that I expect.
We had to take our services online with our Facebook groups for people living with CML, online support groups, as well as the team right around the country in Australia reaching out to people who have had contact with us before, just as a check-in, because people living with CML may not be going to their treating centres, and we wanted to let them know that the Leukemia Foundation was here for them as the challenges arose in their everyday of living with CML and facing the challenges of COVID. The Leukemia Foundation is proud to be working with the CML advocates around elevating and highlighting the needs of people living with CML right around our globe. Here we proudly embrace Blood Cancer Awareness Month in Australia and at the Leukemia Foundation. And on World CML Awareness Day, we'll be hosting an interactive webinar with Professor Tim Hughes, who's closely aligned with the CML advocates, and we're really proud to offer that session to support people living with CML to learn more about their leukemia and also how they can work towards a life without CML.
Yeah, as a CML community or CML survivor, what I think that though we are living with CML for a long, but we have a lot of complications. We have a lot of side effects. So a life without CML would be great for us. So in that context, I think our community should raise our voice to have a treatment or so to have a facility that can lead our life without CML. So we can what we can do, we can raise our voice in different platforms in the world, in the different pharma companies and even also UN. We can raise our voice that a world we need to live without CML.
I believe in three processes. One is we as human beings, we are blessed to have a beautiful body. We are given a mind and there is a soul, which all revolves around energy. And I would like to give this message of this famous equation called E is equal to mc square. I think most of you remember. So for the community, I would like to say, what does this translate? E is energy. We are all governed by energy. E is equal to, the M is the motivation, the first C is connection, and the second C is collaboration. So E is equal to mc square is energy is equal to motivation into collaboration into connection. And the community has to engage and increase a high intensity energy to stay together. And yes, I have faced, one of my very close friends, she's struggling through one of the predicaments, from the CML manifestation. But it's very important to, bring those energies of positivity to, because the pandemic is creating a lot of negativity. So how can we do? And we as human beings can change the negative to positive. And it all needs through a motivation, through a connection, and through collaboration. And with best practices that we have fantastic patient advocates. Try to learn from them on their coping strategies. Each one has got many coping strategies. So we should adopt and try to learn and try to engage and try to work towards that behaviors in us so that this energy kindles and spreads into the community. That would be my message to my fellow, countrymen, my region, and to the global community.
I think the goal for me in relation to wellness for 2021 will be to keep fit and healthy, both physically and mentally. I think they're the keys to fighting CML. So the goal for me is to continue to spend the right amount of time on my personal health, and also to continue supporting Leukemia Blood Cancer New Zealand in the ways that I can. So whether that be shaving my head in the Shave for a Cure campaign, or climbing the Sky Tower in the as I will be this year actually in the firefighter climb in November of this year. So yeah, continue raising awareness, continue raising funds for LVC.
And I suppose my message is that I want to pass on my heartfelt thoughts to everyone that's out there. I know that we're all experiencing extraordinary times, and I'd like to recognise and thank all the frontline health staff, not only in New Zealand, our country, but around the world. Amazing dedication, and that includes their own support services team. Equally, I'd like to reach out to family and patients and peers and colleagues and partners right around the world and wish them the very, very best. I hope they stay healthy and safe. And I'll also finish on the note that it is CML Day, and today, together, more than ever, for a life without CML.
I have to cross the sea. cross the sea, from true north to holy Can we go? Good. Hello and welcome to Voices of CML on World CML Day, the 22nd of September 2020. I'm Dennis Costello. I'm the Executive Director of CML Advocates Network. I'm joined here today by two of my colleagues as well, Celia Marin and Lydia Pekova, as well as one of our regional representatives, Jelena Čugorović from the CML Association of Serbia. Thank you very much for everybody to take the time to join us today, just to obviously get together, feel as a community. Because of the whole circumstances around COVID, we've decided to have a series of virtual regional meetings. We started this morning, European time, at 8 a.m. with our Asian region, and that was a very lively discussion, and I'd like to thank our steering committee member Rob Padua for moderating that. So today I'm going to very shortly hand over to you, Jelena. It's the region of Central and Eastern Europe and Western Asia is actually the biggest region in some senses, in the sense we have the most members from that region, and obviously geographically it's quite an extensive region, going from from Poland all the way over to Kazakhstan. So you're going to tell us a little bit about what World CML Day means for you and for the region, and tell us a bit about some of the activities that you'd like to talk to us about today.
Dobar dan, dobro jutro, good morning, hello everybody from the Central and Eastern Europe region. My name is Jelena Čugorović and I'm working in this region and representing all the organizations in the Central and Eastern Europe. When I speak about my region, I always like to say that it is the most diversified region of all regions. We represent 34 patient organizations coming from 24 countries. In short, if I want to explain the diversity, I would say we have 11 non-EU countries and 13 EU countries. So if we put again in short, we say different governments, different social securities, different health systems, and everything comes very differently. But then if we want to speak with each other and try to make it unique, we can learn from each other and we can share the knowledge we have. Because again, we cross the borders and we learn from each other. So I would say that my region did not come live today as much as we expected, because most of us are at work and most of us celebrate World CML Day with our own organizations having the meetings in the evening. But I know that all the hearts from all the organizations are with us and that they are sending us the strength to show how this region is diversified, but then again, how unique we are. 2020 was a very hard year for all of us. Again, if I want to put it in short, I would say it was a COVID year. This was not only hard for the patients who have challenged many different things, such as getting the drugs on time, getting their PCR tests, getting their appointment with their doctors when everything was closed. So it was hard for the patients, but it was hard for us as advocates to try to give them support and to organize as much activities, as much help we could provide them. So my first applause, to be correct, goes to all of these organizations who managed to help the patients in the best possible way. But then, when I want to be straight, then I would say that the biggest applause goes to newly diagnosed patients. These patients who faced leukemia for the first time in the period of COVID, when they had to deal with COVID and leukemia for the first time all together. And I think that these patients had the hardest time to get to the right doctors and to get the right therapists and to get the right monitoring. So I would say that we as advocates, if we manage to do it properly, we showed how important our work is for all these newly diagnosed patients who could not go to hospitals, who could not speak to the doctors as we usually do. And I think that what we did, and each of the patients who was newly diagnosed, who we gave the support, should get the applause, the biggest applause, and all of us working with them should get the applause for that. So I would really, really like to put again and to say how important this work is, and how that we actually, for the first time after the Glivec came up, can see some difficulties in our work and some new realities. And we should now be stronger than ever and show the support more than ever and learn from each other. So my hope is that 2021 will be easier for us, and that we can learn from the experiences we had in 2020. And then again, during this time, we would say, okay, we did only COVID, but we did not. We did other activities as well. For 6 months, we have been working on a very big project called CML Atlas of Central and Eastern Europe. This project lasted for 6 months, and during 3 months, beginning in December 2019 and lasting till March 2020, we managed to collect the data from our region. I would say for the first time in the world, such important data are summarized on one place for so many countries. We have managed to collect the data from 19 countries from this region, coming from six CML doctors from 6 different countries, and then also and 13 patient organizations. So if you go to Central and Eastern Europe region, you can see that we, on your left side, you can scroll and you can show, can you please go to Czech Republic, for example? So you can search this data in from general information, availability of medicine, cost of medicine, test availability, treatment-free remission. So you can go from a country to country and see all the data there, from the number of doctors, number of treating hospitals, number of patients in the country, number of organizations working in the country, from all the therapies which are available, the costs of these therapies, and the number of patients being on these therapies for 19 countries. And then again, you can use another search engine and go, for example, go to PCR or test availability and see how these tests are available in the whole region. I would not take too much time to go through the details of this project, but I think that we as a region must be and should be very proud of this project. And CML Network should be proud of this regional project because they gave us so much freedom to do it the way we thought it should be done. And I think that this should be a good pathway for all other, not only regions, but also for other organizations to try to do similar things. Unfortunately, again, we don't have many people live from our region, but we had 53 minutes of filming with comments coming from our region. I would say that my region is mainly not always to open for a lively discussion, but they are open to share their views and their opinions and their thoughts. Maybe we are not as open as Asia and Pacific because we never had regional meetings before, but I can say that we strongly support each other and work with each other and feel better maybe when we write. So as the closure of this live part, I would all like you to use all hashtags, use your own social media, write in any language you prefer, but celebrate this day healthy, in good spirit, and with good thoughts. Hug the people you love, and then again, give big greetings to each patient you have in your country with the CML. Now we would go to videos and see what people from my region want to tell you about CML in 2020. Thank you all for being live with us today.
Thank you very much, Yelena, and thank you very much for everyone who's taken the time to join us today. Just before we go to the videos, I might like to give you an opportunity just to say a few words, if you wish. I see that we have Christina, Sophia, Mirjana, Yelena present. If you would like to say a word, you're more than happy to just raise your hand or unmute yourself and say something. Otherwise, I'm happy also to go to the videos.
Okay, sorry, I did not see how many people we have here, but my topic for today was how do you feel and where do you see CML in 2021? So I would be very happy if anyone from you would like to share their point of view. Mimi?
Thank you all for organizing this type of live streaming. It is very unique opportunity to be a part of this type of organization as CML advocates do. We are a very new member in your global network. What are the expectations for CML Advocates Network in the next year? First, I would like to say that I hope that in the next year, the position with COVID pandemic will be ended. I hope till the end of the next year. Until then, we would like to ask from CML Advocates Network to do more for Central Eastern European part, since we do not have the same treatment and the same access as the Western Europe countries. I mean, especially for the non-European countries who always get the access to treatment last, or sometimes they do not get the access. So is there any possibility for this network to go together with us to the system institutions, or to do some plan what should we do in the future or in the next year to help Central Eastern Europe to get better access? Thank you.
Thank you. Christina, big hello to Slovenia. Can you please unmute yourself?
Okay, sorry.
Hi.
Where I see the CML in 2021, well, we have a good access in Slovenia to all the therapies. So I would like for our patients to be more aware about the meaning of rehabilitation, about supporting programs of our organization. And I hope as many as possible patients will attend our rehabilitation program, because it's really good for them, for their quality of life. So this is, I think this is our big goal for next year. How to spread the awareness between CML patients about the quality of life, about the meaning of quality of life, about the about the healthy way of living. So this is really important, because we see that maybe sometimes they are not so active as should be.
Do you need anything from the network to help you, from the region? Is there anything we can do to help you in what you plan to do?
Oh, I think that in this moment we don't need any help from abroad, because we just need the help from our doctors, because they are very important and they help us to invite patients in our programs. So we are doing on awareness between the hematologists about this program, and every year we are better and better. So I'm sure that you know, next year will be better than this year. So
thank you. Lydia?
I actually have a question for Christina. Christina, how did you start that rehabilitation program? Did it prove very difficult with the government?
No, we prepared this program together with the hematologists and specialists for the rehabilitation. And then we introduced the program to our Ministry of Health, and half of the budget they covered with the fund. So they find out our program very good, very good for the patients. So I don't know. They decided to support with the fund. So
you didn't have any opposition, any difficulties with the Ministry of Health opposing it, or they were quite on board with the program? Is it just for blood cancer, or all cancer has that rehabilitation program?
Our program is only for blood cancer patients. But you know, for example, Europa Dona has something similar for the breast cancer patients.
Right, right.
Europa Colon for the colorectal patients. So Ministry of Health support not just our program, but also programs from Europa Dona, Europa Colon. They spread the budget and the money to different patient organizations. Not all who who would like to be funded, but they found out some. They selected some of these programs, and then we got the money.
Because the message I got from a lot of our members around Eastern Europe is that rehab program to re-enter workforce and everything like that. Is that something that your organization can share as a best practice on how you approach that program, and maybe we can share it?
Yes, very important in our country with our negotiations at the Ministry of Health was that the program was made together with the Society of our Hematologists and with the experts of rehabilitation in Slovenia. So it was not something, you know, it was not, the program was made with the super specialists in Slovenia, and they were not able to say, it's not okay, it's not, I don't know, you don't have a good experts or something. We followed also the other programs from Mayo Clinic, for example. We find some good topics and implement into our program. So
fantastic. Fantastic. Thank you for sharing that. That's appreciated. That's something, you know, Mirjana can take back also for Macedonia. Thank you. I appreciate you sharing that.
If anybody is very interested in how to start with this project, I can, you know, we can have a meeting and we can share our experiences.
Thank you. That would be lovely. Thanks.
Christina, thank you very much for sharing this. I honestly hope that I would put it on top of my list to organize the meeting for everybody who is interested in this to to share your point, but you know the inside story. We want the inside story. Cool.
Okay.
Kalimera Sofia. Nice to have you with us. Can you
No, I'm okay. Hello.
You're okay now.
For those who don't know me, I'm Sofia Leonardo. I used to represent a Greek organization which was about all type of cancers. But now the last year I left, and I'm very interested to how to start my own organization, but only about blood cancer. So I could, I need all your help.
Okay, with all the knowledge you already have and us as a support, I'm sure you will do a great job. And anyway, we need a strong organization in Greece.
Okay, thank you.
Last but not the least, hello Stanislav, how are you?
My name is Stanislav. This Zoom is of my wife. Sorry, not my name on the screen. I represent a Russian organization Sodeyствие. And I would like to say some words about my organization. We have in our big country about 85 regions, and each region is like a small country in Europe. We help about 8,000 patients with CML. Maybe you know we have all Russian federal program, 12 nosology, and now it 14 nosology. And CML patients and other patients with oncohematological diseases supplied free by medicine. And we have problem. We have problem that in this federal program we have only imatinib. And dasatinib, nilotinib, and other second and third line CML therapy is available in region by regional budgets. And we plan to hold our All Russian forum on the 1st October this year. And because there is concern that funding for the federal program may be reduced, we prepare a resolution for our health ministry and government. And I would like to include in this program the second and third line of CML therapy, and would like to prevent the cut in the budget of drug supply in the next year, because you know COVID is maybe a cause of this reducing. And on occasion this CML World Day, I'd like to congratulate everyone, every sister and brother of blood, and wish be healthy, lucky, and happy. Thank you. Sorry for my English.
It's perfect. Thank you so much, Stanislav. If there is anything we can do to help, I will even speak Russian. So
I think if the federal program would be cutting, maybe we have help from our colleagues to appear by letters to our authority and health ministry, as we did it before.
Okay.
Yeah. Thank you.
But you should be the one to decide when and what kind of help you need us.
Yes, of course.
Okay, just feel free to contact anybody of us.
Thank you so much.
Thank you. Thank you, everybody. And thank you, Yelena, for chairing this meeting. Before we move to the series of videos, I just want to obviously remind you all that Horizons will take place this year virtually from November 6th until November 8th. So that's a weekend. We have shortened the program so that you don't have to sit in front of your screen all day. It'll just be 3 hours each day. So I think it should be fairly manageable, although it's obviously not ideal that we can't meet face to face, but obviously the circumstances are what they are and we have to deal with them. We just want to also say that because of it's virtual, it will be free for everybody who wishes to attend. So, you know, in the past, as you know, we've had the scholarships and all that, but this year it's going to be free for everybody. So we hope to have, you know, a good attendance and hopefully also a good opportunity to network with other patient leaders from the CML community during those few days. So you'll be hearing from Lydia probably in the coming days about how to register for the online platform for this year's Horizons. So let's go to some video footage that Lydia has been working on specifically with a colleague of ours as well, Justin, and cut together some interesting experiences from the region. Obviously, we'll kick off with a short message from our co-chair Felice Bombacci. This video is quite long, so it'll be available obviously online after this call as well. So feel free to stay here in the Zoom and watch the video. I'm going to share my screen now, and so therefore you will be able to watch the video here. Thank you again for your presence. It's greatly appreciated and look
forward. Welcome to Voice of CML. Shortly, you will hear from some of our members at CML Advocates Network. A few years ago, we started with only a few countries, but since then we have grown. We have 126 patient organizations in over 93 countries around the world. Every year, on the 22nd of September, we come together to raise awareness for the CML community. Unfortunately, 2020 has presented us with many new challenges. However, we continue to adapt. In this 6-part live stream, we hope to give all those around the world the opportunity to come together and share their stories using the digital space. Today, many CML patients do not have access to life-saving treatment. Many CML patients do not have access to doctors. Many CML patients do not have up-to-date credible information on the very disease they live with every day. Our hope is to share those stories while also teaching and raising awareness for chronic myeloid leukemia. Today, together more than ever, for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Cool. Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
It is CML Day, and today, together, more than ever, for a life without CML.
Hoy juntos más que nunca por una vida sin LMC.
اليوم معا أكثر من أي يوم مضى لحياة خالية من سرطان الدم المزمن.
Today, together, more than ever, for a life without CML, mabuhay.
Hari ini bersama-sama lebih dari sebelumnya untuk hidup tanpa CML.
Aujourd'hui, tous unis, tous uniques pour une vie sans LMC. Today, together, more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever
for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for life without CML.
Today, together, more than ever for life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for the life without chronic myeloid leukemia.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
Today, together, more than ever for a life without CML.
How has 2020 affected CML community? How can we work together for a life without CML? What's next for the CML community? The CML community recently came together to ask some of these questions. The following presentation was completed via online interviews and self-tape submissions from the CML community. We would like to thank those patients, advocates, and physicians who contributed to the voices of CML. Today, together more than ever for a life without CML.
The biggest challenge was, of course, the coronavirus. But fortunately, no CML patients have been diagnosed with COVID-19. I think that the Ministry of Health of Republic of Macedonia, having in the mind the specifics of our country, has responded relatively well to the challenge. Also, the Clinic for Hematology was well organized. They working only with urgent patients, and the chronically ill received 3 months of therapy, so as not to be at risk when they are made the regular check. A special challenge was in March 2020, when the Clinic for Hematology ran out of nilotinib, Tasigna medication, for about 20 patients. Normally, the main fault were bureaucratic procedures. During the period, our association had intensive meetings and correspondence with the Ministry of Health of the Republic of Macedonia and with the director of the clinic, and the problem has been solved directly from the director of the clinic and the Minister of the Health.
It's very difficult time in last half year or little more from Corona, when Corona started in the region, and all changed actually from our visiting to our doctors and daily living and everything. Actually, everything is different, and we are adapting. In daily situation, depend of the situation in the country and the rules of the government, what to do, what not to do. We are adapting on that and making it in that way, working that way. So previously we did go monthly to the doctor, 3 months taking the blood, etc. Now we just coming to the building of the hospital, and for stable patient, nurses bring medical to us outside to avoid any possible contact with the corona. But for non-critical patient, for critical patient and with non-stable results, they are still going inside, and with all how to say that, all measurement, following all measurement to protect himself and protecting the personnel in the hospital, and taking exam what is the necessary. We decrease all our contacts in our association, direct contacts, of course, contact with through the networks that is still active, and even more active than in previous time.
So I would like to start with some main points which I want to share and stress around CML in Slovenia. So I would like to say that we started with TKI treatment in Slovenia in 2002. And TKI are available for all patients in Slovenia from 2002. Now in the market in Slovenia, we have first, second, and third generation of TKI, and also generic imatinib and dasatinib. We have excellent specialized hematology laboratory working molecular diagnostic for all Slovenian patients. Results are fast and accurate. And all patients are monitored by trained hematologists, not from GPs. Of course, also we have possibility of stem cell transplantation for those rare patients who need it. And in Slovenia, we published Slovenian recommendations for diagnostic and treatment of CML 2008 and also 2018. And now, what are our challenges for 2020 and beyond? Our challenges now are safety, efficacy, and good quality of life for our patients. We always put together our decision, doctor and patient, which TKI to choose regarding toxicity profile, comorbidities, the aim of treatment. Now we work all together how to do the strategy to maximize the possibility of stopping TKI treatment to reach treatment-free remission. And also what is all the time our challenge, how to educate or really strong working on that education for young hematologists, GPs, and also patients and relatives. But maybe I would like to stress also that we are working together with the Slovenian Lymphoma and Leukemia Patient Association on the patient support program, comprehensive care for the patient with psychologist, physiotherapist, and nutritional specialist. This is altogether what I wanted to stress.
Especially because of the COVID time, and actually nobody knew what to do. So according to it, we tried to do the best crisis management ever for our patients. So we managed to work with our doctors and to find the best way to give them the medicines they needed on time, and to stop going to hospitals whenever we could do it. The biggest issue was the newly diagnosed patients, and that was a big challenge for us and for doctors and for everybody. So I can say that we have worked a lot. We learned a lot. We learned from the doctors learned from us. And I think that now in the middle of the 2020, we can say that we have managed to find a way to work in the crisis which struck not only Serbia, but the whole world. But maybe what was the best in Serbia is that we had so many experiences working in crisis till now that maybe it wasn't the biggest crisis we ever challenged. But I'm proud of the organization I'm working. I'm proud of the people who are working with me. I'm also proud of the doctors, and I'm proud of all the patients who were ready to help each other when they really needed it. So I can say that CML community in Serbia is very strong, and that we can speak about it as a big family. So that was the biggest challenge when I talk about Serbia. But when I talk about the region, then I can say that the region also helped each other to work through these crises and to find the best information we could provide to each other, and that we can learn from each other and the experiences with people who faced COVID and people how they managed to organize their own countries to work in these difficult times. So I can say that 2020 was really challenging, and I hope that we will not have more challenges which are different than COVID this year.
The challenges of this year were linked to the restrictions caused by the COVID pandemics. We had to postpone patient conferences scheduled for March and April until autumn, and we have now organized the first one in September, framed by the World Leukemia Day. Hopefully, we will have chance to organize also in October and November. Our major projects of this year was filming an interview with Dr. Zhachkova, principal investigator of an academic multicentric clinical trial called HAV, which the protocol leads to lowering the dose and potentially leading to treatment-free remission. The clinical trial has started enrolling recently. Our second project was linked to COVID more directly. We have asked the doctor to prepare a document based on research in literature and also experiences from her clinical practice. for the management of CML patients during the COVID period?
During this 2020 was very difficult for all the people, not only for patients with CML and patients with hematological malignancies due to COVID-19 pandemic. Patients and caregivers with CML during March and April were dealing with an opportunity to see their doctors or to reach to their treatment, since a lot of hospitals were closed due to this pandemic. So we had to postpone our face-to-face activities, and usually we were contacting with our patients and caregivers through online media or by phone or by email. But still people and the CML community and the patients with hematological malignancies got adapted very fast. And I think this will be our new future, depends on the COVID pandemic. So we will be forced to contact patients and caregivers through online media or by phone. It's a patient organization dealing with hematological malignancies and among them CML, the disease of CML. We are our country is in a situation where patients do not get the novel therapies for CML as the patients in Western Europe and other parts of the world. We would very like for 2021 or maybe for the next year, patients with CML to get the same treatment and the same access of novel therapy as the patients in the Western Europe and other developed countries. That is our main goal for our patient organization, besides other activities that we do. So we hope that in the near future that could be possible.
So the main challenge that patients with CML had in Romania was the same at the other patients at global level, the COVID-19, because they were scared to go to the hospital to do their treatment, but they were also afraid to stay home and not do the treatment. So that was the main challenge during 2020. And what we did, we tried, as a patient organization, we tried to adapt to the new situation and to support patients as much as possible, to advocate for home treatment for patients, but also to implement new solutions for advocacy, for training, and for organizing groups of patients. So we prepared an online platform for patients with rare disease in general, including CML patients.
Well, in 2020, we had challenges mainly connected to new coronavirus. Since in Slovenia, we are lucky that the basic challenges are actually overcome. So we are lucky to have access to all modern medical and other treatment for all CML patients in our country. And we also have very good network of specialists, of hematologists. And we are also lucky to have complete reimbursement for all our CML treatment. So we are now focusing on quality of life. Actually, we wish to improve the quality of life with our programs, which our Patients Association is conducting together with medical and other specialists. So we are mainly focusing on rehabilitation program, which has 3 modules. And these are nutrition and psychological support and physical exercising for our patients. And our challenge this year was coronavirus. So we were faced to go online with all that, with complete program, and fortunately we succeed. So in spring, we moved all our meetings with physiotherapists, with nutrition specialists, with psychological specialists, and also with hematological specialists. We moved that to our computer platform, to video conference system. And then, it started to function, and the patients were satisfied. As soon as I know, they were sitting actually or exercising in their homes, connecting to that screen. And then, fortunately, because of national precaution measures, the corona situations improved a lot in summer. So in summer, we went live again with all the programs. But now, when the autumn comes, the situation is again worse about corona, and so we are planning to go online again. At that moment, it will be necessary. So that's our main challenge this year. Another goal is to improve connection to our patients online, because situation about new coronavirus can be also present in next year, and we would like to be connected to our patients, to have touch with them. So we are preparing and already started to carry out the education programs for our patients, how to use teleconferencing, video conferencing systems.
I think the main challenge in 2020 remains COVID-19 and the associated quarantine. We urgently had to change the traditional format of the regional schools for patients with CML and other hematological malignancies also. So we organized our regional school in more than 15 territories of our big country in the online format. These online schools were a great success. As they say, a blessing in disguise. It was a new successful experience which can be used in our future work as an additional option for the living meeting with CML patients in different regions of our country.
Well, first of all, we have to hope the epidemiologic situation will improve, because indeed with having the focus on empowering patients, that's very difficult to be done in the virtual world. And the connection among patient organization also is based on maximum of communication, and hopefully we will have an opportunity to have our meetings and conferences as we have had for many years before, since the CML Advocates Network was established in 2007 and I was one of the co-founders.
The main goal for 2021 is a modern, appropriate treatment for CML patients. Normally, this means that all 3 generations of TKI will be on the positive drug list. For each patient with CML, a mutation analysis should be performed on the basis of which the therapy is prescribed, and the appropriate medicine will be given according to the needs of the patients and not according to the availability of the clinic. Normally, it means a timely supply of drugs by the clinic of hematology without stress to the patients?
Regarding the goals in CML in Serbia, I would say that our biggest goal is to bring back PCR in all the institutions where CML is treated, which means that we have regular PCR tests, which we do not have at the moment. And we are strongly fighting for these PCR tests to be paid by the government and not to be the issue for the CML patients anymore. That's our first and most important goal for 2021. The second one is, of course, to have regular access to the therapists, and I hope that we will have more therapists available in Serbia, which are not just imatinib and nilotinib. And I hope that I will manage to finish the donations I have for ponatinib for 2 patients and to save these 2 lives. So it's about Serbia. Regarding the region, my biggest goal is to work very strongly and to provide as much therapies available in as much countries I'm working in. So first, I would love to see new therapies in Kosovo, and these patients there, they have the regular access to the therapies. I would love to see it in Macedonia. I would love to see it in other countries like Azerbaijan and so on. So still, East Europe goal is to have the access to the therapists. And then if I speak globally, of course, my goal is like all other parts of the world, especially Western Europe and the US, I would like to see the cure.
Our challenges for 2021 are focused on 2 things mainly. One is to improve access to our programs for our patients so that we would offer live the programs for our patients in all regions of Slovenia. Slovenia is a small country, but nevertheless, we have a lot of elderly patients who have problems to sit in their car and, let's say, drive 100 kilometers. That's our reality, because some patients would be very much more comfortable, or it would be more accessible for them if they had our programs near their home. So at the moment, majority of our programs are being carried out in Ljubljana, that's our capital, and in few other towns, let's say in Maribor, second biggest place, town, and Nova Gorica. Now we wish to cover more regions, so to come closer to our patients. That is one of our goals.
For 2021, our organizations intend to work very devoted to a national plan for cancer and to include the needs of the patients with CML into this national plan for cancer. For the moment, we are adapting and updating our national plan for rare disease and including the needs of patients with rare cancer into the national plan for rare disease. But we will integrate the needs of patients with CML into the national plan for cancer. That's our main goal for the 2021.
This is a current issue everywhere in the world and also here in Macedonia. We have several patients who are in the TFR phase. They have a regular monthly check, and so far everything is okay. I hope that this trend will continue and that the remaining patients in the Republic of Macedonia who meet the requirements for TFR will stop taking TKI drugs. Of course, with regular monthly checkups and supervision of our doctors.
We want to put more patients to treatment-free remission, to treat more patients very safely, with a good quality of life. We want that our patients with chronic myeloid leukemia can live normal life, can work if they want, can be together with their family, can have families, can have really good quality of life. And of course, for that kind of patient, treatment with TKI or stem cell transplantation or chemo, what they need, is not the only thing they need. They need also support, because if you have such kind of disease, like leukemia is, they need support from psychologists. They need support from physiotherapists, from nutritional therapists, because what I can see in my everyday work is that many people don't know how to live normal life. And this is not just for the patient, it means also for a lot of healthy people around us.
In 2021, we hope for strengthening the role of the patient society due to new healthcare legislation, which is now in the process. As a member of the Patient Advisory Board of the Health Ministry, we have also contributed to drafting the definition of a patient organization, which should be incorporated in the legislation.
Russia has a unique federal program to health nosology, which patients, including chronic myeloid leukemia, receiving imatinib, the generic of Glivec, for free. And one of our most important goals is to include the second and third line of CML therapy, such as nilotinib, dasatinib, and others, in this national program. And PCR molecular studies of blood and also bone marrow CML patients in our country pass free from the fund of obligatory insurance in some region of Russia. We want to extend this successful experience also in other regions where this is not yet.
Well, from our side of view, and I suppose on global level, the most important issues for the CML community, CML patients, to have proper access to novel treatments, because usually patients are afraid when they get diagnosed with a type of cancer as CML is. Though CML is a chronic disease which is treatable, so the patients should not be afraid of the diagnosis. But I think the basic stuff on a global issue is patients from CML to get a proper treatment and access to novel therapies. We need a better communication with the healthcare institutions, since here in Macedonia it all depends on politics, depends on which government will be from which party.
I think we should work together to make possible that the new therapies and treatments to be available to all the patients with CML in the world, and including the new kind of treatments that are in clinical trials now, like gene therapies, and to fight together for a better policy to integrate patients with CML into the society, and to make them have a full life. We should work together to develop policies that ensure access to a normal life for patients, and to look more closely to the problems that they have now, because patients, more and more patients are cured for a long period of time, but they are not always integrated into society. So to prepare policies, social policies and medical policies to support their reintegration into society, it's the major objective for us, and also to ensure the equal access to treatment for patients with CML, to the new therapies, to the new treatments, and to answer to their needs, to organize advocacy campaigns, and to work together for these policies. But in order to do this, we need funds to create awareness campaigns and to train patients for advocacy, to be better, to represent better themselves, and to make contacts with journalists, with policy makers, and to all the stakeholders involved in this. So we need financial support to ensure these activities are implemented.
What is very important is that they have their own hematologist whom they believe, and that the treatment is safety, the treatment is efficacious, and that they can live a normal quality of life. I think that, and also that survival is practically the same like in the healthy population.
Give more information about leukemia, about rights of patients. That's why we try to organize different schools in different regions in our country. We must to be together and fight against CML.
Well, for sure, the patient organizations around the world are aware of the disparities ongoing in certain regions. There are huge differences. So trying to smoothen these disparities and somehow provide better access to CML patients is the next goal step. But for the future, we would wish to hope really for the cure of CML.
In my opinion, the CML international community must continue to fight for equal access to all type of therapy in different countries. And organization protecting the rights of patients suffering from oncological and hematological malignancies in their country need to create national program on medicinal maintenance of patients in need of expensive treatment.
What we shall all focus on, I think, maybe not next step, but bright future for us CML patients would be treatment-free remission for all CML patients. I think there is a lot of work for specialists ahead to reach that goal, but I believe it is possible, and I believe that all efforts could bring this to reality, that we receive treatment-free remission for lifelong. That's one thing. But there are still a lot of steps which should be done in a direction that every patient in the world, every CML patient would have access to treatment, to a very good treatment with which we who are lucky to get that treatment, we can live, we can work, we can enjoy, we can be with our families, we can exercise, we can climb mountains, we can sail, we can be happy with our children, grandchildren, some of us also, parents, friends, and that is not reality to the whole world. In a lot of countries, it is still a dream. So I think we should help the global community that we all come to that same level to have treatment. For reaching that goal, that our patients will be able to use modern technology to connect online, mainly because of coronavirus and also because of regional or physical distance questions. What do we need more? So,
to give my support to all the CML patients that are handling with this disease, and also to their caregivers, and to tell them that CML is a curable disease, and that they should not be afraid when they will be diagnosed with this type of disease, because with the medicine today and going forward, CML is a treatable disease, and patient can have a good quality of life as other patients that do not have this disease.
The most important goal globally is, of course, and always will be the cure. We have very happy situations with the countries where PFR is available, and where these patients attending PFR can be regularly tested and can be followed up and monitored by their doctors. Unfortunately, this is not the reality in Eastern Europe, Asia, Africa, and Latin America. So we cannot be selfish and say that the only goal is cure. The other goal is, of course, to have a regular access and regular monitoring for all the CML patients. So me coming from the Eastern Europe, I'm always fighting for the cure, but I'm always fighting for access. And they know me for that, and they're always joking with me about that, but I still stand to my stand, and I say access first, and then cure and PFR, because we don't need to lose people because of no access. And then together we can work towards cure. And these two goals do not interfere with each other. They need to work together, and we need to work together on both of them.
Hello to everyone. My name is Pepo Levi, and I am president of CML Macedonian Association. In 2007, I was diagnosed with leukemia. In that period, CML Macedonia was not existing. There were no appropriate drugs and therapy for this disease. For that reason, together with the rest of the patients, at the time we established the Macedonian CML Association and started our battle. For these 13 years of our existence, we had many TV appearances, participated in many TV debates, we had press conferences, interviews, and numerous campaigns. All of this was in the function of animating the Macedonian public and making pressure on those responsible in the government of the Republic of Macedonia to provide appropriate medicine which mean life for the patients with CML. After much efforts, with the help of doctors from the Clinic of Hematology, we managed in 2011 to put imatinib on the positive list, and in 2017, through the Ministry of Health, we also managed to provide nilotinib, which since 2018 has been in a regular therapy for a certain number of the CML patients. Through the Max Foundation, Ms. Pat Gonzalez helped us a lot. We provided a donation from Bristol Myers Squibb of dasatinib for one patient, and the Clinic for the Hematology provided a donation of ponatinib for another patient. This does not mean that everything goes easy and without any problems. However, our association, CML Macedonia, is here and always reacted appropriately when is needed. In any case, 22 September, the World CML Day is very important for CML patients and day when we should tell CML patient that we are here and he is also our large global family, CML Advocates Network, which give us great support in our efforts to find a solution for appropriate treatment and availability of adequate medicine for CML patients. Once again, best regards to all members of CML Macedonia and all members of CML Advocates Network. And remember, today together we are stronger more than ever for a life without CML.
We need patient society support because it is politically stronger.
I have been working in CML for more than 10 years. I'm coming from a country which is in East Europe, and I was leading the East Europe region for more than, I think, 6 or 7 years, officially or unofficially. East Europe region is very specific because of its diversity, meaning that we have many countries which are part of EU, which are actually, let's say, West Europe, and they work and operate as West Europe countries. And we have many countries coming from ex-Yugoslav countries and ex-Russia countries, which are working in their own way, representing the real East Europe. This diversity means that I have learned that there are many things which are the same, but there are also many things which are different. So my advice for the whole community is to try to find some organization in some other part of the world which is facing the same issue as you are. Be open, write to the community, write to the regional leaders, not only of your region, but for other regions, because the biggest and the strongest thing that we have in this global community is learning from each other. If we face in East Europe some issue, we can be sure that somebody else has faced it in the West Europe in like 10 years ago. But in Africa, if you're facing an issue, you must be sure that somebody has faced the same issue in East Europe. So let's learn from each other and let's be open and not afraid to ask for help. And again, I really believe that the matter of the CML Horizons is something we should all stop. Be open, ask, let's learn, share, and grow together.
Well, I think it's always very important that the patients who have a long patient journey behind them, like me, I'm 18 years on treatment, they can somehow show the newly diagnosed some positive examples, how to cope with the chronic condition, and even how to cope with sometimes difficult situations. So this is an ongoing role all the time. Newly diagnosed patients are entering the society, and we should somehow take care of them, tutor them, and prepare them for living a good life, but in chronic condition.
I hope that in the future the politics will not get involved in health, because health is one of the healthcare system is one of the most important healthcare systems in every state. Also, our Macedonia country is a very poor country and needs a lot of funding and a bigger budget for access to novel therapies. I hope that in the near future our budget will be bigger to get to the patients the novel treatment that is available in Western Europe.
I think that the CML Advocates Network should continue to take care of the problem related to CML around the world, especially focusing on the CML patients from less developed countries. I welcome the commitment and the work done so far by the CML Advocacy Network, which has so far achieved great results. I hope that we will have future successful cooperation and support, especially now that we have a new challenge in COVID-19. In fact, our motto is, together we are stronger.
TKI, it means tyrosine kinase inhibitors. These are main drugs for chronic myeloid leukemia patients. The first one is imatinib Gleevec from Novartis company, which came to the market in 1998 for patients who were treated in some studies, but for the whole society of CML patients, it came to the market from 2002 to 2004 in Europe. After some years, also second generation TKI came to the market. And what is very important from this point is that some patients don't work well in first generation TKI, and some of them, because of that, need a second generation and also third generation. And if nothing is working, then some patients need stem cell transplantation. It means that they need chemotherapy and then stem cell support to renew bone marrow and to completely destroy chronic myeloid leukemia in the patient body. Treatment-free remission. Treatment-free remission, it means that some patients, we don't know exactly which group of patients are those, but some of them, about half of them, have possibility to finish treatment after 5 or more years of successful treatment with TKI. But it doesn't mean that those patients doesn't or don't need any more hematologist. They need hematologist for the whole life, also in the future, because we never know in which patients or when the chronic myeloid leukemia can come again, can be in the bone marrow and in the body again. And so we need to check those patients each 6 months, or for the start each month, and then for the whole life to see if CML is again in the body, or they are still very good and healthy.
Я съм Глеб Калараш. 22 септември е ден на подигнуване свеста хронична меланична лейкемия. Давам поддержку на новые лица.
Welcome to Voice of CML. Shortly, you will hear from some of our members at CML Advocates Network. A few years ago, we started with only a few countries, but since then we have grown. We have 126 patient organizations in over 93 countries around the world. Every year, on the 22nd of September, we come together to raise awareness for the CML community. Unfortunately, 2020 has presented us with many new challenges. However, we continue to adapt. In this six-part live stream, we hope to give all those around the world the opportunity to come together and share their stories using the digital space. Today, many CML patients do not have access to life-saving treatment. Many CML patients do not have access to doctors. Many CML patients do not have up-to-date credible information on the very disease they live with every day. Our hope is to share those stories while also teaching and raising awareness for chronic myeloid leukemia. Today, together more than ever, for a life without CML.
Today, together more than ever, for a life without CML.
Today, together more than ever, for a life without CML.
Cool. Today, together more than ever, for a life without CML.
Today, together more than ever, for a life without CML.
Today, together more than ever, for a life without CML.
It is CML Day, and today, together more than ever, for a life without CML.
Hoy juntos más que nunca por una vida sin LMC.
اليوم معا أكثر من أي يوم مضى لحياة خالية من سرطان الدم المزمن.
Today, together, more than ever, for a life without CML, mabuhay.
Hari ini bersama-sama lebih dari sebelumnya untuk hidup tanpa CML.
Aujourd'hui, tous unis, tous uniques, pour une vie sans LMC. Today, together, more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever
for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for life without CML.
Today, together more than ever for life without CML.
Today together, more than ever for a life without CML.
Today, together, more than ever, for the life without chronic myeloid leukemia.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Welcome to Voice of CML. Shortly,
Hello, everybody, and welcome to Voices of CML with our African CML community. Today, we are going all over the world with this event. We started in Asia Pacific early this morning, and we moved on to Central and Eastern Europe with West Asia. And now we're really thrilled to join our patient leaders from Africa. Today is a very special day for us. You know, it's our World CML Day, and normally we would probably meet face to face at events in our different countries, but because of the circumstances, that's not always possible this year. But we're going to be together and have a few moments together and talk about what's going on, how things this year has affected us, and maybe how the CML Advocates Network can also help you in your work. I'm really very honored also to have with us leading this call today Mrs. Bahija Gouimi from Morocco, the president of the Amal Association in Morocco, and also representative of the region at the level of the steering committee of CML Advocates Network. Bahija, please, the floor is yours to allow you to introduce all your great colleagues. Thank you.
Thank you, Denise. Thank you to our CEO of CML Advocate Network. Thanks, Lydia and Celia, for joining us. I'm very, very glad to see you all faces of Middle East and Africa region. Good afternoon, and I would like to welcome you and thank you for joining us today in our Middle East and Africa region. Marhaban bikum, bienvenue. Welcome. Today, Tuesday, 22 September, is a big day, a special day for all CML patients. Many of us are patients or caregivers. And my name is Bahija Gouimi. Many of you called me Mama Africa, and it's make me very proud because you all are in my heart, and I try to do my best to represent well my region. I am running a CML patient group in Morocco called Amal, and of course I am your representative to the steering committee of CML Advocate Network. Personally, I have been living with CML for more than 18 years. At that time, CML was a dangerous disease, no treatment, but fortunately today, we have 4 generations of treatment and we have almost a normal life. Today is the World CML Day, and every 20 September, the CML Advocate Network leads to the CML World Day, a global awareness campaign, including our region also, because we represent 23 organizations of the CML Advocate Network. Today, we celebrate the World CML Day. The chronic myeloid leukemia patients across the globe come together to raise awareness about the needs of CML patients. Today, we are celebrating the World CML Day under the motto, today, together, more than ever for a life without CML. I have with me leaders from Middle East and Africa region who will speak about different topics. And I will be moderate this session and ask our speaker to present their topic and themselves and to answer to the following question. Our first speaker is my friend Trevor Stein from South Africa. Trevor is the president of CML South Africa. And Trevor, you are a CML patient for more than 31 years. And my question, can you talk about your CML journey and how CML has changed your life? The floor is yours, Trevor, please.
Hello, Bahia. Hi, Dennis, and everybody else. Very, very good to be with you on this very special day as we celebrate World CML Day. Yes, my journey on the 28th of September this year, it would be 31 years that I have been diagnosed with CML. And when I was first diagnosed, I was told that at that point, the average lifespan for CML patients was 5 years. And so I was a younger man then, married to a young girl and had a baby of less than a year old. It was devastating news when I was told that I have not more than 5 years to live. And so at that point, the only treatment was the hydroxyurea. And so I began to work out how do I best organize my life, having known now that it was going to be such a short life. It was very difficult because there was also a lot of stigma attached to the problem of CML. And it was a very difficult journey because you almost have to journey all by yourself. Lucky for me, I had the full support of my family, but it was difficult to tell other people because you didn't want people to feel overtly sorry for you, because you wanted them to treat you as a normal human being and not all the time feel sorry for you. But at the same time, if you had told them, it was difficult for them to remain friends with you. So it was very, very difficult. So over the many years, I just continued to live my life as normal as possible, and to a great degree of thanks to the medical fraternity and the pharmaceutical fraternity for having developed different technologies to help manage our disease. Today, we can clearly say to people the disease of CML is not a death sentence. It is, in fact, very much a disease that if you have access to all the care, then it is a disease that can be well managed. But we do know that there are still people who die of CML, and many of them die as a result of them not being able to get access to PCR testing and all the other things that go with it. So yes, it is a very difficult disease if you don't have access. This has been a very difficult year, this COVID-19 year, because many of our patients, they found themselves all of a sudden without a job. They found themselves with without the resources. The journey is alone. You cannot go into the hospitals. You cannot, when you go into hospital, you have to go alone. Your support system can't go with you. And so as an organization, we had to embrace our people and try and help as far as we can. But you know, the most important thing for us is that we continue to say to our patients, keep the faith, keep being strong, and do the right thing. Make sure you take your medication on a daily basis. Do not skip it and so on. So it's been very difficult for me, for instance, when I had young children, I tried to get some insurance cover for them, especially since I was never sure when I was going to die. And no insurance company wanted to cover me because they said you had a dreaded disease. They also did not want to, if they were prepared to cover you, they were going to load it substantially to the point where it was almost impossible. And so 31 years later, I say to those companies, you know, here I am to tell the story. Where are you? So yeah, it's been a very difficult journey, often at times a very lonely journey. But as a person of faith, I also thank God that here I am today to tell the story, and I go out of my way to do whatever I can to help patients, not just in South Africa, but in Southern Africa and across the region. Wherever we can, we help, because we've been through it. We may be able to help others so that they don't have to make the same mistakes and the same challenges that we have. We can make their life easier. And that's my commitment to this CML journey. And I'm very grateful to the many people, especially the Max Foundation and others, who so wonderfully got alongside us. The CML Advocates Network, what a wonderful network of organizations who support each other and make this journey for all of us much easier. So thank you very much. And I suppose I have to say to all my patient colleagues on this network to say to you, happy World CML Day.
Thank you very much. What's an inspiring story, and thank you, Trevor, for sharing with us your personal story. Very proud of you and very proud of your CML patient journey. Thank you, Trevor, again. And our next speaker is a passionate advocate, Elo Mapelo, the president of Henzo Kenya. As you all know, COVID-19 is a general challenge for each organization. How you manage, Mapelo, your advocacy work in this pandemic? The floor is yours, Mapelo.
Thank you, Mama Africa. Thank you so much. And I would like to begin by saying happy CML Day. I think we don't have very many cancer groups that begin their greetings with happy CML Day like ours. But it's because there's every reason for us to be happy and there's every reason for us to celebrate. Before I respond to your question, Mama Africa, allow me to first say that it is a great honor to be here. It is a great honor for CML Advocates Network to put together this meeting. Thank you so much, Denise Costello and your team. We are very grateful for this. We had our own version of celebration here in Kenya, and there is a lot of celebration. There is a lot of joy going around, and we did it like the good Kenyans we are. I will be sharing a little bit of what we did later on in video. Trevor has never been to Kenya, but he can tell you Kenyans know how to celebrate. and I believe it's true to many Africans. There can't be a complete celebration without a cake and a dance. We did that earlier today. I'll be sharing that later on. But just to look at what Mama Africa asked, COVID-19 has really brought a situation in this, actually in the whole world, that is not known to anybody. I mean, nobody was ready for this. Nobody had a playbook to read from on how to carry out advocacy work in such a situation. And in Kenya, which I believe is true to many countries, we saw a lot of resources being directed towards COVID-19. Every kind of resource, be it financial, be it a human resource, was all focused towards COVID-19. We had a whole national agenda shifting towards looking at what COVID-19 has brought along with, and it has not been easy in the last few months to engage our partners, to engage our friends, to engage the people that we work with in advocacy, because everything was focusing on the COVID-19 situation. We had also restrictions, closures of businesses, closures of offices, closures, and of course restrictions to traveling, restrictions.
Hello?
Sorry about that.
We lose you. Yeah. Okay.
Yeah, but I'm back.
Go
now.
ahead. Go ahead.
Yes.
Go ahead.
Yes.
Yeah. Go ahead.
All right. So we were faced with an unprecedented kind of challenge as far as COVID-19 is concerned. But as we were discussing in our meeting today, we were able to bring together all our partners that we work with in our various areas of advocacy.
Yes. Mapelo?
Sorry.
Sorry.
I'm afraid,
yeah.
yeah,
You finished? Yeah.
So
Please.
Some calls are coming through. But just one last statement. I just want to say that we have been able to try and see how to put everybody back again together. We are looking like we are coming to the end of these extra focus towards COVID. I'm not saying in any way that we are coming to the end of COVID, but at least there is a little bit of focus now into what was currently in the forefront of government agendas. We have had that challenge with advocacy, but now we are able to get back to the work that we've been doing, getting back to talking to the ministries of health, getting back to talking to partners, and trying to put together everybody back to the conversation that we had of cancer and of course of CML. But those were 6-7 months of some sort of darkness, I could say. I don't know if it is a case in other countries in Africa and in other countries in the world, but I believe it is. It actually came to the shelf quite a number of our activities, including, of course, not being able to put together our annual May pilgrimage that we plan to do as CML advocates across the world. So, Mama Africa, thank you. If there's any other things that you'd like me to respond to, I'm at your disposal. Thank you.
Thank you, Mapelo. Thank you for sharing your thought with us. And it's true that's all challenges that we have faced in 2020 are mainly affected and linked to the pandemic, to COVID-19. Thank you for sharing with us your thoughts, Mapelo, and good luck for your advocacy work. Our next speaker is a parent, the father of a beautiful lady, Zaina. Zaina is a young girl, CML patient from Palestine, who attended with us, I think, CML Horizon 2017. Right, Jamal?
Yes.
Hello, Jamal.
Yes.
Yes. She attended with us, and she is full of life and hope. And Jamal Hourani is the president of CML Palestine. And my question to Jamal, as a parent, you faced every day, with your daughter, the procedure, administrative and medical procedure in Arab country is not easy. And can you please share with us and explain the challenges faced by the Arab CML patient in terms of access and monitoring in the region? The floor is
thank
yours.
You, thank you very much, Bahija, and everybody. It's actually my pleasure to be attending this webinar. And I will start by building on Trevor's journey. Actually, he's an inspirer and he's a great guy like everybody, but I can say that he's our sheikh, he's our president.
Yeah.
Yes, and he inspires us a lot all the time. The same as everybody, Bahija as a woman and everybody. So to talk about the ability, the access to treatment, it is not only access to treatment, it's access to drug, and it's access to the medical treatment, including the drugs and the laboratories and the doctors, and dealing with the community. As you know, we have 4 pillars. The first pillar is the patient and his family themselves, and we have the doctors, we have the government, and we have the society. So in the Arab world, we have a lot of complications where the government is responsible for providing the drugs and the medication, control the doctors to the cancer patients, where the CML is treated as one of the cancer issues. So having a doctor who's knowledgeable, who has the experience, is an issue. And after the diagnostics and reaching to the right diagnosis, we have the ability to get the drug. You know, the drug was very expensive, and the new drugs now are too expensive too. It was a blessing from God. We have the generics now that are in the market, where we are now able to convince our governments to provide the drugs on a permanent way. Our patients until today, like in Iraq, like in Lebanon, the same way in Palestine, we have a lot of complications getting the drug, which is provided by the government. We have some help sometimes from foundations like Max, but many patients in different Arab countries cannot get their bills on daily basis. Sometimes they skip, sometimes they have to skip because they don't have the drug that is enough for them. So this is one of the challenges in the Arab world, which is the access to the drugs, the access to treatment. The second thing is the challenges for the control. And the control, we need laboratories, and we need to have the required accessories so that we can do the testing. This is also is making us sometimes late in reaching the TFR, because so as to reach the TFR, you need laboratories and you need the testing equipment that enables you to check for 4.5. And I think most of the Arab laboratories available in the Arab world are now at max of 3. And this is preventing many CML patients to get themselves ready to reach the TFR level.
Hello, Jamal.
So
Jamal,
we are trying hard.
Jamal, we lost you. Can you repeat the last sentence, please?
Okay, so what I'm saying is that because of the lack of the testing equipment that is suitable for the treatment-free remission level, many Arab patients are not able to start the TFR with their doctors. So this is another challenge for the Arab patients in the Arab area. We're trying hard to push for that, and we're trying to convince our governments that this is for the benefit of everybody, for the patient to be without medicine, for the government to save some cost on providing the drugs and sparing that drug to the new entrants who are entering as CML patients, and for the family and everybody to be in a better life. So these are the challenges. Actually, we try to support each other. We try to help each other using our different experience in working together. Everyone has his own success story in his own society. And so we share it together as Arab CML leaders. We try to benefit, and it is of benefit actually. We try to help each other by sometimes speaking about the drugs that are used differently. We use different generics in different countries. So when there is a generic that is introduced in a country, we ask each other, and we can bring the information that this is a good generic, this is not good generic, and about the testing. So the journey is not easy to describe. Being a father is something else. I know that the patient has his own feelings, but also the parents and the caregivers have their own feelings. If sometimes, it's not sometimes, all the time, if we pray to God that I would be more happier if I am the patient and not here. But this is what happened actually. For the CML Advocates Network, it gives us a great information, a great networking abilities. It gives us a great network so that we can communicate together, we can contact each other, we can ask each other, we can help each other, and we can support each other. I'd like to take this opportunity to say that I pray to God that the next CML day will be the next TFR day, where all the patients are in free remission, and even to be in a better more if we have a drug that cures this disease and not only control it. I wish everybody a happy CML day, every patient, every caregiver, and I hope that we enjoy it and we enjoy it more in the coming days with a better news. Thank you very much.
Inshallah.
Thank you, Jamal, for your participation. And you are right, we need more work together. We need to be united to share best practice in the region and to improve, treatment access and monitoring also. Thank you for sharing your story, and the best regard to Zaina and your family in Palestine. Our next topic is a topic, a very important topic, is about women. And I have with me a great woman. She is the CAB members, and she is also the president of MaxCare Nigeria, my dear Eunice Oreka. She will talk about CML and women in Africa. The floor is yours, my dear.
Thank you, Bahija, and thank you everyone for joining in. This is a big topic for me, and I guess it's a good topic because I can use myself as an example. CML and women, generally in Africa, women's challenges are enormous. So we live in a society where it's more patriarchal because the men are the ones in charge. And so when a woman has a challenge, sometimes it's almost like it's easy to a woman is almost easy to dispose of. Now, when you have a CML, as it were here, and because there's limited information, it's not that the information is not available. It's just that people just choose, you just hear leukemia. So when you hear leukemia, that's like a death sentence. And so a woman is told that you have leukemia, and she probably has a marriage proposal, and the man hears that, and then the family members tell her, how do you want to marry a lady who has leukemia? She will die soon. So of course that marriage proposal is dead on arrival. And that's one of the main challenges women face. Women usually are the ones who are the child bearer in society. And so a woman generally knows that once she's married, she wants to have a child. You can imagine if a woman who is married and is trying to conceive now hears that she has CML. I'll use myself as an example. When I was diagnosed, it was devastating because at the time, I knew leukemia meant something that could be terminal. And so doing research and finding out eventually that I could use a drug, and over time I would get better, it was simply amazing. And so it gave a lease to life, but not everybody knows that. Unfortunately, in some parts, because we have people coming from different parts, many people sometimes don't even know that there's a drug to take. So because of the way the symptoms of CML are, you lose weight, you're sick, you're sickly, so it's almost regarded as you are dying. And so sometimes before they even get treatment, sometimes it comes very late. And even when they get treatment, sometimes if you're single, many times you don't want to disclose. That's the truth. I have met patients who their family members, some of them don't even know they are sick because there's that stigma. Unfortunately, we still have that stigma in Africa. So you don't want to disclose because, like Trevor was saying, sometimes you don't want people to feel sorry for you. And then in some cases, if people are aware that you have a disease that they actually turn it terminal, you could lose your job. And so people prefer non-disclosure, especially women. You just not disclose. There's no point letting anybody know. I'm doing well, I'm taking my drugs, that's fine. It's one of the challenges we also face in the patient group. Many times, like I run the patient group and we run an online platform to be able to provide support for one another. Sometimes people just want to stay in the patient group and be silent. They don't want to disclose them. You really can't bother them. You just make sure that they get the right information because the information is power. Another thing we also face is fertility issues. So many people feel, if I have this disease, I don't have children. Now, we try as much as possible to ensure that we inform them, but people are the way they are. Sometimes when they want to get pregnant, they will not tell the doctors. They will just stop taking their drugs. They do get pregnant eventually, but they are now sick. So what we do every CML day, we're going to have like a forum later today, and then tomorrow, we always invite the doctor so that they can inform the patient. If you want to get pregnant, if you have issues, both male and female, please come to the doctors. Let them speak to you. Let them advise you. Like I said, I always use myself as an example. When I was diagnosed, I was just the mother of a 2-year-old son at the time. And of course, I wanted to have more children. But I didn't know what the chances for me were. But unfortunately for me, I had good doctors. And incidentally, where I was the GPAP center. And so I had the wealth of information. And it was new to them, but the doctors guided me. And I have a daughter today, and she's going to be 13 in November. And so this is my journey, 16 years. And so it's really about empowerment. And that's one of the things we really want to do, to empower. Because if we empower them, then many of the choices that the women make, fortunately, that harm them, they won't do. Another thing we also face as women is, you know, when you have a disease that people don't really know what to do, they give you all sorts of advice. So we call these old wives' tales. They tell you, if you mix this with this and take this, then this will work. But then you also have the challenge of drug interactions. And so those are the other things we face. So in addition to the fact that people won't disclose, when they do disclose, then of course you get wrong advice. And so what we always try to do is empower. We feel that once you empower the women and tell them, this is what you must do, this is how you should do it, then eventually there is lead to life. But there's hope, because we are very happy, we are very lucky. We thank the pharma companies, we thank the Mass Foundation, because in Nigeria, many of the patients are on they get access to the drugs through the Mass Foundation. And it's really very helpful for us, because we have a lot of women who have a new lease to life. Apart from me, I have several other cases who have had children consequently. So the message out there is no longer a death sentence. And like I also allude to what my fellow advocates in Arab said, we need to get to a point where TFR is also available to us. Because many people qualify for TFR. It's just that, you know, because there's even much access to monitoring, it's a bit difficult, but that's where we're heading. And we trust that once we can overcome that barrier of TFR, then eventually we will get a cure. Because that is what we advocate for this season, that more than ever, we will live a life without TFR.
Thank you very much, Eunice. I can hear passion in your voice. Thank you for this. I know it's a big topic. We don't have enough time to discuss all things about, you know, stigma, education of women in Africa, and also how people, they make pressure, you know, to women about pregnancy, and the pregnancy with CML is it should be managed and discussed with the doctor. Thank you for sharing with us your thoughts, and thank you for your participation. Last but not least, another topic, very interesting. As Jamal said, we are here to talk. I tried when I was preparing the agenda to, you know, to touch to everything, to every topic in the region, and the caregiver are very big and interesting, you know, pieces of the puzzle. And Alioune Boukhari, he is here with us, and thank you for hearing to joining us. He is the president of Association de lutte contre les leucémies, as a CML patient group in Niger, and a very interesting topic, as I said, to all CML patients, the role of caregivers. Can you talk about the role of caregivers in CML care, dear Alioune? The floor is yours. Can you turn your we can hear you. Can you, Denise, can you maybe assist me? Yeah, about
Alioune, can you
animate? Yeah,
voilà.
a second. It's okay. Voilà. Yeah.
Okay, thank you. Hello, dear participant. Thank you very much, Mama Africa. Let me introduce myself. I'm just to try to speak English because I'm not speaking very well. Et je
No,
me débrouille un peu.
no,
J'espère
no,
que
Alioune. Your
oui.
English is perfect. Go ahead. If you don't
C'est vrai
find
que-
a word, ask and we will help you, me or Dennis.
Alioune, you need to
Alioune,
unmute yourself again, please.
yeah.
Now
Yes,
it's okay?
It's
perfect.
okay, yeah.
Okay. I'm the president of the Association for the Fight Against Leukemia in Niger. I'm very motivated to participate in this video conference on this day, September 22, dedicated to World Leukemia Day. So good every day. Good day, everyone. So good day, everyone. Living with a sick person, supporting them and accompanying them over a long period is very trying, both physically and psychologically. The term clause refers to any person around the sick person who has a positive link with them, whatever the nature, friendship, affection, love, etc. Or their degree of kinship. What is important is first their perception and understanding of events. Then it is possible to adapt. To adapt to the situation, it is essential to trust yourself and learn to listen to your intuition. Inform yourself in order to help the patient. Do research the better, understand the disease, its treatment, and especially their side effect. Always provide moral support to the patient. Moral support to the patient. Also, be sure to take medication. Provide all hope to the patient during the treatment, a favorable environment, a holy and cleaning environment. Relatives can also benefit from moral or psychological support. A doctor can prescribe medication if needed, antidepressant or others. A psychologist and can listen to them. People around them sometimes need a break. Sharing role is not always easy or possible. Anytime relatives can approach support group. In support groups, relatives can express their anxiety, discomfort, guilt, or angers, and share them with people who are going through the same things. They allow them to come out of their isolation and the universe of the disease of which they may feel trapped, and help them to reestablish the dialogue with the patient when he has been interrupted. All relatives of sick people, spouse, companion, brother, sister, can participate in discussion are most often done with the help of a psychologist. In the end, I wish a good leukemia day to all living leukemia patients, and every special trophy to those who are hospitalized. Thank you all. Thank you very much. This is the memo who I tell for us for this day or this leukemia day. Thank you very much. Merci.
Thank you very much, dear Alioune, for your participation. I know that you make a lot of energy, a lot of effort to speak in English, and you are brave, and then you are a good example for other people speaking only French. Me, myself, I start speaking only French and Arabic, and you know, when you practice your language, you can become a good speaker, a good you know, advocates
Thank you.
also, because internationally, globally, we talk only English. Thank you very much, dear
Very much.
Alioune. I remember, you know, we are talking about caregiver, and Jamal also talk about the feeling of caregivers. I remember I read a book, a French book about the others. The others means the other touched by cancer, because no one talk about the other, the caregiver and the relatives, and maybe we forget their suffering, and we underestimate their feelings also. Maybe we should, for example, make some activity for the caregivers also, because they need to talk, they need the psychological support, and we are here for hope. That's why we start by the energy and the good story of hope of Trevor, 31 years of CML, and he is still with us. As Jamal said, he is our president, he is our king. We can call you, I am Mama Africa, you are King Africa, and Your Majesty, you deserve all happiness and love, and I am very happy and to see you all. We have Lorita. If you allow me, I will give 1 minute to Lorita, because she is here and she is very, very good advocate, and we will give her to speak about something today together, more than ever, for a life without CML. Lorita, how can you say about this motto and your feeling in this day? The floor is yours.
Thank you so much for having me. I really appreciate it. We had a recorded program earlier. I don't know if that is going to be viewed, but it is so wonderful to belong to this African association, because before it was when we were associated with the European association, it was really difficult because they couldn't understand our African problems. We are not unique with our problems in Africa. We share them together, and we are so grateful to be able to be part of CML Africa. Thank you so much for this wonderful CML day today of today together. More than ever, we will be able to get rid of this CML one day.
Thank you, thank you. Thank you, Loretta. Thank you to all our speakers and our guests and all who joined us today. Thank you for sharing your knowledge and experiences today together, more than ever, for a life without CML. Our session is recorded, and you will find more information in our website. Please visit www.worldcmlday.org. You can post any question, and of course, our team will answer. Thanks again for joining us, and much love and happy World CML Day. Thank you very much.
Thank you, Bahija. Thank you. Thank you, everybody, for attending. I just want to tell you that, like the videos that Loretta mentioned that were pre-recorded by Lydia and our colleague Justin over the past couple of weeks, I will broadcast those in this Zoom room now. It's a short video. It's around 30 minutes, but if you don't have the time today to see it, you will also be able to see it in the future on our Facebook page. Don't also forget, you know, that the next maybe big get together for us might be also virtual this year, but for CML Horizons. Save the date for CML Horizons, please. It will take place from November 6 until November 8. And it will be free for everybody to attend this year. You will have more details about the event in the coming days and weeks. So we look forward to your participation. Thank you again for your participation today. Thank you, Bahija, for moderating in such an expert and lovely and welcoming fashion. And I wish you all a good day. So I will play the video now. If
For a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, now more than ever, a life without CML. Taa, onye ọbụla, ọkacha mkpa ugbu ndụ enweghị CML.
Today, together, more than ever, for a life without CML.
Taa, onye ọbụla, ọkacha mkpa ugbu ndụ enweghị CML.
Today, together, more than ever, for a life without CML.
Kájùmọ̀ gbé ìgbélé aláyọ̀ láìdí CML.
Today, together, more than ever, for a life without CML.
Welcome to Voice of CML. Shortly, you will hear from some of our members at CML Advocates Network. A few years ago, we started with only a few countries, but since then we have grown. We have 126 patient organizations in over 93 countries around the world. Every year, on the 22nd of September, we come together to raise awareness for the CML community. Unfortunately, 2020 has presented us with many new challenges. However, we continue to adapt. In this six-part live stream, we hope to give all those around the world the opportunity to come together and share their stories using the digital space. Today, many CML patients do not have access to life-saving treatment. Many CML patients do not have access to doctors. Many CML patients do not have up-to-date credible information on the very disease they live with every day. Our hope is to share those stories while also teaching and raising awareness for chronic myeloid leukemia.
How has 2020 affected the CML community? How can we work together for a life without CML? What's next for the CML community? The CML community recently came together to ask some of these questions. The following presentation was completed via online interviews and self-tap submissions from the CML community. We would like to thank those patients, advocates, and physicians who contributed to Voices of CML. Shukran. Merci. Thank you. Today, together, more than ever, for a life without CML.
Okay, because of the pandemic, there was an imposed lockdown and travel restrictions imposed by the government to stem the spread of COVID-19. And so one of the main challenges were people couldn't travel to the GPAP center to go get their drugs, which is how we get drugs in Nigeria. And so what the center did in collaboration with the head of the center was to use logistics services, so courier services, to assist patients to get drugs. Because as you know, the drugs are for life, and you have to take them every day. And so we used courier services to send the drugs to patients in different parts of the country. And that was really well received by patients. It was so helpful. A lot of patients now have adapted to that situation. That's what we're using. So now many more patients also had to ensure that they came online, because we have like a WhatsApp group for everyone who is a caregiver or a patient, a CML patient. And so the use of the courier service, as well as everyone coming online to find out, get information about how are the drugs going to get to me, what are the requirements, and then how do I get the drugs in there. So that's one of the main adaptations we've had, challenges and how we adapted.
Since the pandemic COVID-19 started in Madagascar, we have organized patients follow-ups. Each patient must do the NFIS analysis in or near by laboratories and send the result by mail to the doctors. Then each patient must send one person to collect drugs in the hospitals.
Donc, le défi a été vraiment, ça a été vraiment contredit par l'apparition de la maladie, de la pandémie COVID-19, ce qui fait que nous nous sommes contentés par des sensibilisations et d'autre part par des distributions de masques et de gel alcoolique pour les patients et proches patients, et aussi les sensibiliser comment y faire face à cette maladie. First of all, believe in the existence of the disease and the strict application of the barrier measures ordered by the Ministry of Health. The permanent distribution of masks to patients, the celebration of Doctors' Days, the sharing of cake, and the distribution of masks and alcoholic gel to health workers. Thank you.
2020 has been very challenging because of the corona. In terms of we getting drugs, it is okay because we had an envisaged for drug purposes, Martinez from Mass Foundation, they've done very well. Anticipated that we were going to get drugs. So that one is perfect. For going to the hospital to report for reviews, it's been a bit challenging because the doctors themselves have been very, very busy and not to us. But health-wise, we are perfect. I'm very, very perfect.
Bonjour, c'est un réel plaisir pour moi de participer à ce projet virtuel du CML World Day 2020. Donc, notre défi pour l'année 2020 était essentiellement marqué sur des conférences et des sensibilisations pour pouvoir vraiment amener les patients non seulement à accepter leur maladie et à comprendre exactement ce que c'est la maladie et comment vivre avec cette maladie. Et notre défi majeur, c'est vraiment de pouvoir installer, c'est-à-dire une plateforme de concertation, pour que chacun puisse participer à sa manière dans la lutte contre le leucémie au Niger. This year has not been easy to carry out our activity in the fight against leukemia, given the health crisis facing all countries of the world linked to COVID-19. But nonetheless, we have focused on raising awareness among patients and their close relatives. What do with the COVID?
أهم التحديات اللي واجهناها عام 2020 هي انقطاع العلاج عن المرضى منذ أكثر من سنة، وحاولنا جاهدين توفير العلاج من خلال شبكة CML Advocates بالاتصال مع شركة نوفارتس وبمساعدة السيدة بهيجة كويمي رئيسة جمعية أمل في المغرب، وحصلنا على العلاج من شركة نوفارتس أخيرا الحمد لله تم تأمين العلاج. والتحدي الثاني هو الكوفيد 19 مرض وباء الكورونا اللي يواجه المرضى، وحاولنا نساعد المرضى في الكثير من الأمور والتوجيهات في حماية أنفسهم من هذا الوباء.
Our 2020 challenges have not been unique to Zimbabwe only, but these problems are worldwide. COVID-19 pitched up and Zimbabwe was not spared. We found our group unable to meet. We had all our awareness programs, our fundraising programs, all put on hold. We also were unable to even meet with bereaved ones to help them with their problems. Sad times that we all are facing. The worst problem that we found is many of our members don't live in the city where the medication is available. So they have to travel up, some up to 500 kilometers to get to the city hospital to collect their medication, have their review. And because of lockdown, city-to-city travel was banned. So we really found ourselves with a major problem. We were so grateful for our WhatsApp group. Our WhatsApp group suddenly came alive, and now we were able to meet together on social media. We had our meetings on social media, and we were able to deal with the problems that were presented by our patients, and more importantly, the newly diagnosed patients that desperately needed information. The doctors were able to refer them to our WhatsApp group, and we were able to help them via social media. With the medication, what we did is we tried to reschedule all our patients' appointments to coincide, all the ones that needed to travel, and then we all pooled in to be able to access DHL. Charges in Zimbabwe are really high, so we were able to share those consignments and get our tablets a little bit closer so that the patients didn't have to travel 500 kilometers.
For 2021, what we would like is to create more consciousness of the need to be informed about what's the future for a lot of us that have CML. Let me explain that. Now, because of our peculiar situation, we don't have very good health insurance for CML patients. So we get our drugs where our drugs are donated to us. And so because of that, you have sometimes people just taking that for granted and not consciously being aware that these drugs, that's not all, a few. These drugs are very expensive, and so the need to ensure that you take proper care of your health, use the drugs as prescribed, and also ensure that what are the things you need to do more consciously. For example, we've had people who sometimes some carelessness just don't use the drugs well and then end up having complications. Then we have those that do use the drugs well, and then sometimes it doesn't just work. So, but we've had lots of help from the Max Foundation, who has assisted us to get the different. So we have, because the drugs come in different, we have different levels. So sometimes when people don't do well on this drug, then they are moved to the next level of drugs to use and all. What they've done to help us a lot is to ensure that we have the different levels. So if you don't work with, if just drug doesn't work with you, then you get the next one and all. I want to see that we have more access to drugs. That's one of my greatest challenges. More knowledge for patients so that they take care of their health more, and then more access to drugs. That's really a goal for us. I'm hoping that before the end of this pandemic, or when this pandemic gradually winds down and comes to an end, then we can sort that out. Because in addition to getting the drugs into the country, of course, we have our own peculiar internal structural challenges. And so that for me is that, because if you have access to drugs, of course you'll be well. And then we can actually achieve our global goal, which is for a life without CML. The better you are, the stronger you are, the healthier we are, the better community we are. I think that's for me, that's what we want.
For 2021, our goal for the new patients is that to have access to all of the free treatments. And also, all patients can follow the PCR at the low cost, thanks to the biological laboratory, which begin to be operational in the hospital.
أهم الأهداف الموضوعة لعام 2021 هو تأمين العلاج الكامل ولمدد بعيدة لكافة مرضى CML في العراق. هذا الهدف الأول. والهدف الثاني هو زيادة الوعي الثقافي والطبي لدى جميع المرضى لنصل إلى أبعد مستويات الثقافة التوعوية والتوجيهية لكافة مرضى CML في العراق.
Our goals for 2021 are, because inflation has hit Zimbabwe really hard, we can see that our patients are really struggling to put together funds for even the local blood tests. The ones that were being done every 6 weeks, their budgets have now enabled them to only do it every 3 months. And then our more important PCR testing was now unaffordable. So 2021, we have decided that we're going to try to concentrate more on getting PCR testing available in Zimbabwe. We want to catch up to our European counterparts. So maybe if we work together as CML Africa, we could bring the much needed testing into Africa so that maybe we could reach a stage where we could have trials, African trials, which I don't think have ever happened, and we could qualify. Once our testing is in order, we could qualify for these trials, which will lead us into treatment-free remission. And I think that could be the goal that all African countries would want to reach. Right now, it's not available, and we're going to be on medication for the rest of our lives. But thank goodness Novartis made such a wonderful product, and it's kept us going for many years. But the ideal goal should be treatment-free remission for Africa.
Pour 2021, nous souhaitons vraiment une meilleure santé à tous et que nous pouvons vraiment mener nos activités en pleine année. Comme cette année, nous n'avons pas pu mener nos activités liées à la pandémie. Et nous souhaitons vraiment que l'année 2021 soit une année meilleure, une année de pleine lutte contre la leucémie, une année qui nous permettra de mettre en œuvre tous
nos activités pour pouvoir vraiment atteindre nos objectifs. Et notre objectif principal, c'est vraiment de pouvoir installer un laboratoire génétique au Niger qui va permettre de bien suivre les patients, les diagnostiquer, de bien suivre les patients et aussi s'accentuer sur le dépistage afin de prévenir la maladie dans notre pays, surtout au Niger. Okay, for the year 2021, our challenge is to be able to organize ourselves to set up a genetic laboratory, allowing us to do our examination and follow up on it. And we wish the end of the pandemic in order to carry out our full year's activities.
One of our goals for 2021 is to try and get our medication distributed to most of the regional hospitals countrywide. Maybe not all, but at least if we could introduce one more hospital so that medication is easily accessible and we don't put a strain on our patients to travel so far. We console ourselves by saying it's a small price for us to pay for the benefit that we're getting from the free clinic. But at the end of the day, if we can alleviate the problems for our patients, it would be really great.
Well, globally, I know that we've made tremendous advances. So in more advanced communities and economies, we are talking about TFR, where people are able to go on off treatments for a while, monitored, and they're doing well. Unfortunately, we don't have that here. So I'm hoping that there will be some focus on low-income countries that need assistance to be able to consider trials for TFR, because a lot of us in Africa and other countries do qualify for TFR, but because of our peculiar challenges, it's something that we might not be able to do. So I'm hoping that the global community can kind of look at low-income countries and consider that. But eventually, I do hope we can get to where a cure can be found, because 10 years ago, TFR was never something people considered, or even 15 years ago. But look at it now. So I'm hoping that indeed we'll do get a cure. I'm hoping that we can.
We need a little bit of training on the fundraising side, and this would be a great advantage because Africa have similar problems to each other, whereas Europe is a completely different kettle of fish. So we could learn from our African leaders on their CML groups on how they've done fundraising programs, and then we could implement that. If we have the initial cash just to get us started, because then we could take it from there and grow. We know that it's not just a handout all the time, but just a starting, something to start us off would be great. Test kits, if that could be donated, that would also be great.
Our common goal is to live like normal people and not to be treated like people who has disease.
Donc, pour cette question, par rapport à l'ensemble de tout le monde, à l'endroit de tout le monde du moins, pour vivre sans la leucémie, je pense qu'il faut toujours renforcer nos capacités, rester ensemble et joindre nos efforts pour pouvoir faire face à cette maladie, pour s'échanger des informations, se donner des expériences vécues et voir faire des sensibilisations de masse, du dépistage à temps afin de prévenir la maladie à tous les niveaux et un suivi régulier pour pouvoir atteindre la PCR 0,001 qui est la rémission complète. Et je pense que c'est un défi que nous tous, on peut toutefois atteindre et que, Inch'Allah, Dieu nous aidera pour pouvoir vivre sans cette maladie. Et ce serait mon souhait. Share our experience with the disease, strengthen our capacity, and especially have a regular follow-up in order to reach the PCR 0.01, which is the complete remission.
العمل من أجل دعم قوي و يعني يشجع المرضى السيام على تجاوز الصعاب في مرضهم هو مساعدة الجمعيات كلها في عمل خدمة ممتازة، تقديم خدمة ممتازة مثل ما حصل من أجل توفير علاج التسقنة لمرضى السيامال في العراق في هذه السنة، حيث قامت مجموعة منظمات من ضمنها جمعية أمل في المغرب من خلال السيدة بهيجة كويمي، وسيام آل فلسطين من قبل الأخ جمال حوراني، ومساعدة سيام آل أدفوكيتس. هذا الجمع كله قدرنا نضغط على شركة نوفارتس من أجل توفير علاج التسقنة للعراق. إذن العمل الجماعي يخلق أهداف مساعدة للمريض من أجل توفير علاجه وطمأنينة المريض من هذا الناحية.
So some of the goals can be achieved if we have access to testing. You know, the main issue with CML as a disease is not only to take the drugs, you also have to test so that you kind of monitor and be sure that the drugs are working. And that's what we don't really have. We don't have a lot of access to testing. And so people have to travel within the continent, certain countries, to get access to traveling. And in the pandemic, that's been almost very difficult because it's just now, like in where I am now, we just opened our borders, international borders, over the weekend. So that's mainly the challenge. So in that time, people haven't been able to test because of the pandemic. But if we had those testing facilities within, because we opened our internal borders much earlier, people would have been able to travel to the different cities where the testings are available and do them. But now there is no access to testing because we can't travel across borders, international borders, only just recently. So that's one, access to testing. And then more access to drugs. But for the foundation, Max Foundation, that I've told many, me inclusive, we don't have access to drugs because, as we all know, cancer drugs are very expensive. They are close to unaffordable on a regular basis. And so those are the things, access to drugs and testing. That really is the challenge. Those are the things that we really need most. I just want to say a big thank you to the CML community globally, because people have worked tirelessly, and that is the reason why we have a day to celebrate CML. But for the persistence in the global community, we won't be where we are. So I think we're thankful. We're very thankful for the forum we have now, where a lot of people are becoming aware. And so that really for me is that we're thankful. We are glad that the awareness, CML awareness, has made tremendous advances in the treatment of CML. I think that is what has really helped the community to grow and more people to become healthier because of their tireless work in ensuring that CML is known by people, and then our needs and what we require is taken seriously. That's what I'm really glad about.
I'm talking to our patients here, but when we start the webinar, everything will be in English. So nothing to worry about.
Hello, Professor Anani. You are muted.
Hi, can you hear me?
Yes, we can. Yes.
Everything okay, Giora?
הכל perfect.
אני שמה על English, נכון? ב-translate.
Yes, we go to English.
בסדר. אז אני לא צריכה לקחת פיקוד?
לא, אני מקווה שלא, נראה. עם המסך שלי לא יעשה לי בעיה.
אתה רואה אותי או שאני...
רואה, אני רואה אותי.
טוב, נרגש.
רגע.
היי סיגי.
היא לא שומעת כי אני עם אוזניות. אני יודע, כי אני מדבר עם אשתי, אז אני לא רוצה שכולם ישמעו.
בסדר גמור.
גיורא, אתה יודע שאני ב7:30 צריכה לרדת מהשידור.
אין בעיה, מתי שאת צריכה? מתי שאת צריכה?
אני לא... אולי בהתחלה אתה תגיד אני תעזוב אותנו ואחד וולינר אחר או משהו כזה.
בסדר, כשאני אציג אותך, אני...
בדיוק, פשוט אני לא רוצה לי לחתוך כזה.
אין שום בעיה.
למה פתאום נראה כזה צרה? רגע, ביו. לא? רגע.
and hello to everybody. We have a lot of people here from all around the world. I want to thank all the great speakers that have joined us. For me, it's a dream come true to be with the three speakers, including Dr. Brian Druker, who is always been our hero, and we'll hear it later in the presentation. So I'm really excited and nervous. And before we start the presentation of the great speakers, I would like to thank all of you for joining. And first of all, I want to dedicate this webinar, special webinar, which celebrates 20 years from opening of the IRIS trial, which was the first trial that imatinib or STI or Gleevec, call it whatever you want, was approved for treatment of CML patients. And it's also a personal story for me for 20 years. I want to dedicate it to all the CML warriors that we have lost along the journey in the last 20 years, and especially to two close friends of mine. The first one was a patient of Dr. Brian Druker, and that's Zavi Miller from Canada. He was a very close friend of mine. They used to call him and me the drug smugglers because we used to send drugs all around the world. We collected from patients drugs they didn't need, and we send, if there are few patients in Iran who like Israel, that's because they received some imatinib from us many years ago when it was not available. And he was also the Zero Club establisher, and that's every CML patient who reached zero or close to zero, he gave him a number, and that's really gave a lot of hope for many patients at that time. 20 years ago, it was not clear like today, and I'm really proud to be number 50 on the Zavi's Zero Club. And then the second one is Israeli CML patient. He was a member of our board. He was an accountant. He was in charge of the auditing of our patient organization. And he actually tried all TKIs which were available, and he was either resistant or intolerant to all 5 of them. And he, at the end, went through a bone marrow transplant, which extended his life for 5 more years. And unfortunately, he passed away last year, and we lost him. His name is Menachem Kazanovsky. So they are very good friends of mine, but they only represent a lot of the patients from all around the world. So without further ado, I want to start the webinar and the presentation, and I invite Professor Pia Ra'anani to open this meeting and tell us what was CML like before 2000, what was the story of CML patients before we had the big change started. Professor Pia Ra'anani is the head of the hematology department in Beilinson or Rabin Hospital in Petah Tikva near Tel Aviv. It's a very big center. She's also the leader of the Israeli Hematologist CML Working Group, and she has been the medical advisor of our local CML patient organization from the beginning, almost 19 years ago. So it's always a pleasure having you with us, Professor Ra'anani, and the stage is yours. Thank you.
Thank you, Giora, and thank you very much for giving me this kind opportunity to share this day with you and with these great speakers. So good evening, everybody. During the next 10 minutes, I will take you through the journey of CML during the decades between 1960 and 2000. Alongside this universal journey, I will tell you about my personal own CML journey in the pre-imatinib era. In 1960, Peter Nowell and David Hungerford discovered and described the Philadelphia chromosome. This was a real quantum leap of an abnormal small chromosome 22, which turned out to be the most significant milestone in the journey of CML between 1960 and 2000. Here you can see the two scientists, Nowell and Hungerford, with their publication in the medical journal Science in 1960. In this slide, you can see the major milestones in the unraveling of the biology of CML and its treatment. In 1960, the Philadelphia chromosome, a minute 22 chromosome, was discovered, as I said before, by Nowell and Hungerford. During that period, CML patients were treated with chemotherapy pills like busulfan and hydroxyurea. In 1973, Janet Rowley found that the Philadelphia chromosome is a result of a translocation between chromosomes 9 and 22. That's why we celebrate today the CML Patients' Day. While in the 80s, the molecular basis of the BCR-ABL fusion gene was established, and treatment with interferon and bone marrow transplantation was introduced. During the 90s, the biological meaning of the fusion gene as a causative factor for CML was established, and the first clinical trials with tyrosine kinase inhibitors were initiated, culminating in the Irish phase 3 clinical trial that set the stage for the fast-track approval by the FDA in 2001 of imatinib as first-line treatment for CML. In this slide, you can see the historic development of CML therapy. As you can see, between the 60s and the turn of the century, treatment moved from chemotherapy pills like busulfan and hydroxyurea to bone marrow transplantation and very high doses of interferon alpha. Patients were bedridden either due to the very high doses of interferon or post-bone marrow transplantation. Both were associated with a relatively high rate of mortality and morbidity. To summarize the main differences between CML before and after 2000, I will highlight the following issues. Before 2000, CML was a fatal disease with poor prognosis, while currently it is regarded as indolent with excellent prognosis. While interferon improved median survival from 3 to 6 years to nearly 7 years, nowadays patients with CML have the potential to survive for decades. Imatinib has replaced interferon and allogeneic stem cell transplantation as frontline treatment, and in the past there were very few second-line treatment options available, while now more powerful tyrosine kinase inhibitors can overcome resistance to imatinib. In this slide, you can see data taken from the MD Anderson Cancer Center database. You can see here the survival curves for CML patients over the decades between 1965 and post-2000. One can easily see the improvement in the 5 and 10-year overall survival over the years, rising from less than 3 years median survival in the 60s and 70s to 7 years and more in the 80s and 90s, and nearly normal overall survival of patients beyond 2000 with the growing use of tyrosine kinase inhibitors. In the time left for me, I will share with you my own personal journey with CML. Like the Philadelphia chromosome, I was also born in 1960, but not in Philadelphia, but in Tel Aviv. I went to medical school in the 80s during the years that BCR-ABL chimeric gene was discovered. In 1992, while being a resident in internal medicine, I published my fourth scientific paper entitled Life-Threatening Hypophosphatemia in a Patient with Philadelphia Chromosome-Positive CML in Acute Blastic Crisis. At that time, treatment for CML consisted of interferon and bone marrow transplantation with a median survival of 7 years. I will never forget my CML patients whose quality of life was very low, many of them being bedridden, depressed, interferon and bone marrow transplantation. In those years, CML was considered a very frustrating illness to treat for a young doctor as myself in those days. In 1995, I was sent for a postgraduate course at the Hammersmith Hospital in London. This was a turning point in my career. This course was moderated by Professor John Goldman, who was the guru of CML and the mentor of many future leading figures in the field. After that summer course, I knew that this is what I want to practice in, though in those days, CML was not a very attractive disease for a young physician launching on her medical career. In January 1996, Professor John Goldman and his group came along with many other rising stars in the field of CML to a CML meeting organized in Jerusalem by the late Professor Rachmilewitz. Among them was a young oncologist from Oregon, Dr. Brian Drucker, who presented his early results with STI 571, later called imatinib or Glivec. And here you can see his name and the title of his talk in 1996. During that meeting, Professor Goldman also introduced me to Nick Ross, who became my direct supervisor in the MRD lab at Hammersmith between 1996 and 1997. The clinical rounds in the CML department at Hammersmith during those days were rather depressing, but the good place in the West End in London compensated for this. Here you can see Professor Goldman, Nick Ross, and myself. During the following years, I was treating CML patients with either high doses of interferon or bone marrow transplantation, facing the dilemma whether to offer them the single curative treatment at that time, namely bone marrow transplantation, with a chance of 30% mortality, or continue with high doses of interferon, which could offer them a median survival of 7 years. In 1999, I participated in the 41st ASH annual meeting in New Orleans. I will never forget this cold winter day when we listened to the talk given by lung oncologist Dr. Brian Drucker about the new drug, STI 571. We all had goosebumps when we left the hall. We felt that it was a real revolution in the treatment of CML and an important milestone in the treatment of cancer in general. In 2001, STI 571, later called imatinib, was approved by the FDA for the treatment of CML first line. 2 years later, I joined the CML support group headed by Giora, and since then, our paths have never parted. I would like to conclude on a personal note. I started my career as a resident in internal medicine in 1988. One of my patients, named YZ, was treated with hydroxyurea for CML and developed blastic crisis manifested by hypophosphatemia. This was my 4th medical publication. I was then lucky or unlucky to treat patients with interferon at very high doses with a median survival of 7 years. Quality of life of these patients was very poor. CML patients' fate changed dramatically in 2001 with the introduction of imatinib into clinical practice. During the next decades, CML patients went through a fascinating journey with a changing image of CML from a fatal disease into a potentially curable one. I feel I was lucky to be part of this journey, which is still ongoing, and I'm lucky to share my personal CML journey with you today. So I wish you a very nice and interesting evening. Thank you very much.
Thank you very much, Professor Pia Ra'anani. It really was a nice description what it was like to have CML in the before 2000. And now I'd like to share with you just a short story of myself, CML, and actually my story is reflecting the revolution that happened in the CML in the last 20 years. So I was diagnosed with CML, which was a big shock for me. I was 48 years old in February 2000. It was just after the millennium has changed, and I was sure that the computer has made a mistake. If you remember all the concern we had about computers changing from year 1999 to 2000. But unfortunately, it was not. I went to 3 experts in Israel, top experts. Each one of them gave me a different treatment plan, and I was lost. And I started searching the internet and tried to find my way. What do I want to do? I found a first chat group of CML patients in the beginning of 2000. And then we joined, those who remember at that year, Susan McNamara. She was a CML patient. I think she was also a patient of Dr. Brian Drucker, if I'm not mistaken. And STI was being developed by Novartis, but all the people who are involved in developing this were telling the CEO of Novartis, Dan Vazella, that it's not worth to develop it. There are too many few patients, it's not worth economically, and they should not spend so much money. And there were hesitation whether to develop further this drug or not. And I'm sure that we'll hear much more about this from Professor Brian Druker. And then we wrote a petition to Dan Vazela, the CEO of Novartis. Within few days, we raised 4,000 signatures. The petition came to his table. There were also many people who came to him and asked to continue, and he decided at the end, against all the recommendation, to develop the drug, and that was the big change. You can read all this in the book he wrote later, which is called The Golden Bullet. I was waiting to join the IRIS trial to open, and actually I was in touch with Professor Brian Druker. I already made all my plans to go to Portland, to Oregon. I spoke with a local rabbi. I organized school for my 4 children to make sure they can go, and I was planning to go there for about a year. Unfortunately, the trial did not open in Portland, Oregon, and I ended up through the internet finding the IRIS trial opening in Germany, and I was lucky to join a trial with another great doctor, Professor Hochhaus from Germany, who is still my doctor until these days. I was randomized to the interferon and RSC, always asking myself, why do I have to fly to Germany to get interferon when I can get it in Israel free? But after 7 months, I was switched to the STI 571 on 14th of February 2001, and that actually became my second birthday. Imatinib or STI worked on me amazingly. I became PCR negative within 9 months, and I kept the deep molecular response for 13 years. And in June 2014, with the pressure of my doctor, I stopped imatinib to see if I'm cured. And now I'm more than 6 years on TFR with my deep molecular response MR5 kept in all months in all the PCRs that I'm doing every few months. And because of all the hesitation I had and all the lack of information, I decided to use my experience and help other CML patients, both in Israel and also globally. So the skies, of course, of CML have changed from very cloudy to blue. But we all know that they are not completely blue, and there are still clouds in the sky when we talk about CML. There are still challenges for CML patients today. I just list few of them. One of them is a non-adherence of CML patients, which is not clear why a patient should not take a drug which is saving his life. But still, we know that about 30% of patients are not taking the drug as prescribed by his doctor. We know about resistance and relapses that we don't always have the solution to, but it's an issue for some CML patients. A lack of information, for example, pregnancy, how do you treat a young female CML, female patient who wants to become pregnant? It's not always clear, and not all doctors have a consensus about how to do it. In some countries, there are issues about generics and suboptimal treatment. Quality of life is a big issue for CML patients, and we hear it every day. I hear it from my patients, and many of them suffer, some of them more, some of them less, but it's an issue that we have not yet found the solution. And last but not least, access to treatment. Most of us come from Western countries, North America, Europe, and others, and where we have all the TKIs available, or most of the TKIs available, and patients are receiving them and living with the disease. But as part of the leadership of the CML Advocate Network, we are very aware that there are so many countries in the world where there is no access to, sometimes not to any TKI, sometimes only to one TKI with no second line. And CML patients are still dying in too many countries in the world, and that's an issue that we are working on. So what are we doing both nationally and also globally to tackle these challenges? First of all, we are doing research to understand the patient perspective and what the patient thinks. I was lucky enough to lead a team of CML advocates to do two big studies. The first one a couple of years ago about adherence or non-adherence with more than 2,500 patients from 63 countries all around the world. And the last one was last year about TFR, patient who stop, to understand the patient's feeling and perspective, what happens to them when they consider. Both of these studies were published in a scientific magazine. The last one we are very proud about was published in Leukemia only in May this year. We participate in advisory board with companies to improve access. Actually, this happens all the time, and we just had a recent advisory board trying to see how we can help the access in the Philippines, and we have a few other countries on our list, and we work with the companies, and mainly with the help of the Max Foundation and Pat Garcia Gonzalez, the CEO, how we can improve access for patients in these countries. We are today participating in new drug development as members of investigators committees, and we work together closely with the leading CML hematologist groups like the ICMLF or the EICML. Professor Salio, I still remember very well the last meeting I participated in Turin when you hosted the EICML meeting a couple of years ago. We are doing educational empowerment for patients to teach them about the different aspects of CML, and I have just released today a new TFR short video which explains to the patients what TFR is and make it in a very visual, easy to understand concept. And most important, we are keeping the hope of the dreams of the patients. And yes, I myself still have a dream. And my dream is to organize a similar webinar like we have today in 5 years, when we all will be able to discuss the cure for CML patients. So I thank all my Israeli patients and also the global CML advocates community for giving me the strength and energy to continue my dream. Thank you very much. So now I would like to invite my hero. I don't know if you remember, Brian, the letter I wrote to you, I think 18 years ago, when we organized a book for you, and many patients wrote an album with pictures, and each one shared his own story, and we send it to you as a thank you for actually saving our life. So I'm really proud, and I think this is for the first time, to host Professor Brian Druker from Portland, Oregon. He is the director of the OHSU Knight Cancer Institute. And what can I say about him? We have a Facebook group which is called Brian Druker is the Man. And it has hundreds of CML patients in that group. And really, I'm really excited and honored to have you with us and to listen to your story, how you have developed the drugs that saved the life of so many CML patients all across the world. Please, Brian.
Thank you, Giora, for that very kind introduction, and congratulations on your 20 years with CML and 6 years off treatment. It's a great pleasure to be with you today, and I'd like to start by wishing all of you a very happy new year, Shana Tova, and I wish you all the best for another healthy year. My journey in the developing the first targeted therapy for cancer began as a medical student nearly 40 years ago, when I learned about acute leukemia in children. We learned in the 1950s this was a universally fatal leukemia, often within 6 weeks or less. And articles written about this leukemia all started by noting the best that could be done was to try to ease the horrible pain experienced by the children with this leukemia. Over the next 2 decades, this leukemia became routinely curable with combinations of chemotherapy drugs given over 2 years. As remarkable as that was, all I could think about was there had to be a better way. And in my final term paper, I wrote that only through understanding of what drove the growth of cancer could we develop better therapies. And so my journey began. Of course, I still had 3 years of medical school left, then 3 years of residency training, followed by 3 years of training in medical oncology. During my oncology training, I grew tired of giving patients chemotherapy. It rarely worked and was always toxic. So I returned to my long-held desire to do something different and began working in the laboratory of Dr. Thomas Roberts at Harvard's Dana-Farber Cancer Institute to study how cell growth is regulated. I thought there had to be a better way, that we could kill cancer cells without harming normal cells. During the next 7 years that I was working in the laboratory, many strides were made. As you heard from Professor Anani, a few threads in CML had come together. From Peter Knoll and David Hungerford's discovery of the Philadelphia chromosome in patients with CML in 1960, to Janet Rowley's discovery that it was 2 chromosomes, 9 and 22, exchanging segments to produce this abnormal chromosome, to Rick Van Etten and George Daly showing in 1990 that the product of the Philadelphia chromosome, BCR-ABL, caused leukemia in mice. To me, this meant that BCR-ABL caused CML, but most in the field remained skeptical that it was that simple. In the meantime, Alexander Levitsky, working at the Hebrew University of Jerusalem, published an eye-opening paper in 1988 showing it was possible to specifically inhibit the activity of enzymes like BCR-ABL that regulate growth. Prior to that, most people thought that targeting this family of enzymes would simply not be possible. During this time, I had forged a collaboration with Nick Leiden at Novartis, one of the few companies working to develop drugs to inhibit this family of enzymes to which BCR-ABL belongs. Nick had sought my advice as I developed one of the most widely used tools to study the regulation of cell growth by this family of enzymes. And in addition to being a researcher, I was also a doctor, treating patients who might benefit from drugs such as these. Even though at the time I wasn't working on CML, in 1988, I told Nick that CML would be the best cancer to test targeting this family of enzymes. Then in 1990, I took my own advice and began working on CML with the guidance and mentorship of Jim Griffin. I was beginning to make what I thought were significant strides in my CML research. I had published several papers, mostly as a collaborator. I was feeling pretty good about my work. So I met with the man running Dana-Farber to ask for some lab space and a promotion. He sat behind his desk thumbing through my papers. He told me I didn't have enough independently authored papers and I didn't have a future at Dana-Farber Cancer Institute. But I had a backup. I'd been negotiating with the chief of medicine across the street at Beth Israel Hospital. When I went back to close the deal, I was told the job had been given to someone else with more promise. I was devastated. 2 of the most prominent leaders in the field of medicine had told me I wasn't worth the investment. But as I look back, this was a turning point. It was like someone knocked me in the head. I'd gone into cancer research to find a better way to treat cancer. I was tired of giving chemotherapy and had promised my patients I would go into the lab until I found a better way to treat cancer. These events awakened and invigorated my desire to make a difference. It was an opportune time. I believed targeted therapies are the future. Those setbacks gave me focus. I just needed lab space and a fresh start. I accepted a job at Oregon Health and Science University and moved to Portland, Oregon. I had one goal. I wanted to find a drug that worked in my CML disease models and get that drug into the clinic for my patients. I was fortunate to find a wonderful boss in Oregon, Grover Bagby. He said sometimes the best thing you can do for a researcher is to give them an opportunity and leave them alone. And he did just that for me. Within 6 weeks of arriving in Oregon, Nick Leiden sent me some compounds that his group had developed that he thought might inhibit BCR-ABL. I started working with these compounds, one of which killed leukemia cells without harming normal cells. I had exactly what I'd been looking for. This compound would later become the drug Gleevec. But at the time, there were huge hurdles. The drug company didn't think it was worth the investment. They thought the drug wouldn't work or it would be too toxic. And worst of all, they thought it would never make enough money to warrant the investment in its development. nor were they willing to take a chance on an unheard investigator from Oregon. So began a 5-year crusade to get this drug to patients. Fortunately, I had a few scientific advocates. Professor John Goldman was the first to recognize the potential of this drug. You heard Professor Egmilowitz invited me to give a presentation in Jerusalem in 1996, the first international presentation of my data. And shortly after that, Moshe Talpaz joined us. And though I felt abandoned by some people I once respected, there was one group of people who never doubted me, my patients. I'm always amazed at how patients believe in you, even when you're just starting out. Bud Romine was one of those patients who believed in me. Bud was a newly retired railroad engineer. He had been diagnosed with CML, and at age 65, he had few options. He tried interferon, but it didn't work and left him with little energy. He was too old for a transplant. His wife of 42 years, Yvonne, a retired bank clerk, kept a meticulous folder filled with charts of his blood counts. The lines fluctuated dramatically from 15,000 to 150,000. She drew another line at 10,000 for the top of the normal range, something Bud hadn't seen in years. But for Bud, the numbers didn't mean much. He only knew he didn't have any energy. He couldn't play golf, and he often felt too weak just to get out of bed. Bud read a story in the newspaper about our laboratory studies. He contacted me and put his life in my hands. Bud knew the average life expectancy for a patient with CML was about 5 years. And with 4 years on his clock, he knew his time was running out. Bud put his faith in me and trusted that I would be able to help him. That faith bolsters you. It emboldened me to take on the biggest drug company in the world and get this drug to them. We had tested the drug in the lab and were pretty sure it was safe. But until you give it to patients, you don't really know. Bud was incredibly courageous. He stepped forward and wanted to be the first patient to be given this drug. In June 1998, Bud's wish was fulfilled, and he was the very first patient treated on our clinical trial. Within 6 months, every single one of our patients had their blood counts returned to normal. Over the next several years, patients traveled from around the world to enroll in our clinical trials, including 2 from Israel. As you heard from Jora, patients lobbied for faster access to Gleevec in clinical trials, and this helped spur the drug to FDA approval in record time in 2001. For Bud, the numbers, the approval, the data didn't give him the real picture. For Bud, it meant he could play golf, buy a new truck, and spend his winters with his family in California. Now, almost 20 years later, this previously fatal leukemia has a 95% 5-year survival. And we can tell patients diagnosed with this leukemia that the life expectancy is the same as anyone else their age. And for some patients, as you have heard, we have been able to stop treatment safely. But we know that Gleevec isn't perfect. Some people's leukemias become resistant to this drug and their leukemia returns. We learned an enormous amount about what causes resistance, and now have 4 additional drugs targeting BCR-ABL and several more in clinical trials that target the main causes of resistance. Other people struggle with side effects, and we continue to strive to find new ways to manage these side effects and to find more reliable ways to get our patients to a point where treatment can safely be discontinued. Our journey with this leukemia is not over, but the current ability to treat it is so vastly improved that we now consider CML a manageable condition as opposed to a life-threatening illness. I owe the greatest debt to my patients who put their faith in me as we've gone on this journey to find better cancer treatments. I've learned the importance of listening to your patients. Some of the best lessons come from them. Years ago, I said the greatest lesson that they have taught me is the greatest gift in life is hope. But now, 20 years later, I've learned that the greatest gift I've been given is seeing what my patients can do with the gift of life. And I just want to share with you what some of those patients are doing. I'll start with this patient on the upper left, the very first patient, or the longest patient continuous on treatment. She's doing things she's enjoying, like gardening. On the upper right, this patient, the first patient treated from Italy in our clinical trials, doing what he enjoys doing, which is dancing. This remarkable young woman who was diagnosed at age 6, almost 20 years ago. She's now a nurse at our children's hospital, and within a couple of months is expecting her very first child. This very close friend of mine who was diagnosed 15 years ago, when he met with me for the first time, he said, all I want to do is to live long enough to walk my daughter down the aisle. He was able to do that a few years ago, and now is the proud parent of is the proud grandfather of his first grandchild. This remarkable woman, one of the very first patients treated from Australia, who traveled to Portland in the year 2000. She then returned to Australia and was selected to be one of the torchbearers for the Olympic Games for the Sydney Olympics in the year 2000. These stories are your stories, and it all begins to add up to lots and lots of people who are now thriving, surviving, despite a diagnosis of chronic myeloid leukemia. And for me, this is the greatest reward. And for that, I thank you very, very much.
Well, Professor Drucker, what can I say? I hope the camera is not showing the tears on the side of my eyes, because it was a really, really moving story. And I don't know if you know, if I ever told you when we met a few times at ASHES, that actually the idea to start the Israeli CML patient organization came when I supported the CML patient in my city, Netanya, Dorothy. I think you remember her, Dot. She was progressing from a chronic to accelerated phase, and there was no solution. And we supported her to go to you and receive STI 571 on compassionate program or early access program, not in a clinical trial. And really, you have saved her life. And if you remember at the beginning of the trials where you had the first patients taking STI 571, you used to gather all the patients once a month in the clinic and talk to them about this new drug. How is it working? What are the effects? What are the side effects? And you had a patient called Judy Oram that was writing a magazine about each meeting. And when Dorothy came back to Israel after almost a year, she stayed with you. She asked me to start organizing meetings like the meetings you used to organize in your hospital for the Israeli CML patient. And that's how our Israeli CML patient was born, with 7 CML patients in the small hospital in Netanya. And now we have more than 500 CML patients from all over the country. And it's really, the beginning was due to your meeting. So I thank you for that also. So I want now to move to another great friend of mine, Professor Salio, Giuseppe Salio, always easier for me to say Beppe, so excuse me if it's difficult to pronounce Giuseppe. We met many times in many meetings, and you presented in many of our CML Horizons meeting for the CML Advocate Network, and it's always great pleasure having you with us. We heard what was the situation of CML before 2000, and how this has changed dramatically in 2000 with the introduction of STI 571 in imatinib. But I think no one of us could have dreamed at that time that there will be one day that maybe we'll be able even to stop the treatment, because we all thought that this is a life-threatening disease where we will have to take a pill or few pills every day for the rest of our life. But then came the first trials of stopping imatinib stim, and I would like you to tell us about this idea of stopping treatment and how did it come to life, and all the experience and knowledge that you have about the TFR. Remember, we did a video together when I interviewed you about this TFR story just a couple of years ago. So Professor Salio is a professor of internal medicine and hematology at the University of Turin in Italy. He's one of the world's leading CML experts, and as I said, I heard him present in many meetings, and it's always a pleasure having you with us. So the stage is yours, and thank you for joining us very much.
Thank you very much, Jora. And first of all, let me thank you for the invitation to participate in this very important day for CML patients, because this is just to have to speak with persons like Brian. I think that is always an emotion. I would say that I was present in Jerusalem, Brian, when you first presented your data in 1996, as you remembered, in the house of in a hotel near the house of Eliezer Rakhmilevich. And indeed, already at that point, everyone was really impressed about the possibility opened by this new drug at that time, the imatinib. But as I would like to remember now, if imatinib and all the, let's say, the second and third generation TKIs were able to control the disease and give to the patients the possibility of an overall survival similar to that of a control population without leukemia, our goal now is becoming just to achieve a real cure. And we call this status TFR, treatment for remission, which is operational cure according to the definition given by John Goldman some years ago, which means that the patients may live without showing a relapse, a recurrence of the disease, even without taking the TKI. So this is something that after a certain number of years becomes a real cure. As you know, the story started approximately 10 years ago when Francois Xavier Mahon published the first paper concerning this trial, the STEAM trial. And as you can see, what was surprising, that after an initial period, after discontinuation of the therapy, that almost a huge number of patients, huge 60% of the patients indeed showed the recurrence of the disease. Indeed, there was a plateauing of the remaining cases who were able to persist in a deep molecular response without taking the TKI anymore. So this was the first scientific demonstration. There were already anecdotal reports, but this is the first trial really introducing the concept of TFR in the story of CML. And show us that indeed treatment discontinuation is possible. We didn't know how many patients could achieve this goal at the time, which was the denominator, let's say, of the CML patients which were achieving this goal, but at least the concept was established. After that study, many other studies, and this is almost an old slides because it was just 1 year old, more than 50, but so far I think more than 60 or 70 discontinuation studies have been published, involving more than 4,000, probably more than 5,000 nowadays patients, and no more of 3-4 cases of progression have been reported so far. We are lacking precisely this information. We are trying to establish now a precise registry and to compare the number of progression which occur in patients who are discontinuing the therapy with respect to those who are continuing the therapy. Of course, similar categories of patients, patients in deep molecular response. But for the moment, what we know that apparently the treatment discontinuation, TFR, can be considered safe. So it's not dangerous to try to discontinue the therapy. And then a very interesting phenomenon that was explored some years ago by the group of Kim in Korea, as well as more recently, even in Australia, you may see that even after stopping the therapy, some of the patients who are still scoring positive using very sensitive PCR, indeed, they show a progressive decrease in 1, 2, 3, 4 years of the residual leukemic cells. This is based on RNA, so on the expression of the BCR fusion RNA. But the same experiments was more recently repeated by the Australian group, as I told you. They did a DNA, showing that indeed the leukemic cells not only are in some cases expressing, but also their presence is progressively decreasing until a total exhaustion in most of the patients. These are their experiments. So the conclusion that once that we achieve a very deep molecular response and we keep it for a quite long period of time, the progression of the disease or the risk of progression is becoming less and less, almost disappearing with time. And for those patients that after discontinuation relapse, as we will see approximately, previously I showed a slide in which they were 60%, but the correct percentage at the moment, as you will see later also, is approximately 50%. Indeed, if they restarted the therapy, in most of the cases, they achieve again, almost all the cases, they achieve again not only MMR, major molecular remission, the safe haven, but also again deep molecular response. This is a very important concept that, of course, tell us that the worst that can happen for patients who are discontinuing the therapy is to have restarted the therapy that they have discontinued before. There is an interesting category of patients that are those that after stopping the therapy are showing again a reappearance of the BCR-ABL. But if you do not restart immediately the therapy with TKI, indeed this initial increase is becoming a sort of fluctuation without overcoming the threshold of the major molecular response. And so from the clinical point of view, this is not relevant. The patient remain in a major molecular response and doesn't need to restart the therapy. It is allowed to increase the threshold to restart the therapy from the reappearance of the BCR Abelson transcript, so what we call MR4.5 or even lower, to the reappearance, to the loss of MMR. And indeed now the loss of MMR is the standard to restart the therapy. There has been a study, another study of the French group, recently updated at the ASH this year, showing that indeed patients that were discontinuing the therapy and were not losing MMR, in this trial, as you see, were 61%, so a percentage higher with respect to what reported in the STEAM trial after 5 years. You may see that after 3 years, indeed, there are still some relapses. So the French investigators were curious to study better in a deeper way this phenomenon, and this is the long-term follow-up of these patients, in which after a consistent number of years, 45% of the patients are still in a deep and molecular remission. And what they have established, they have distinguished two types of recurrences. One is an immediate, which is occurring within the first 6 months, really, but some cases are also occurring during the first in the second year, or those who are late relapses of the disease between 2 and 6 years after the stop of the therapy. So this category, precise category of patients. And what they have seen is that those patients who are in a stable molecular remission in TFR without losing or really occasional increase of the BCR-ABL, but which cannot be distinguished from lab variation of fluctuation with respect to those who show a fluctuation more pronounced, which are represented in approximately 55%. These patients, this group here, are those who are at risk of losing later on MMR. And there are two messages that we can retrieve from this slide. The first one is those who are remaining for a certain period of time in a stable, deep molecular response, indeed are not losing, and probably, probably they are entering the category of patients in which the disease, if studied with very sensitive methods, is progressively going down. The other category of patients with a more unstable deep molecular response, if you want, they are losing the response, but not in 100% of the cases, as you may see, but in approximately 1/3 of the cases only. And this is important. But what is important is that after a certain number of years, as again, as in the previous slide of the STEAM study, we can consider these patients out of the risk of the disease, of recurrence of the disease. And I would say that from the canonical, let's say, conventional point of view, in hematology, once the disease in the patients is not occurring again after 5 years, we can consider these patients really cured of the disease. And so, obvious question is the question that in part we didn't answer so far, which are the patients in which it's possible to try to stop the TKI therapy. There are recommendations. The most recent one is the one published by the European Leukemia Nest 2010 to 2020 this year. As you may see, there are optimal in which is recommended at least to consider to stop the therapy. Duration of TKI therapy for more than 5 years, more than 3 years if MR4, and more than 2 years if MR4.5. And there are, however, other conditions which are mandatory, and in some other cases you can also consider to try to stop the therapy even if the conditions are not optimal, which is just because you need to stop the therapy for toxic effect, for pregnancy, for other reasons. Among these criteria, therefore, which is the most important, certainly is as you see in the results of this very important study called EuroSCI, for the number of patients who were studied, that were approximately 800. As you may see, it's important to have a quite long treatment with TKI. This is statistically significant. But what is important, is more important, is the duration of the deep molecular response while receiving TKRs. And you may see that here is highly statistically significant, whereas the time of TKI treatment before TMR is not really important. So it's not statistically significant. So what does it mean? It means that we need to reach DMR as soon as possible and to keep it as long as possible. So the message is very simple. How many patients are falling in this category of patients who are reaching deep molecular response in for a quite period of time? And we know that if we are using in really imatinib, these are data from the NEST trial, which has been recently updated, will be published soon again after a 10 years of follow-up. 1/3 of the patient is achieving this goal if treated with imatinib after 5 years. More rapid is the achievement of a deep molecular response if we are using a more potent TKI, like a second generation TKIs. Therefore, if we consider, I would say, a scheme just to explain this phenomenon, we may say that we are using imatinib, which is absolutely let's say, the king, the basic drug, if you want, we are remaining with some amount of residual BCR-ABL, which is due to the persistence of some subclones which are less sensitive to imatinib. If we are using a more potent TKI, like a second generation TKI, indeed we are in part overcoming the resistance of the subclones. Therefore, we are remaining with a lower amount of BCR-ABL. How do we know that the decrease of BCR-ABL is strictly correspondent also to the rapidity of the response? So there are two concepts, two sides of the same coin. If we are the persons who are responding very fast to the therapy, indeed, I heard previously Jora, who said that he was already in deep molecular response after 6 months only after starting with imatinib. Indeed, these are those who are major chances to achieve later on very deep molecular response, and therefore the possibility to try to stop therapy with a high percentage of success. This is the optimal response independently from the type of TKI that we want to use. That is the minimum that we want to have if we want to achieve the possibility to try to stop TKI. BCR-ABL less than 10% after 3 months, BCR-ABL less than 1% after 6 months, MMR within 12 months, and MR4 within 24 months. If we are achieving these goals, it's very likely that you will achieve later on a MR 4.5, and after a certain period of years, you can try to stop the therapy. How many are these patients after 5 years of TKI therapy? This is, I would say, not, I would say, these are a scheme which has a deduction from the NSTD study and published reported by Andreas Ocaus et al. In 2015. If you are using imatinib, as you see, 1/5 of the patients, 21.6% after 5 years. If you are increasing using nilotinib, 300 mg twice a day, or another second generation TKI, we are increasing this percentage of patients. And there are 2 studies that I would like to show to you, which are telling us, however, again, which is the most important goal that we must achieve to try to stop the therapy. One is the nested freedom. These are patients who were indeed treated first line with nilotinib for at least 2 years. They were achieving MR 4.5. They were maintaining MR 4.5 for at least 1 year of additional therapy, and if this was demonstrated with a very stable deep molecular response, they were allowed to stop the therapy, restarting the therapy only after the loss of MMR. And there is another study which is extremely important too. It's called an Nested Stop, in which patients were initially treated with imatinib. They were responding well, but not sufficiently well to try to stop the therapy, which means that they were in between 1% and 0.1% of BCR-ABL. We're not achieving MR4. They were switched then to nilotinib, the second generation TKI, and they, after achieving MR 4.5 on nilotinib, they were indeed entered the consolidation phase of 1 year, continuing nilotinib, and then if this stable molecular response, deep molecular response was achieved, they were allowed to stop the therapy. As you may see, the curves of discontinuation are always the same. So we are always, all the curves that I will show you today are showing that there is a 50% probability of remaining in TFR, approximately, after stopping the TKI therapy, which means that independently from the type of therapy that you have started with. The only difference is not the time of the MR 4.5 to to the beginning of the study, not the duration of the nilotinib treatment prior to TFR, but the total duration of the TKI therapy. So what does it mean? It means that probably what is really important is to achieve a very deep molecular response and to keep it for a certain period of time that, as I told you, can be at least 2 years, but maybe a little bit longer if you want to have more chances to achieve probably TFR. However, of course, to accelerate this process is good, but it exposes also the patients to the risk of a major toxicity. That's why nilotinib, as you know, is associated with a higher increased risk of cardiovascular events, which is not good in particular for elderly patients or for patients who have already the risk of cardiovascular events or developing cardiovascular events. So it's something that should be discussed with your doctor. I think that, however, fortunately, in the future, we will have other possibility. And one of the possibility is just to have a new category of inhibitor that we will see recently in the therapy of CML, which are different from all the other inhibitors, which are inhibiting, as the original imatinib, all the subsequent TKI, are not inhibiting the ATP binding pocket, but in this case, we are inhibiting the methylation site. Methylation site is something which blocks the activity of BCR-ABL. Of course, you can understand that the mutations that can occur can cause resistance to traditional, let's say, TKIs are different from the mutations which can interfere with this other process. And this may say that this is a drug which probably will be very useful to complement the activity of the other TKI. For the moment, it has been tested only as a third-line therapy. Before there were data on the phase 1 study just to establish the dosage. And indeed, it was demonstrated that even at the dosage of 40 milligram twice a day, of 60 milligram twice a day, indeed, it was in patients with a very old story of CML, it was able to demonstrate a very high percentage of even of molecular responses, and even in patients with the 359 mutation. But the most important aspect that these responses were associated with a low degree of toxicity, particularly cardiovascular level. This is something which can be very, very important to be considered in patients. Soon, as I told you, this drug will enter is a new TKI therapy it's not called a TKI, really it's called a STAMP, which means specifically targeting the Abelson methylation pocket. However, this STAMP drug will enter the market because in a trial in which was compared as third-line therapy with bosutinib in patients without the 359 mutation, indeed with the primary endpoint, very ambitious MMR at 24 weeks, indeed it was demonstrated to achieve this primary endpoint, and therefore this will probably be associated with the registration of the drug as third-line therapy. However, we are very curious to see the results of another trial, which is adding asciminib, as I told you, which is an optimal drug from the conceptual point of view to be added to the traditional TKI because they are inhibiting two different sides of the Abelson with imatinib with respect to those patients who are remaining on imatinib or those patients which are switching to nilotinib. This is just to see if in patients starting with imatinib, which is certainly the most likely, I would say the most diffuse drug for CML therapy around the world, and now in the vast majority of the countries is indeed quite cheap because it has become generic, are not achieving the goal of a deep molecular response using this drug. Indeed, imatinib only, indeed, but the addition of Abelson 001 will be able to improve the achievement of the deep molecular response, and therefore to try to allow. Are we ready to introduce TFR in clinical practice? I will finish with these few slides saying that indeed we are already doing this. In Italy, we recently published this paper, which was an observational trial on more than 300 patients who discontinued the therapy. I will go very fast now. All of them were in deep molecular response, one-third in MR4 at least, and two-thirds in more than MR4, MR4.5, MR5, or even lower. And the results are exactly similar, as I told you, to what we have seen in the traditional study. There were no progression, no risk of disease, and some of these patients are continuing in TFR. Those who restarted the therapy achieved again at least MMR, but most of them are again in a very deep molecular response. Again, this is what happened. I don't have time to go deep. Similar data have been recently reported also by the Spanish group, by Hernandez Boluda. As you may see, the percentage here of those patients achieving a successful TFR is even higher with respect to what in Italy. And the most important aspect of the paper published by the Spanish group is that indeed after discontinuation there was an increase in the hemoglobin, an increase in the leukocyte number, the lymphocytes too, the platelets too, the creatinine decrease. So there is an advantage just to stop the therapy in terms certainly of quality of life, and maybe I would like you to discuss this point later on, but also in terms of safety. There is a withdrawal syndrome, but generally this is not so terrible, and it is lasting only for a certain period of time. Thank you very much for your attention.
Thank you very much, Professor Salio. It's always nice to hear you, even though it's not always easy for everyone to understand. I'll try to move along, and we have now some time for question and answer. And I just want to relate to the topic of TFR as we see it in CML Advocate Network. Of course, trying to start treatment is important, and it can be a goal of treatment for every patient when he works with his doctor, when they consult. But when we look at reality, and we saw this reality in the survey, the study we did among CML patients in 68 countries, we saw that because of the lack of monitoring in many countries around the world, and you cannot stop treatment today if you don't have access to a reliable monthly PCR testing. And that's mainly available in countries like Western Europe, North America, Australia, Japan, Korea, but in most of the world, South Africa, in Africa, in South America, in Asia, in most of these countries, patients don't have access to such reliable PCR, so they don't have the ability even to try to stop. So TFR is important, but for us, as I said, cure is much more important, because if we calculate how many patients are stopping today, even in the trials that are running, we see about 25% or 30% of the patient can stop. But that relates only to the patient in the Western countries. If we take the whole CML population, we are talking less than 10% of the CML patient. And that's not enough. As I say, for the CML community patient, we really want to try to achieve cure. And that's why CML Advocate Network is planning to do next month in October a scientific community advisory board with about 8 scientists who are working on different approaches to try to find cure for CML, and together with about 20 patient advocates from all around the world, we'll sit for a few hours, of course, on Zoom this time, and try to explore and see how we, the patient community, can support the investigator to drive forward the approach to find the cure, and hopefully we'll achieve that. And if I already there, and we move now to Q&As, and I apologize on behalf of Professor Pianani, who has another webinar coming at 7:30. She'll have to leave us even if we continue for a few more minutes. So on her behalf, I apologize. So the question is, and to all three of you, CML is one of the diseases we know molecularly best from all the other cancers. It only has one mutation, and that's why it was maybe easier to find the first targeted therapy to treat the disease. What makes it so complicated to eradicate the disease? What makes it so complicated to eradicate the stem cells, the leukemic stem cells that are existing? Why is it so difficult to continue to the direction of a cure? Maybe we start with you, Dr. Drucker.
Yeah, great question. If I knew the answer to that, I would get that into clinic as quickly as we could. The reality is that, you know, if you go back to some of the things I said earlier, it probably has to do with CML isn't perhaps as easy as we think it is. We certainly know the growth of the leukemia cells is driven by BCR-ABL, but perhaps the survival is dependent on other factors that preceded BCR-ABL. So maybe it's not just a one gene abnormality. Maybe there really are other things, or maybe we even have some data from my laboratory that if you shut down the enzymatic activity of BCR-ABL, the stem cells still can survive. So maybe there's more to BCR-ABL than just the enzyme activity. So to me, it's a little bit more complicated. And it's also complicated because trying to isolate these cells from a patient in a deep molecular remission, when it's a very small fraction of their stem cell population, and trying to study them and comparing to the normal stem cells is a really hard scientific problem, but a critically important problem as you described.
Okay, thank you. Anybody wants to add anything, Professor Salio or Professor Anani?
Pia, please. I will after you.
I don't think after what Brian said I have much to add. I just remember again the late Professor Goldman talking about the dormant compartment, that maybe TKIs do not reach it. So might be that still maybe the only real curative treatment would be bone marrow transplantation, but of course we don't want to pay the price. So, and he also, again, I can only quote him, he used to talk about operational cure. So maybe we can live in peace with this small amount of cells with TKIs or without TKIs. But Beppe, I'd like to hear you.
No, I think that you are perfectly right. I think that the eradication is difficult, but certainly not impossible. The only system that we have to eradicate the leukemic stem cells, so let's call like this, is just represented by bone marrow transplantation, thereby allo bone marrow transplantation, and therefore by the possibility of an immunological control of the residual leukemic cells. The problem is that using TKI, what we are doing, we are masking in part we are killing certain progenitors of the leukemic stem cells, but on the same time we are indeed masking the stem cells because we are inhibiting the BCR-ABL. So we are making them very similar to a normal stem cells. And therefore, this is something that probably will require also not only TKI therapy, but something in addition. This is something similar to what Brian was previously saying, that probably we need to discover something which is preceding or facilitating or I would say changing the CMLs themselves in a way to be recognizable by the immunological system again. So the phenomenon of the eradication of the leukemic stem cells is still a big, I would say, something that certainly it needs more exploration, more is a challenge for all of us, because if we understand these concepts, probably we will be able to cure not only CML, but most, at least, all the myeloid leukemias.
Thank you. Thank you all. We have here in the, I don't want to start reading all the applauses and all the thank you that you have, the speakers have received, and especially for you, Dr. Drucker, for the life-saving of so many patients and the participants here. But hopefully I can gather them and send it to you by mail later. We have a parent to a child which was diagnosed with CML, I think a couple of weeks ago. And he's asking if you can say a few words about the treating children with CML. Is there a difference between treating adult or treating a child with CML? Do you want to take the question or?
Okay, I think that of course the disease in children is particularly challenging because we need not only for I would say because we are facing the same difficulties that we are facing in adult patients, but also because with the TKI therapy we are in part interfering also with the growth of these children. So we must be very careful. However, they respond to the same drug. We are using in most cases imatinib, and there are also trials in which we are able to achieve at least a control of the disease after a certain number of years using after TKI therapy, using interferon in combination with TKI, and also in part some successful discontinuation has been achieved. So this is a little bit more challenging because certainly we have to deal also with the problem of the toxicity, which can be more important for children with respect to what we have for adult patients. Therefore, we do not want to use very, very potent TKI with a high degree of toxicities because I think that this could, I would say, in a certain sense, change a little bit the perspective of their developments. So we must be very careful. But there are many trials now ongoing which can answer this question. And the survival of the children patients is good in our days too.
Okay, thank you. Pia, do you want to say anything?
Yeah, I want to say that I think we can take it even to a broader range. I think that when we think about patients, we should think about what is the purpose of the treatment, and treatment should be age adjusted. Just if we look at the opposite side, for example, the purpose for an elderly patient are different than those for middle age or young patients. So I think first of all, we should think what are the aims of the treatment. And for a child, it's, as we mentioned, not to disturb growth, thinking about the future, stopping, the option of stopping. And yes, the child is not just a small old patient. It has its own right.
Okay, thank you. I have a question of mine to you, Brian. Last time I saw you, I think it was a couple of years ago at ASH, I think was it New Orleans, if I'm not mistaken, where you presented the plan of Beat AML and the plan that you are participating, trying to find solutions for the more difficult leukemias, acute myeloid leukemia, and there's really a very big plan trying. Do you think that the progress that you will be making with treatments for AML, will that be also suitable for blast crisis myeloid CML patients?
Yeah, so thank you. I first of all want to make sure that people recognize that I still have a significant lab effort in CML, but as one of my colleagues said to me at a conference, CML was a stupid disease, and I didn't take that personally. He was really trying to say what you said earlier, that it's a much simpler disease. So I have put some lab effort into a much more complicated disease, AML, which is very similar, as you note, to CML blast crisis. And certainly many of the things that we're learning about the treatment of AML could be used to treat blast crisis CML. But fortunately, blast crisis CML is a pretty rare occurrence these days. And Beppe and Pia, I wonder how often you're seeing it in your clinics, but I see it pretty rarely, and that's quite fortunate because it was an extremely difficult leukemia to treat.
Okay. Okay. Thank you. I think the next question may be for you, Professor Salio. It's an Israeli CML patient, 41-year-old. She lives in the US, in Florida. And she said it took her 22 months to achieve 0.099 PCR, which is less than optimal response. It's like basically MMR after almost 2 years. And she was asking, would you recommend to try TFR if in the future she is able to maintain deep molecular response for at least 3 years, even though the speed of the decline of the PCR was slower, not optimal?
I think that certainly, but I would say if she maintains a very good deep molecular response for at least 2, maybe better 3 years, I think that it's possible to try to stop the therapy in this specific case. Of course, there are always patients who are responding very slowly, but this takes more time. But what is more important is the length of the deep molecular response that you achieve. So if then in a few, let's say, 1 or 2 years, we will have the possibility to use of one of the new possibilities that we are developing now to achieve a deeper molecular response, which means maybe a asciminib or another drug, this is another possibility. So I'm sure that most of the patients that at the moment, you are perfectly right when you are saying that we are discussing about Western countries, most of the patients do not have the possibility of monitoring the disease and so on. But I'm sure that even if this represents only a small proportion of the number of the CML patients in the world, however, the experience that we are doing will, at a certain point, allows us to extend the possibility of TFR. I hope in a, let's say, a reasonable future, let's say 10 years, to most of the CML patients. So please resist. Be patient and resist.
Okay. I think we have some questions that were. I would like to do some kind of a case study, a case story, and share with you the speakers. It's really a patient which is very close and dear to my heart. Her name is Michal. I have a daughter named Michal, and she was diagnosed with CML 3 years ago when she was 37 years in a routine blood test. Actually, she took imatinib, and even though it decreased in 3 months from 100% to 10% PCR, 3 months later, it already increased to 30%. So she was switched to dasatinib for 1 year, and the lowest she could have reached with dasatinib was 10%. And but she had a lot of difficult side effects with dasatinib. At that point, her doctor started. She did the bone marrow biopsy and found she has a very, very complex karyotype, which I don't know what it is. She was put on 30 milligrams Iclusig, ponatinib. But after less than a week, she developed pancreatitis, and they decreased the Iclusig to 15 milligrams a day, and they started preparing her for a bone marrow transplant. 1 week before the transplant, she got pneumonia, and after 3 weeks with 15 milligrams, only after 3 weeks with Iclusig, and her last PCR before the transplant went down to 2%. She had a very extensive chemotherapy protocol before the transplant, and then she did the bone marrow transplant. And she's now, I think, 9 months or 10 and a half months from the transplant. Because the PCR was still positive, and after the transplant, they put her back on Iclusig, and she's taking it with terrible side effects, really difficult. Even though she doesn't have difficult GVHD, the Iclusig is giving her a hell of a time, and she described it, my life is hell. I have very strong bone, joints, and muscle pain, and I am on 50 milligrams fentanyl and 24/7, and still in very pain. She cannot eat properly. I'm tired all day, but can't sleep properly. I am alive, but without a decent quality of life. She suggested the doctor to switch the ponatinib to bosutinib, but the doctor told her that he thinks the only drug that will work for her after all the difficulties and challenges he had is ponatinib, so he doesn't recommend to change. She suffers, she's hurting, she's on the edge of being desperate, and what can she do at this point of time? Is there any solution you can think about you would recommend to such a patient? And I know it's not easy to give recommendation over Zoom and over the internet when you don't know the patient and when you don't see them, but let's try to do your best.
But if I can say, is, oh, Brian, please, Brian. We cannot hear you.
You are mute.
I'll chime in after you.
Okay. No, I'm saying that certainly the story is, I would say, a very complicated story because of the transplant, because the resistance to at least 2 different TKIs with sensitivity only Iclusig, which is associated with some toxicity and so on. However, the situation at the moment is from the disease point of view is good because the patients has responded very well to the Iclusig therapy, and therefore for the moment I cannot remember exactly which was the response. Can you go down please a little bit?
You want to this question, to the one we asked?
Yes, yeah.
It's right here.
One, yes, sorry, Iclusig at that time is the look, and after transplant, 6 months with Iclusig, and the PCR is 0.07. So I would wait to change the therapy until we achieve at least MR4, which means 0.01 or less, and then we can also try to decrease the dose of Iclusig. Maybe taking Iclusig every other day and so on. I wouldn't change the therapy because the disease is responding very well in cooperation with the graft versus leukemia effect of the transplant. But I would try little by little to monitor very strictly the response and therefore the PCR Abelson, trying to decrease the dosage of the drug as much as possible without observing an increase of the disease. Then to switch for the moment, I think that the doctor is right. It's too early, not the best thing to do. Then we do not know the resistance to bosutinib and so on. So I would continue the same therapy, trying to decrease little by little the amount of the Iclusig dosage.
Okay.
To try to improve the quality of life.
And that's a challenge. Any other comments, Brian?
Yeah. So I would just, first of all, I'm just so sorry that she's suffering so badly from this leukemia and from the treatments. I guess I'd start by looking at whether she's off all immunosuppressants, and if she isn't, it's certainly well past day 100, and it's time to begin to taper those, and that may actually help the immunological control of leukemia. And I also agree with Professor Salia that generally my approach with these leukemias are to try to get the most out of each medication that I can before I switch. So Iclusig is working. I would try to get to the lowest effective dose possible. If that means 15 milligrams every other day, or even doing what is probably not supposed to be done, which is to split the tablets and do 7.5 a day. Again, seeing if that would allow continued control of leukemia. But the reality is if somebody's post-transplant and is in a deep molecular response, it also gives you the ability to look at other options. So if Iclusig isn't tolerable at a low dose, but still has the ability to control, I would be okay trying other medications, because you know you can always go back to Iclusig because it would work. As long as you're well below that 0.1 major molecular, I feel comfortable trying other treatments but I say I do prefer to get the most out of each medication before I switch, because then I'm not switching back and forth, going from one medicine to another medicine, and then not knowing whether that's going to be the best approach.
Okay, thanks a lot. I think we have quite many questions, but I'll try to at least to put two more. One of them is interesting. It's another young CML patient from Israel who has been on nilotinib, and he changed to the dasatinib for suboptimal response. And after 3 years on the dasatinib, he reached 0.015% PCR. He wanted to see if he can stop. His doctor did not recommend him to do so, and he decided not to listen to his doctor, and he did stop treatment. And strangely, without treatment, he became PCR undetectable, 0. And this holds now for more than a year, the undetectable. So he's asking actually, did you see such cases where the PCR goes down to 0 without treatment and holds for long? And what is your experience with that? Brian, would you like to start?
I think Professor Salyer showed some examples where people who are off therapies, PCRs continue to improve. So congratulations. Good job convincing your doctor to stop treatment. And I hope that there's every reason to believe that at this far off treatment, as Professor Salyer showed, that this should continue.
Yes, absolutely. And I would add that we have also some cases who stopped the therapy because of pregnancy when they were only in MMR. Of course, we were waiting for loss of MMR to start any kind of treatment during pregnancy, like interferon and so on. But indeed, they were in the same situation that which has been described by these patients. So I think that there are still many mysterious things concerning the possibility to overcome the resistance of the residual leukemic cells and to achieve TFR and maybe a complete cure of the disease.
Okay. Before I go to the last question of the pregnancy, we have a patient. I think he's oldest with the most many years in our group. He's almost 29 years CML patient. He was almost 9 years on interferon, and then in 2000, of course, he was switched to imatinib, and he's doing well in regards to response, even though he had to go up to 600 milligram imatinib. So he's taking a higher dose of imatinib than the regular 400 milligram, but it's keeping his response in an acceptable level. But his creatinine has started to climb, and it has reached now 1.65, and he's worried. Would you recommend to change imatinib after so many years? And if you change, to what treatment would you recommend to change?
Please, Brian, to you, up to you.
I would do ABL sequencing, see whether there's a mutation, and that would help guide my decision. But with the numbers going up, it sounds like it's time to make some changes.
No, not the numbers. The PCR is not going up. The creatinine, the sugar, the creatinine level is going up. And it reached 1.65. 1.65.
Yeah, and so what's the PCR doing?
It's normal. I think it's around less than MMR.
Yeah, you know, one of the things that again, for people who are in MMR, you have such an incredible luxury of doing things. So, for example, oftentimes in a patient who's is MMR or less, and I'm seeing some side effects, I'll give them what I call a treatment holiday. I'll stop treatment for 4 to 6 weeks, see what their PCR is doing off treatment, see what his creatinine does off treatment. If the PCR goes up and the creatinine goes down, I'd switch to a different drug. If the PCR stays down, I just continue to extend the holiday.
Yes, absolutely.
Okay.
I agree with Brian.
Okay, sounds a good solution to me for him with so many years with CML. And I think we'll move to the last question, and that's about a female. She was 31 years old when she was diagnosed with CML. She was 2 years on Busulib because she joined the clinical trial of Busulib. So she received Busulib for first line, and she reached MMR. After 2 more years, she has reached MR4, and she had 1 son before she was diagnosed with CML, but she desperately wanted another child. So together with the doctor, they tried to stop treatment and see if she can conceive. She lost her MMR after 5 months from stopping, and she had to restart Busulib, and she regained MMR within 2 months, and 3 months later, she regained MR4. So how does she continue now from here? She is 37 years old now and eager for a second child. What are her options?
Personally, what I think that for the moment, MMR the second time is very, very short. So I would continue for at least some other time taking Busulib, just one additional year at least, better 2, but I would say 1 additional year or 2 could be the right solution. Then I wouldn't stop the therapy trying to conceive, but I would try to conceive, to be very careful if there is a pregnancy ongoing immediately after, let's say, 15 days or so, just to be very careful about the timing, because at this time, if there is suspicion, even suspicion that there is a pregnancy ongoing, is better to discontinue the TKI. During the first days of the conception, there is no mixture before the formation of the placenta. There is no mixture between the blood, the maternal and the fetal blood, and therefore the embryo blood in this case. And therefore, I would say this is not the dangerous period. The most dangerous period is that starting after the 3rd or 4th week of gestation. And so in this way, as we have already a proof that she was able to maintain MMR for at least 5 months, we will probably be able to get, I would say, the period sufficient to restart the therapy after delivery, so without the need to restart the therapy. So I think that in this can be, but this needs to be done eventually when there is a longer period of reachievement of the MR4.
Okay.
Yeah, I would completely agree with Professor Salio that, again, first of all, longer time in MMR, MR 4.5. I also completely agree that I wouldn't discontinue therapy while trying to conceive, but I would be extremely careful that the day you think you might have conceived, do a pregnancy test. If it's positive, stop therapy immediately. But the last point I'd make is that, remember, Zavi Zero Club was a complete cytogenetic response. That was a PCR value of 1%. Let's not forget that a PCR value of 1 is still really well-controlled leukemia with a very low risk of relapse. So during pregnancy, I don't feel the need to restart therapy until that PCR gets somewhere above 1. And we know during the 3rd trimester that at least imatinib can be used with some degree of safety during the 3rd trimester. So 5 months to get from off therapy gets you to MMR. That's probably another 2 or 3 months to get a PCR value of 1. So again, I think you might be able to get through pregnancy after a little bit longer in a deep molecular response.
Absolutely, I agree.
Okay, thank you both very, very much. I really want to thank you, each one and one of you again. Professor Salio, for being again with us. Thank you very much for your great presentation and answers. And of course to you, Dr. Brian Druker, thank you very much for joining us. I hope this can become a habit that we'll get to hear you now that I know that traveling is an issue for you with children at home, and you know how much I try to bring you to CML Horizon, but it was always difficult for you to travel, and we understand and appreciate it. But maybe now with the Zoom and the online platform, we can get meet together more often, and you can share your vast knowledge and experience with the CML patient community. So thank you again all. Thank you for everybody who has joined us. It was a pleasure having you, and I hope you enjoyed the webinar. It was really, really exciting for me. So I wish everyone good morning for you, or good evening for the others, or good night for the one from the East. And hope to see you very much. Have a wonderful World CML Day. Thank you very much.
Thank you, Jora, for involving us in this beautiful webinar. Thank you very much.
Thank you.
Thank you all.
Felice.
Ciao, Denise. All is okay.
Yeah, it's a long day, but
Yes, for you especially. Also for us, but
So, hello, welcome to Voices of CML, the virtual event of the CML Advocates Network for Western Europe. You may be aware that we have been traveling around the world today. For those of you who are joining us either here on Zoom or on Facebook or on YouTube or on Twitter, you're very welcome to join this event, which brings us all together today on this very special day, the 22nd of September, World CML Day, a day where we come together as a community to really just share face to face again, you know, what it means for us to be together, especially under the circumstances that there are, because as we know, many of our organizations haven't been able to put on the regular face to face events that we would do as a patient organization. I'm very privileged to be joined here today by my two colleagues from the team, Lydia Pekova and Celia Marin, as well as our co-chair of CML Advocates Network and representative of the Western European region on the steering committee of CML Advocates Network, and a tremendous advocate for CML patients, both in Italy, in Europe, and globally, I would have to say, Felice Bombacci. I'll hand over to you now, Felice. You can take the floor, and it's a pleasure to share this moment with you.
Thank you, Denise. Thank you for your effort. Thank you to Celia and to Lydia to help us to organize this event and to stay up from this morning to this evening, this night, from sunrise to sunset. Thank you so much. Thank you also to Professor Saglio, who joined us and I thank you him from his great available and for attention for patient needs. Just he finished the talk in the Israeli meeting and just changed the computer with us and join us. Thank you so much to other leader of European group like my friend Tony Montesar from Spain. Oh, my name is Felice Bombacci. For who don't know me, I am a CML patient diagnosed on March 2000, and from March 2014, I am in TFR. I am the founder of the Italian CML patient group, and it is a very pleasure for me to welcome you to Western European session of Voice of CML. To celebrate the World CML Day together more than ever for a life without CML. This is the logo, the motto of this year, the slogan of this year. Why the World CML Day 20 years after the discovery of the target therapy that changed the natural history of CML? Because still today, a large part of CML patients do not have access to the CML therapy. Unfortunately, especially in low and middle income countries, people with CML are left to their fate. It's unimaginable how terrible it is for a person to know that there is a therapy that can save them and do not be able to have it. Today, on September 22nd, 126 patient organizations in 19 countries on the whole continent turn the spotlight on the challenge that people with CML face every day. And together, we ask to politicians and public decision makers to make therapy available to all patients, company to do everything is possible so that the price of drug is not a barrier to life. Doctor, to consider CML not a good cancer, not a solved problem, and to commit to improving clinical practice to improve patient quality of life and the researcher to find a definitive cure for this rare and terrible disease. This is the motivation, the goal of why we stay together and raise the voice on CML. I live with CML, but other people die with CML because other people don't give them access to therapy and to right test, monitor test. So, Professor Saglio, my friend, my doctor also, and my light when the black of diagnosis put me in the tunnel of the CML. When other people say to me, you have 3-5 year our average life expectancy. In 2000, the story of CML was this. And now the story was changed by the Magic Bullet and the other TKI. It's possible to with your help, to put in evidence what is the CML in 2020. And after we talk about the future of the CML, the perspective for CML patient. Thank you, Professor Saglio.
Thank you very much, Felice. Indeed, we are getting older together. This is a good news. So I would say that certainly the achievements in CML have been really of paramount importance for CML patients, first of all, but also for medicine in general. Why? Because we have been able to transform a disease that in years in 2000 was considered still fatal, with a few exceptions of patients who could be transplanted, into a disease which is now, let's say, really curable, and not only patients which is dominated by the therapy, but in some cases at least curable. So we have what has changed in this period of time. We have transformed the perspective of survival, the expectation of the overall survival of the CML patients for, as you said, a median time of 3-4 years to a normal expectancy life, almost normal. There are still, however, two little problems. First of all, there is an unlucky, unfortunately, but unfortunately for them, a percentage of patients who are still dying of CML. And these are patients who are progressing very fast, even after diagnosis, who are diagnosed immediately with in blast crisis or in a more advanced phase of the disease. These patients at the moment, in some cases, let's say 40-50% of the cases can be saved, but only with the old method that we had to eradicate the stem cells and the pH-positive clones. That means the allotransplant. So this is what we are still doing. We have no real medication to able to eradicate the disease at this stage. For all the other patients, fortunately enough, we have the possibility to dominate the disease. We have at our disposition not only imatinib, which is, I would say, still the king of the TKI inhibitors, but we have inhibitors which are more potent, even in some cases a little bit more toxic than imatinib. And but organizing I would say the change of the therapy between these drugs, we are able to maintain the patients in a good remission. Unfortunately, most of the patients, if we discontinue the therapy, there is a reappearance of the disease. There is, however, now we know a percentage which is not so the majority, but is a consistent percentage of 15-20% of the patients who are have the possibility to discontinue the therapy without showing a relapse of the disease. This is the famous, everybody knows, the TFR, treatment for remission, that after, if it's lasting for a certain period of years, can be considered a real cure of the disease, at least in my opinion. This is my opinion. So our goal of the therapy at the moment is to expand the number of this option to the vast majority of the CML patients, independently, even if you want to, from the age or from, of course, this can be more important for younger patients, but even for older patients, to get rid of the disease, why not? It will be an extremely important goal. Of course, we must always balance which is the advantage and which is the price that we have to pay for this, to achieve this goal. But I think that observing and studying this phenomenon, we are, I would say, also understanding some of the mechanisms that are allowing us to maybe render the disease or to eradicate the leukemia stem cells, the so-called leukemia stem cells, which are able to reproduce the disease when we discontinue the TKI therapy. And this may be immunological mechanism. Probably we will have monoclonal antibodies able to do this job. Maybe we will use additional drugs. The most, I would say, what we expect to enter the therapy in a rather short period of time, not so experimental anymore, but efficacious from the clinical point of view, is just a new type of TK inhibitor of the BCR-ABL, which is not the classical TKI, which is able to bind the ATP binding pocket, but to bind another site of the same molecule. And this is a drug is called Ashimimab, has demonstrated a good efficacy in very bad conditions. Patients who are resistant to 4 or 5 different TKIs, almost all the TKIs that we have at our disposition. The toxicity for the moment, even the follow-up, of course, is not so long, is very good. And this will be a different class of drugs, that certainly the first class of drugs that probably will enter the therapy of CML, different from the traditional TK inhibitors. Then, of course, there are also many other attempts to, in many other trials, experimental trials, using different drugs affecting other pathways, molecular pathways, which can be activated in CML patients and so on. But I expect that for this, we have to wait some additional year. However, if we, in 20 years, we have transformed a fatal disease in a curable disease, once that we have done the first step, I would say all the rest should be easier. So I would expect that reasonable period of time, or 10 years or so, we will be able to achieve this goal for the vast majority of the CML patients.
Thank you. The prospect is very fine, and we expected your researcher to search this definitive cure for us. In Professor Saglio, another big issue in this period for the patient, the challenge in this COVID-19 period emergence. Many patients say we are immunodepressing people, we are people, the risk is major risk for us, or there are less risk for people who take some kind of drug, or the drug or the disease increase the risk to achieve the infection of COVID-19. What about from COVID-19 and CML in particular?
So far, we do not have data supporting the notion that CML patients can be, I would say, at a higher risk of the COVID infection, because we are collecting this data both at local Italian level and in international level. And the number of CML patients who developed the COVID apparently is not certainly higher with respect to that of a control population. Indeed, there is the suspicion that the TKI therapy, in particular imatinib, but also other TKIs, can also exert a sort of a protection against the COVID-19 infection. We do not know, however, if the lower is apparent, let's say, apparent for the moment, because we are lacking precise data, we are developing apparent less incidence of a COVID infection among CML patients that has been observed, indeed is due to the fact that the CML patients being conscious of being affected of such an important disease and being on therapy for this disease are very, very cautious, and therefore they take all the measures, which is always in any case, or this is due to a real protection of the TKI therapy. We are studying this phenomenon. What we can say for certain, and that there is no additional risk of continuing the TKI therapy for CML patients who are on therapy during this period of COVID infection. And of course, we suggest, as we suggest to all people, to be particularly cautious in taking all the measures which can prevent the infection, because the infection cannot be worse in CML patients with respect to the other patients, but of course is something better, is always better to avoid it at all for CML as well as for the other patients.
So for the patient who here has, pay attention to maintain the control of the to avoid the infection. Wash the hand and maintain the distance between people 1 to 2 meters more than, and work from your house like me, smart working, to avoid the infection. And about vaccination, in the case of people like me, CML patient, over the in addition to winter vaccination, the flu vaccination stage, winter flu, is possible when is available the new vaccine for COVID-19 to make vaccination, or we have risk?
Of course, at the moment, we do not have information about this vaccine or vaccines, because at the moment we do not know which are the side effects, which do not know exactly. But I don't think that there will be a problem just to take this vaccine. As I personally, I suggested to my patients to take the vaccination, the normal vaccination against flu and for all the other diseases. So we do not have at the moment evidence that the CML patients, independently from the TKI that they are taking, are immunodepressed with respect to the control population. So are exactly similar to the control population.
Okay, thank you. It's important for us for precaution to maintain our health. And I asked to my friend Tony if he have something from Spain, and what is your issue, challenge for the patient who live in Spain?
Well, I'm not sure if it's only about Spain or not, but I think maybe it could affect different countries. But my questions to Professor Zayos, from a patient's point of life, be able to try the TFR is obviously a point to, let's say, avoid drugs. Politically incorrect because pharma will lose money, but that's another point. Forget it for today. But how will we be able to achieve a highest level of people trying the TFR when the majority of hematologists, and here, yes, I'm speaking of Spanish, have any interest or even a lack of knowledge? Even ELN guidelines talk about it, but they are not really concerned because at the end, that will mean more work to them, will need more controls, but how can we solve it? If I, as a patient, I told to my hematologist, I want to do the 10-free remission, she will say, wait, you're a patient. No, I'm sorry, I'm a patient advocate, I would like to do that. But the main reaction or the normal reaction of hematologists, and I think it's not happening only in Spain, is, well, I'm the doctor, you are the patient, and patient would like to be involved. Patient would like to decide about our health. How can we do it? How can we put the common point between professionals and patients to improve these ratios?
You are perfectly right, Tony. This is a very important point that you have touched. Of course, I would say to achieve a TFR is something, particularly in patients who are in deep molecular response, doing well without apparently no toxic effect to the therapy that they are taking, so no side effects, good quality of life. It's always something that should be, I would say, it's difficult, it's a work. It takes for both doctors and patients particular attention, more frequent molecular monitoring, so even costly for a certain period of time. And so these are problems which are true. And it's true that doctors are not focused on CML, not have any specific interest in CML. Indeed, they tend to avoid this because they are entering a field in which they do not feel to be very sure. So the patient is in a safe condition, is doing well, is taking the drug, is coming every 3 months. Why do I have to complicate my life and his life to achieve TFR? So an improvement in this, once that the TFR, of course, will be expanded a little bit more than now. And I know that in Spain, for example, there has been a study published by Hernandez Boluda already in 2018, showing the number of patients was approximately 200, an observational study, TFR. So there are doctors which are little by little, of course, trying to attempt a TFR for the patients. So I think that this is something that we should synthesize both to the patients, and this is your job in a certain sense, and our job is just to sensitize the doctor to this aspect. Of course, we need, I would say, being now CML a real chronic disease, which is supposed to last, let's say, at the moment for the rest of your life, you say, which can be a very long life, hopefully. Therefore, we need just probably that these patients are followed by specialized doctors in the field who have a specific interest, like thalassemia, like Mediterranean, like other genetic diseases, which are followed not generically by hematologists, so which are taking care of lymphomas and so on, but more specifically, at least in part, for doctors who are taking care of myeloproliferative diseases. Of course, this can be a limitation for the doctors, but I'm sure that this is the way to do, because as is a disease which can, of course, provide a very good long life on one side, a little bit risk of dying because of the disease still exists, and so on. And we have the possibility, of course, to achieve very good results that with the TFR, it cannot be treated by persons who are not really expert in the CML treatment, because even details, so we are playing the Champions League, we are not playing, I would say, the normal league. So at this point, even a small a detail can represent the difference. And so this should be managed by an expert center, including, of course, a center which has the possibility to have all the molecular facilities and so on, to study the patients in depth, a diagnosis and during the follow-up and during the TFR process.
Can I start with another question? And related to Spain and Italy, more Italy than Spain. Fabio Ficacci is one of the small group of sociologists talking about quality of life in CML, concretely in CML. Even EORTC designed a form for quality of life of CML patients.
Yeah.
A question which, as this last week, I finished my participation on the Beyond clinical trial, okay? The specific form for CML, quality of life, is not used.
No, yes, no.
Is there, any, for me as patient, only as patient, if I know this is a specific form for CML, I'm on a clinical trial for a CML drug, I can realize we are not using this form.
Yes, this is just a comment, but we have not a solution. The choice is in the hand of the investigator when they design the trial and decide what kind of the tools use for their trial.
No, well, sorry, Felicia, part of our work is to make the researchers or the pharma companies use the best tools to take care of our quality of life, which is one of the main issues, which is pending to be solved.
Yes, I agree with you, and we work for achieve this goal, but it's not so simple just to talk. We try in some situation, but it's not simple.
It's always very difficult to deal with the quality of life, because it's highly subjective in some cases, of course. Even in a population without CML, if we are talking about, I would say, quality of life, there are so many factors that can influence quality of life outside the CML and outside the therapy, which can play, of course, a major. But we have to try. We have certainly to improve also the perception. And this can only be done, in my opinion, by talking, by a lot of time between patients and doctors and so on, but a very good relationship between patients and doctors. What I would like to say is that, however, as the CML patients, I do not know how many are in Italy at the moment. How many, do you have a number? I've calculated that certainly there are more than 10,000 CML patients. So it's a small town of CML patients living, of course, spread in Italy in every place. But with the social network that we have created, that we are using in our day, it's possible just to have a common, I would say, a good influence on how to manage the disease. So as a specialist, I must say that I spent most of my life, scientific life, that gave me a lot of satisfaction too, and so on, dealing with the CML, of course. And therefore, so I am, let's say, really, I do not know, linked to this disease for personal reasons. But of course, even more for CML patients, it's important to deal with CML and to have a current treatment for CML, because they have a personal interest. And you must be aware of your enormous potential that you have, and just in a way that is developing little by little and growing, I know, just to have the possibility to make this advocacy advocates society more powerful, more organized, more influential. on both doctors, health systems, and so on.
Thank you very much,
you.
Professor.
And I would like to invite, sorry, Tony, but I would like to invite the other people to attend this meeting, like Connie or Johnny, Jerry, if they or other people to have some question for Professor Saglio. Professor Saglio is a professor of hematology in University of Turin, and is one of the best of the great hematology expert on CML. He dedicates his life, professional life, to find something, the solution for CML. And if we have some question, please, we have 2 minutes to end. Barbara? No? No other question? Okay. So the time expired, and I thank you, the people behind the Scena, who help us to organize this meeting. Also, I thank so much for his availability and for his close with us, with patient attention for Professor Saglio. And also my friend from around Europe, the Western Europe, to join this meeting, and Denise, Celia, and Lydia for their great effort. This day, they dedicate from this morning to this night, continuous to follow the sun and help us, patient representative of the region, European, Asia, Pacific, Asia, America, and so, all continent, they help us to run this initiative, because it's important also today to understand that the CML is not a good cancer, it's a cancer, and we need to turn on the light on this disease to find a definitive solution, a definitive cure, and to have access for all people. This is what we ask. Have access to treatment. It's not possible in 2020 to die because you have not access to the treatment. Thank you to all. Have a nice day and celebrate the CML Day.
Thank you, Felice. And thank you again, Professor Saglio, on behalf of CML Advocates Network. We very much enjoyed your participation and are very, very thankful. Thank you to all of you patient leaders who have attended. I am going to share some pre-recorded messages from the wider Western European CML patient leadership. If you so wish to watch some of that, it's about 30 minutes long, but it will be shared also subsequently on our social media. So please feel free or not. I wish you again a very good evening, and thank you for your participation today.
Thank you very much. Thank you.
Grazie mille.
Prego.
Welcome to Voice of CML. Shortly, you will hear from some of our members at CML Advocates Network. A few years ago, we started with only a few countries, but since then we have grown. We have 126 patient organizations in over 93 countries around the world. Every year, on the 22nd of September, we come together to raise awareness for the CML community. Unfortunately, 2020 has presented us with many new challenges. However, we continue to adapt. In this six-part live stream, we hope to give all those around the world the opportunity to come together and share their stories using the digital space. Today, many CML patients do not have access to life-saving treatment. Many CML patients do not have access to doctors. Many CML patients do not have up-to-date credible information on the very disease they live with every day. Our hope is to share those stories while also teaching and raising awareness for chronic myeloid leukemia. Today, together more than ever, for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Cool. Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
It is CML Day, and today, together more than ever for a life without CML.
Hoy juntos más que nunca por una vida sin LMC.
اليوم معا أكثر من أي يوم مضى لحياة خالية من سرطان الدم المزمن.
Today, together, more than ever, for a life without CML, mabuhay.
Hari ini bersama-sama lebih dari sebelumnya untuk hidup tanpa CML.
Aujourd'hui, tous unis, tous uniques pour une vie sans LMC. Today, together, more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever,
for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for a life without CML.
Today, together more than ever for life without CML.
Today, together more than ever for life without CML.
Today, together more than ever for a life without CML.
Today, together, more than ever, for the life without chronic myeloid leukemia.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
Today, together, more than ever, for a life without CML.
How has 2020 affect the CML community? How can we work together for a life without CML? What's next for the CML community? The CML community recently came together to ask some of these questions. The following presentation was completed via online interview and the self-tape submission are from the CML community. We would like to thank those patients, advocates, and the physicians who contribute to Voice of CML. Today, together, more than ever, for a life without CML.
Being a scientist in CML for more than 20 years, and I'm really keen and I'm thinking that we can go further, that at the moment where we stay, so that I'm really keen to support this and to work with you all together in the future, and I'm looking forward what we can find out together worldwide.
With COVID-19, and the patients are very anxious because of COVID-19 and very angry about it. We don't know anything about it. But we had to adapt and get all the information from the whole world so we could help the patients. It was the biggest challenge ever.
Oh, during 2020, the COVID infection, the COVID virus created many challenges around the world, especially in Italy, where many people die and many patients was recovered in the hospital, and a CML patient was very dangerous for them to live normally, because in Italy the pandemic virus epidemic create more and more issue. The hospital was full for ICU unit, was not able to recover patient, and more people stay at home and die. This was a very strange period. Many people lost the work and the job. And in Italy, for CML patient, was a big challenge to reach the hospital, to maintain the follow-up on to reach the access to drug, because it was not simple to move from home to the hospital pharmacy to then was very complicated. Now is better.
Well, since I'm involved both on a local country, running two patient organizations in my country, one is CML, one is all blood cancers, and also I'm a co-founder of the CML Advocate Network and NPN Advocate Network on global level, which are global organizations, and the challenges were actually on both terms and regions. So I think the main challenge was that patients are not able to gather together anymore at this time of the COVID virus, and everything that we had to move into virtual meetings, talks, presentation by doctors, and any activity that we used to do, we had to change and adapt. So that, of course, was a big challenge because we had to do it very quickly within a few days or few weeks, and actually we did it quite well. Other challenges were how patients can get to hospitals because public transportation when we were at lockdown was not operating. And even today, when the public transportation is operating on a limited term, patients who have immune system which is not as good as a healthy person are concerned